Good morning all. I am Dr. Vishal. Stroke. Stroke is a brain attack. It is one of the leading cause of disability worldwide. Most of the people know about heart attack, but awareness about stroke, which is brain attack, is still not that great in community. Stroke is treatable by mechanical thrombectomy, by thrombolysis, which was not there in the past. Now we have all these modalities available. Stroke is also preventable, and its risk factor can be controlled, and recurrence of stroke we can prevent. So with this perspective, I would like to welcome you all for today's interactive CME on acute ischemic stroke update from casualty to rehabilitation.
Good morning everyone, I am Dr. Shilpa. Let's start the first session, Casualty Management of a Stroke. I would like to invite chairperson for the session, Dr. S.V. Kulkarni sir, Dr. Pallavi Patekar ma'am, and Dr. Ashwin Bhosle sir. Dr. S.V. Kulkarni sir is a clinician for 42 years. He is a professor emeritus medicine, MGM Medical College, Panvel, and Dean Indian College of Artificial Intelligence, ICAIM. He is the president of Maharashtra Association of Physicians and API Navi Mumbai City Branch. Dr. Pallavi Patekar madam is a practicing internal medicine consultant, diabetologist and intensivist in Apollo Hospital, Navi Mumbai. And she is her clinic in Navi Mumbai. Dr. Ashwin Bhosle sir is a consultant physician, diabetologist and intensivist practicing in Navi Mumbai. He is a visiting consultant at Apollo Hospital. Has his clinic in Navi Mumbai. Now a quick clarification. Stroke management begins in the emergency department, which is the frontline unit for all acute and time-sensitive cases. Stroke is true medical emergency, and evaluation and treatment must start the moment the patient arrives. To begin the scientific program, our first speaker is Dr. Akshay Devdar sir. He is a consultant emergency physician at Apollo Hospital. He will be speaking on the evaluation and management of acute stroke in the emergency room, outlining the critical first step in acute care. Imaging is a... Dr. Balaji. May I invite Dr. Akshay Devdar sir.
So good morning everyone. So thank you for the intro, Shilpa. I was going to kill you when you started with casualty, but you resuscitated yourself by calling it emergency. So any difference between the two, casualty or emergency? Physically it's the same spot in the hospital. Yes. So I mean, any difference? Anyone feels there is a difference in casualty or emergency? Casualty is not casual. Emergency should be emergency. Yeah. So we are talking of more specialized care when we talk of emergency. So if I give you an option, say in a casualty you drop in an information, you have a 50-year-old male coming with stroke from 1 hour. And the patient comes and we call up Dr. Vishal, sir, stroke patient aa gaya. And as compared to that, the same information in emergency department gets relayed to him. You have a 50-year-old, he has NIHS of 14, looks like a large vessel occlusion, he's in the imaging. His blood pressure is so much, airway is secured. Which do you prefer, casualty or emergency? So that is the extent that we want to make an impact in all specialities, that your basic management gets already done and you are only talking of core critical decision when you actually initiate. Okay. So till the time the PPT is being loaded, so Dr. Vishal correctly said that it is a leading cause of mortality and morbidity. So the WHO states stroke as the second most cause of mortality in the world. It was briefly knocked off its second place in COVID. COVID managed to secure the second place, but then again we came back on second. Any idea how much percentage of patients die in the world because of stroke? Rough guess? Rough guess? Not so much, ma'am. It's 11%. 11% of, obviously in India we have limited data. We are not publishing. We are busy treating patients. We need to make sure that we present equally well the data. So when we talk of stroke, do we see majority ischemic or hemorrhagic? Yeah. So it's around 70-80%. And hemorrhagic would be 10 to 20? Yeah, roughly I'm saying. Okay. So just touching base on numbers, because we are always obsessed with numbers. Any idea how many neurons are there in the brain? How much? 3 trillion. No, yes? I am not debating on the number and the function. I just want an average. We may disagree on the number and definitely on the function. 86 billion is what I could go through the literature to actually realize that we should be more intelligent. So what happens for every minute I delay stroke management? Some part of neurons are going to die. So the rough average they say is 1.9 million. 1.9 million per minute. Now this is a very fancy number if you want to make people work quick. So in our emergency, if you want to push our residents or the radiologist, we just have to tell them for every minute you delay, you are killing 1.9 million neurons. That looks very big and fantastic number to make things work. So that is where we'll need to rush with things. We ready? PPT? Okay, fine. No, I can continue. Yeah. Okay. So till the time they load it. So when a patient comes to the emergency with stroke, you would obviously want to identify first, is it a stroke or no? The previous thing which all of us had in mind was FAST, F-A-S-T. That's been slightly upgraded to be fast. So keeping you on your toes also. So when we say be fast, it starts with balancing issues, eye problems, facial asymmetry, arm weakness, upper or lower limb, speech disturbances, and T is time. So because it is a time critical illness, you need to identify the exact onset. Many times we will get a different information. When the specialty, the neurologist comes, he will get a different information. You need to establish the exact onset. For example, many times the patient will come to you in your clinic or may ring you up that since 2 hours, he's not moving his right side. If you ask him, you were fine 2 hours back? No, there was some weakness since 4 hours. Then you ask him, okay, you were fine 4 hours back? No, I was having some speaking difficulties since 12 hours. So you need to establish the exact onset. So that is going to help you and guide you in deciding, okay, when and how aggressive should you go through. So this is basically trying to identify. Now, obviously, when we interact with the neurologist in the emergency department, we do not want to waste time in giving a detailed neurological examination. And for that reason, we have something called as NIHSS, that is National Institute of Health Stroke Scale. So that is a predefined score of 42 points where different aspects of the cerebral function are assessed, and it becomes very easy for us to communicate how bad the stroke is, and at the same time, when we intervene, whether it is in terms of thrombolysis or whether it is in terms of mechanical thrombectomy, to assess if the intervention has been helpful or no. Just to give you an example, someone coming with right-sided upper limb weakness, dense, right upper limb and lower limb dense weakness and aphasia would get scored around 11 on NIHS. So the moment I am thrombolizing, and if that 11 becomes 8 or 6, I know my intervention is working. And if that 11 becomes 14 or 16, I know my intervention is not working. And I may suspect there could be a bleed secondary to the thrombolytic agent. So this uniform scaling system helps us in interacting with the neurologist with minimal time and making sure that we don't miss out on any major findings. Okay, so again, as someone who's not an emergency and not a neurologist, you may not worry much about the NIHS. It's a tool purely that we use in hospital to make sure that we know the progress as well as the importance of intervention. Now, when we are thinking of the presentation for lectures which will cover about thrombolysis also, you will have something about, Thank you. Okay, fine. Okay. That's okay. Let it download. It's fine. So, when we are thinking of thrombolysis, people who are aware, there is a cutoff of NIHS 4 and above. If it's 4 and above, you would consider thrombolysis if there's no contraindication. But there's something also called as disabling strokes, where the NIHS may actually not be 4, but it is enough deficit to cause a permanent disability to the candidate, which will prompt you to make sure that you intervene. So I'm just rushing through the slides. So again, 911 is for India? Is 911 for India? Yeah. So do we have a common number yet? 1066 is Apollo. I'm more than happy marketing that here. But we need a unified, maybe at least for stroke. So STEMI, strokes and polytrauma is something which is very time critical. Unless we have a consensus on a common number that they avail the quickest treatment, I don't think we'll be able to take that major step in pre-hospital care. So this is just to constantly remind us we are lacking that. We need to develop it. So one more thing which I forgot to touch base upon. If all symptoms looks very confusing, this is the simplest thing you can remember. Positive symptoms and negative symptoms. So negative symptoms will go more in favor of stroke. Positive symptoms will not. So for example, weakness, loss of motor movement will go more in favor of stroke, negative symptom. Whereas presence of involuntary movement, most of the times will not go in favor of stroke. Numbness, loss of sensation will go in favor of stroke. Tingling, presence of additional sensations will not go in favor of stroke. Loss of vision will go in favor of stroke. Flashes which someone sees may not go in favor of stroke. So again, I'm not going in detail, but few points what we check in NIHS: level of consciousness, whether they are following commands, whether they are doing actions, answering well, best gaze, the visual, what you're checking, whether if there is any hemianopia, you're checking for facial palsy, you're checking for drift in upper and lower limbs, you're checking for limb ataxia, you're checking for sensory deficit, you're checking for best language. So most of the times we find people who are newly getting trained in NIHS get confused between best language and dysarthria. Best language, you're going to give them something to read and ask them to say what they are seeing. Dysarthria is purely interpreting the way they are speaking. And last but not the least, extension and inattention. So like I was saying, disabling deficit. Suppose someone is completely aphasic and there is no weakness. The NIHS would be 3. You would say it is not more than 4. I don't want to thrombolize, but you might have to consider it. So these subtle disabling deficits, there is dense hemiplegia of only one limb. There is complete vision loss. And a very weird presentation could be a locked-in syndrome, where your brainstem is involved. Now, obviously, if I'm promoting emergency, I would want to show off certain skills also. So we always bug Dr. Vishal with this. So it looks like LVO. You have a patient with weakness, and there is either a vision issue, or the patient has aphasia, or there is complete neglect on one side. So this is going to prompt me to alert him early. it looks like a LVO, might need a neuro intervention. I'm keeping you alarmed. Okay? Because every minute we lose, we are killing 1.9 million neurons. Yeah. So obviously this is based on a study. So pre-VAN protocol, patient took around 120 minutes to go to the neuro intervention area, and VAN protocol, they could do it in 60 minutes. Again, it is based on city. I would say at Apollo, we have the luxury of prompting and getting MRI done for all strokes within golden period. When we do all these things, obviously last but not the least things, we need to catch hold of our mimics. Any mimics? Anyone, any mimics of stroke? Hypoglycemia? Yeah? So TODS, good. So keeping things simple, the mnemonic for that is HEMI. The mimic of stroke is HEMI. You have hypoglycemia or hyponatremia. Again, there are a long list. This is just highlighting the common ones. So most of you, which we are very happy nowadays, when we also get patients from outside, other than home, you would always have a point of care testing done. So if it is hypoglycemia, it's corrected. If it's hyponatremia, you already have 3% or normal saline initiated. Second, like somebody correctly said, TODS paralysis. It's a post-ictal phase, but the patient is still presenting with unilateral weakness. The TODS paralysis should be at the back of your head when you're doing workup. Then M for multiple sclerosis and migraine. Obviously, the history will help you differentiate, but you might want to go that extra mile and do a quick imaging. And last but not the least, infections. So the history will be subacute to chronic, but again, in the heat of the moment, we jump the gun and we may not have a complete history with us. So if I have a stroke patient, my first aim would be, is it, I would say, a disabling or not disabling deficit? The next aim would be, is it within window period, within 24 hours? And then I would rush with imaging. And while I'm doing all these things, I would make sure the airway, breathing, circulation, disability and exposure are kept in check. So that's it from my side. Thank you. Questions we'll take at the end.
Good morning, everyone. I'm Dr. Balaji, DRNB Neuro Resident in Apollo Hospital. Now we will go ahead with the next part. That is the most important after initial evaluation in emergency, that is imaging. Without we are handicapped. So imaging is a critical component of acute stroke evaluation, and numerous advanced protocol and software tools are available now to enhance the diagnostic accuracy. After casualty assessment and initial stabilization, the patient is taken promptly for brain imaging. So I would like to invite Dr. Smriti ma'am, Senior Consultant Radiologist at Apollo Hospital, to deliver a talk.
Good morning, everyone. I'm Dr. Smriti. I work at Apollo. And Dr. Akshay, wonderful. Interesting, absolutely great. And now that you have sent the patient to us, so what do we do? So these are the questions. As I'm a radiologist, and these are the questions which I think Dr. Akshay would like me to answer at some point or the other. First question, is it a stroke? Because if the diagnosis changes, the entire flow chart of how the patient is handled changes. Second, if it is a stroke, is it arterial, venous, watershed, territorial? Is it vasculitis related or anything else which has a systemic cause? Third point, what is anatomical location? What is the anatomical location of the infarct? Absolutely important. What is the timing? Very important for emergency people and for us radiologists, because by the time the patient has come to radiology, the clinician is already having a pretty good idea of whether it's infarct or not. That's my experience. The clinician knows. So why exactly is radiology so important here? It is because of this point, infarcted versus at-risk tissue. This is one of the very important points. These are the other reasons: tandem lesions, status of arteries, any other complications, any other etiology. Can we predict any other stroke in future by looking at the current imaging? So CT is the commonest, most easily available modality, radiological modality by which we can image the patient, and it is relatively inexpensive. So let me start with CT scans. These are few of the signs which we get on CT. So basically what we have to remember is that infarct means cytotoxic edema of the cell, means that edema, the cell is now ballooned up with more water. So the area of infarct will appear it will appear more darker on CT. That is the basic funda. So here what we are getting is, can we appreciate it whether that this area which I'm pointing is slightly more darker compared to this area? So this is the obscuration of the lentiform nucleus, a subtle sign. And one thing we have to remember, in CT it may not be very obvious on the image which we get directly from the scanner. So we have to play a bit with the HU values. And because our aim on radiology is to pick the stroke at the earliest. And this we find the same hypodensity, what we call slightly darker area here in the area of insula. So this we call insular ribbon sign. This is just a MCA territory infarct in which this area is more slightly darker than this area. So this is the area of infarct here. Here we can see that the MCA is brighter. This is a dense MCA sign. This tells us that there is an acute thrombus there. So having done CT, we know that in MR, it's very easy for MR. We don't have to adjust the window, nothing at all. We just know that anything which is showing diffusion restriction, we have to consider it as a differential for infarct is as a differential for that. And before finalizing that, yes, this is infarct, we have to rule out the mimics. What are the mimics? And trust me, this list of mimic is in no way infrequent. It's quite common, in fact. Hemorrhage, press, hypoglycemia, seizures, demyelinating diseases, tumors, encephalopathy, all of them can mimic infarct. Few of the images which are from our hospital. This area, this is a diffusion, ADC images, two of our friendly sequences on MRI which helps us find out acute infarct. So this is bright here, this is dark here. This is classical for infarct, no? But no. This is hemorrhage, this is hyperacute to acute hemorrhage. We can find it, this is the gradient image. So not just looking at the diffusion images, we have to look at gradient, we have to look at flare, minimally these four sequences we have to look at before saying that yes, it's an infarct or not. And in spite of looking at these four sequences, our confusion may persist about the mimic, and then we have to take T1, T2, and maybe angio. So this turned out to be hyperacute infarct in which the oxyhemoglobin that mimics the area of diffusion restriction. This, we find out that this small area of diffusion restriction is here. Is it an infarct? No, this turned out to be glioma. And this is well seen on this T2. This turned out to be high-grade glioma. This is, this turned out to be demyelination. We can see this small foci, this white. Same thing is appearing dark here, black here, black here. And this thing was appearing bright on FLAIR images. So we know it is demyelination. This turned out to be hypoglycemia. In this we find that there is symmetrical diffusion restriction. See, this is white here, this is black here. So this is the basal ganglia and also in the cortices. So hypoglycemia. This turned out to be CLOCCs, a patient of dengue. This turned out to be press, in which we can find out that typical parieto-occipital diffusion restriction. Now, one of the easiest ways to rule out the systemic reasons like press hypoglycemia, clinical context. We have to have a clinical context, and plus these sort of systemic causes, they usually end up following some pattern. This was an interesting case. In this, we find that diffusion restriction, avid diffusion restriction is there in the right frontal lobe. This is the flare images where we are getting something bright, what we call hyperintensity. And we initially, provisionally, the technician said it is an infarct. But looking at the patient's clinical conditions and the fact that the patient had these symptoms of nasal sinusitis, we again did a contrast also. In contrast, there was absolutely no enhancement, but we get some sort of meningeal thickening and enhancement here. And this is the ethmoid sinus. This shows sinusitis. So this finally turned out to be encephalitis fungal. So now we know, now we are sure that yes, it is infarct. So that diagnosis is sure. So now what do we do next? So first of all, in radiology, we can give it a test to decide whether if it is a stroke, and by stroke, saying it here on this platform, I mean AIS only. Is it thrombotic? Is it atherosclerotic, embolic, watershed territory? Is it vasculitis? Is it RCVS? What is it? All these points, they help. So, and the second point which we see is whether the infarct is well established or is any salvageable tissue present. So per se, this is a very important point. Any salvageable tissue present. And here we will see in the coming slides as to how the MR and CT helps us. These are the methods by which help us finding out the salvageable tissue. First and the easiest, the quickest is diffusion flare mismatch. As the name suggests, we take diffusion, we take flare, and we see if the mismatch is there or not. So the top three images, if we see, top three images we see, we find there is something, there is ADC hypointensity here, diffusion hyperintensity here, nothing in flare. So this is a mismatch. Now what does it mean? It means that the infarct is still in the window period of less than 4 to 5 hours. The same, another MRI showing diffusion restriction here, we find that flare hyperintensity is here. So the timing of this infarct is definitely more than 4 to 5 hours. We should also remember that this flare diffusion mismatch, it does not depend upon the patient, the age of the patient, the sex, the aspect score, the NIHSS, it is independent of all this. It is just a prognostic factor. And one thing, that in the last image, one second. Supposing in this image, I say it is dark here, it is bright here, and supposing I say there is nothing here, the other radiologist says, no, I find there is something bright here. So this has got a bit of inter-observer variation, as well as it varies from machine to machine and from the magnetic field, the B0, what we say, whether it is 1.5 Tesla or 3 Tesla, 3 Tesla being definitely better. So to address all these issues, now we are moving towards AI. So more and more AI deep learning tools are coming up, which will give this information in an automated and a much, much faster way. Second point, how we can find out the salvageable tissue is the diffusion-perfusion mismatch. As it says, we take diffusion images and we take perfusion images. This perfusion can be in CT, it can be in MR. We give contrast, and then we just trace how the contrast goes. So once we inject the contrast, the machine, it just picks up as the contrast flows further into the arteries, and then we map it out in various color-coded ways. And then the machine, it represents that color-coded maps to us, which helps us. But one thing we have to realize that there are multiple factors, multiple technical limitations also to this. For example, this slide I've taken from the net. This tells us this is the AD. These are different methods, so let us just concentrate on the upper row images. This is the ADC images. We find out that this area is much darker than the rest, which is corresponding to the acute infarct. The same in color-coded images, we find it is very nicely visible. This dark blue area here, this reddish area, this is the core of the infarct. That tissue is already infarcted here, not much can be done. Surrounding this green thing is the penumbra. Now we are not interested in this anymore because what has to be done is already done, cannot do anything. This green thing is the interesting thing to us. Can it be saved? The single important question here. And this can be done on CT and MRI, but most of the places nowadays, what we are doing here is just a semi-quantitative measure. What we are doing it the post-processing, and then we are coming to these color-coded maps. So it does take time. It does take technical awareness and technical knowledge to streamline all this. Now again, AI is coming into this. What we call rapid, as the name is self-explanatory. It is AI-based, it is fully automated, it is totally unsupervised data collection and representation. So data collection of diffusion and of the CT or MRI perfusion images. And I have not yet worked in this, but what the literature says, it takes as little as only 5 to 7 minutes for the color-coded images to come finally to the clinician. And the best part is the integration of this AI software with the current MR system is absolutely seamless. But these are the contrast modalities. We have to inject contrast, which carries its own side effects. Is there any non-contrast way? Yes. This is the ASL, that is arterial spin labeling. We do it in MR. And it gives a gross idea of the penumbra and umbra. But what are so advantages are that we can do it in renal disease, pregnancy, pediatrics. What is the disadvantage? Disadvantage is number one, the resolution is still low. In the contrast modalities, we know that the resolution is pretty good because the resolution is pretty good. In this, the resolution is not as good as the perfusion images. And the second point is that, before coming to the second point, let me explain the first point, that how do we do this without contrast? So what is measured actually? So the arterial blood, the protons in the arterial blood, those are tagged by the MR machine. As that arterial proton flows forward, that is traced, and finally the whole journey of that proton, so to say, is mapped up. So that is how. So if there is delay in between the tagging by the machine and the time by which that proton reaches the site of infarct or the site of umbra/penumbra is more due to any other reason beyond the infarct. For example, the artery, which is proximal artery, has got stenosis or something, then that is a big technical hiccup for us because the time for which the tagging is done is very limited. This is an example of ASL. We can see the infarct here. We can see diffusion. It is hyperacute infarct, absolutely nothing in flare. So this is a flare diffusion mismatch. But the same thing, ASL, it tells us that this area is totally at risk. So we have to address this. These are the main methods, but there are few other methods which can again help us. First of all is diffusion SW mismatch. So what do we do? So the basic funda of this is that in hyperacute infarct, the artery is occluded. And the veins which are downstream to these, the collaterals which are downstream to this, it increases. So the CBF, the flow decreases, but the cerebral volume, it increases because the veins get dilated because of stasis and hypoperfusion. So we are trying to pick that up. I'll give you an example. This, for example, this is acute infarct with changes in flare. Now these two are the SW images which I have taken, but I have thickened them so that the vessels, these collaterals, they are seen better and in a more obvious way. So we find that the infarct area is roughly till here only. It is from here to here. Whereas the collaterals, so infarct was only till here. Slightly anterior to it, the collaterals are still prominent, as prominent as this part. What does that mean? This means that this part where the collaterals are prominent is definitely penumbra. We cannot see it in diffusion in this, but we see it that this is the penumbra part. We have to try our best to salvage it. And one more point for prognostication and to help us with treatment is aspect score. Aspects can be done on a non-contrast CT as well, and it basically helps us in prognostication and helps us in pointing out the direction. But in a non-contrast CT, we have to be pretty clear that aspect score which does not show any abnormality, that means it is a perfect score of 10, that does not exclude AIS. This again I have taken from the net because of the beautiful color combo. So this typically aspect was developed for the MCA stroke, the commonest one, and this is each color area that carries 1 point. So how we do? We take a number 10, and if depending upon each area, if this area is involved, we subtract 1, this area involved, 1 more subtract. So we go on counting like this. So how much, and we go on subtracting it from 10. So how much, what is the number we are left with? For example, in this case, if these 3 points are, these 3 areas are involved, okay? So this thing will be 10 minus 3, 7. 7 is a borderline, above that is still okay prognosis, below that is the prognosis is not as well. This is the anterior circulation, the MCS circulation aspects. We have also come up with the posterior circulation, in which each color-coded area again carries points, with the midbrain and pons carrying 2 because of the obvious reasons, and the rest each carrying 1. So the reason why we are going into radiology, the clinician already knows it's a stroke, AIS, most of the times. So why are we doing? Number 1 is, so this is our final goal, proper patient selection and to to find out the direction in which the treatment should go, and for prognostication of the patient's condition. I think that is it. And with that, I thank you for your time, your patience, and your attention. Thank you.
Thank you, Dr. Akshay and Dr. Smriti ma'am. Any question on this session? We can ask some few questions. A quick comment. For diagnosis of acute stroke in emergency, MRI is not urgent. You can do all thrombolysis based on CT protocol. In fact, in most of the centers, they have perfusion based on CT angio. But in our setup, we have MRI readily available, and in MRI advantages, we can get better information. And to save time, here we have modified the protocol where we don't do all MRI, we do only limited, and we save the time. So that is thing. Second thing, whatever Dr. Akshay said, actually they are doing it. At middle of the night, we get a call that patient is having NIHS and all, and by the time they call us that patient is in MRI and this sequence is going on. So by the time we reach thrombolysis, we have to just start thrombolysis, and sometimes before we reach there, they start the thrombolysis. So we have stroke protocol, there are timelines, and they analyze every month. Suppose there is an outlier, suppose a patient came in ICU ER and thrombolysis is done more than 45 minutes or more than 1 hour. So there is a critical discussion. So why this delay? So we try and reduce the time duration and increase the thrombolysis faster, and so because we have protocol there. Any question we can, otherwise we'll start with the next session. Thank you, chairpersons.
How much time do you take to complete? Suppose the person strikes you at around 10 o'clock in the night. All these studies which you are told, how much time it takes?
Sir, most of the time we do 35 to 40 minutes. Thrombolysis we can start. Stabilization, assessment. MRI takes 12 minutes, not more than that. And sometimes we have to take the consent and all. So most of the time we do thrombolysis onset to door. I think, Akshay, any change? 30 to 40 minutes, that's why.
Who was very agitated, so we required some procedural sedation, so that became an outlier. So we would want to make sure that the airway is also taken care of and the imaging happens accurately. So that went slightly beyond 60, but then he was taken up for mechanical also. So dictum general would be within 30 minutes you are done with imaging and you are ready with the provisional report.
You said about AI-based assessment of the images. So So do you have independent observer or you have got a built-in system only which predicts the things?
Sir, there is a software called as Rapid. It is installed in our mobile. So whenever MRI real time, the one set of images go to the software, and within few minutes, I would say 2-3 minutes, we get a idea that patient, and who are authorized, they can see the penumbra. It gives a calculation that this is a T max time and this is a volume. So based on that, as a thrombolysis, especially in a wake-up stroke and all, we take a call, and for thrombectomy, sometimes they are helpful for me. So there is a Rapid AI, yeah, it is there in Apollo.
Do you have any kind of prognostic studies? Means you have done a imaging for one particular group and that person has worsened later on. So like post-marketing surveillance,
Yes.
can you do a post-procedure analysis of the things which will tell us to pick up the red flag, maybe a false positive or false negative?
So in stroke and window periods, sir, a lot of things are there. Sometimes we open the artery within 3 hours, patient may not recover, and sometimes even 6 hours, patient do good recovery, because there are a lot of things. Like Madam said, collateral circulations. Collaterals play a very good role, and sometimes they may not be visible in other, but patient comes in within window period, we have to do everything. So they decide our long-term prognosis and outcome, whatever treatment we do. But we get idea, most of the idea, based on the whatever imaging we are doing.
I have questions. Can I ask a question?
Yes, sir.
If by chance doing all this thing, it takes 30 minutes, and at the end of 30 minutes you come to know that patient has arrived you late, thrombolysis may not be helpful. So what, you would go other modes of treatment or what? Or you would thrombolyze?
So we are very much particular about the window period, because brain is very sensitive. If we cross it, it will bleed. So 4.5 hours, generally we strictly restrict, and sometimes in very outlier, like a patient wake up stroke and we see classical diffusion flare mismatch, clinical mismatch, then we may consider for thrombolysis. Then if there is major vessel occlusion, then next treatment will be thrombectomy. Even suppose the patient is becomes late out of the window for thrombolysis and thrombectomy also, then it is only medical management in ICU.
So you will not give thrombolysis?
No,
if
sir,
the
because patient will
comes-
bleed, sir.
Okay.
Yeah.
In that case, you will go for the
Yeah,
mechanical.
the recommendation they are coming, they are from the trials, and that's why they recommended 4.5 hours.
Well, this is what you are talking of, the corporate setup. But suppose some private nursing homes, what amount of window period one can extend to get a clinical benefits?
So 4.5 hours is a window period for best outcome, because after that it indicates that already tissue is damaged, and whatever we are doing, it will harm patient more than benefit, especially in thrombolysis. But in other nursing home setup, you don't need all this imaging. Only CT scan is required and only blood sugar. If you have only these two things, you can thrombolyze. Nobody will challenge you. Suppose a patient have low platelet after next day or CKD, nobody will challenge you. Only two investigations are must: CT scan, no bleed, no contraindication clinically, and blood sugar. Other are relative. Nobody will challenge you. Even if thrombolyze, the person is having multiple sclerosis, nobody will say why you thrombolyze, because it is retrospective diagnosis, and most of the time patient is not having stroke and we thrombolyze. Most of the time there is no bleeding because the area is not that big.
Last questions. Most of the time the strokes are because of the hematological clottings and thrombosis. If it is, say, like malignant tumor, like say malignant embolizations, the treatment remains same?
Malignant stroke we call, whenever the penumbra is, the infarct is very large, more than 1/3 edema. Generally, they are not a good candidate for thrombolysis, thrombectomy. And sometimes we see hemorrhage into the DWI, SWI sequences. Then these are the patients we should not thrombolyze.
Thank you.
Okay, we'll start with our next session. Thank you,
Thank you,
Chairperson.
Vishal.
Thank you, sir.
We now move to our next session, IV thrombolysis. Stroke is increasingly treatable, and IV thrombolysis has rapidly moved to the forefront of acute stroke management. With expanding access and growing evidence, its utilization has risen significantly in recent years. I would now like to invite our chairperson for this session, Dr. Suresh Ade sir, Dr. Nikhil Varghese sir, and Dr. Saurabh Kothari sir. Dr. Suresh Ade sir is a consultant physician and diabetologist practicing in Navi, Mumbai. He is a consultant at Apollo Hospital and has his own clinic in Navi, Mumbai. Dr. Nikhil Varghese sir is a consultant physician practicing in Navi, Mumbai. He works as a consultant physician at Terna Hospital and attached to Apollo Hospital as a visiting physician. He also has his clinic in Navi, Mumbai. Dr. Saurabh Kothari sir is a practicing physician, internal medicine in Navi, Mumbai. He is a director and consulting physician, Seawood Hospital, and a visiting consultant at Apollo Hospital. IV thrombolysis has progressed from being an uncommon intervention to become a cornerstone in acute stroke management. With evolving guideline and availability of multiple thrombolytic agents, its role continues to expand. For the next talk on IV thrombolysis, I invite Dr. Aarti Kulkarni ma'am. She will provide insight into the available IV thrombolytic agent and current treatment protocol. Dr. Aarti Kulkarni is a practicing neurologist in Navi, Mumbai and is currently attached as a consultant neurologist to Apollo Hospital and Medicover Hospital and MP City Hospital. She has her neurology clinic in Kharghar. Now that we have revived, you can.
So very good morning to all of you. I thanks Apollo Hospital, Dr. Vishal and Dr. Vishal's team for giving me the opportunity to present today's talk. Today's talk on stroke is my 100th talk so far which I have delivered in my 8 years of career. And I have done this talk in multiple setups, maybe right from the tertiary care centers, nursing homes, and even at the peripheral centers, rural area of Maharashtra. So today's discussion is stroke. And the topic which is specifically has given to me is about IV thrombolysis. So my talk will be limited only to the IV thrombolysis because mechanical thrombectomy would be taken by Dr. Vishal sir. I'll just take 2 quick slides. Why understanding stroke is important. If you are getting heart attack, you go to cardiologist. But if you get a stroke, you never go to a neurologist on time. That is the problem in India so far. Because nobody understands the stroke mortality, morbidity, and the awareness regarding stroke is lagging amongst the common people. If the patient is getting tingling and numbness in the hand, they think it could be just a spondylosis. They sit at home. Next day morning when they develop full-blown paralysis, then they visit neurologists. That too, they don't come directly. They come via some or the other general practitioner or by the physician. So creating awareness about the stroke is extremely important because it is a killer disease. Every 6 seconds stroke is killing somebody. Every other second stroke is attacking a person regardless of age and gender. I have presently admitted one patient who is 22 years old patient who has admitted under me yesterday with the paralysis of 3/5 and his age is just 22. So it can affect any age group. So if you are 35, 40, if you think you will not get a stroke, it is not like that. In India, being Indian is a risk factor for getting stroke. You need to understand this. 17 million people experience stroke each year. 6 million of them, they do not survive. About 33 million people have a stroke and most of them, they develop residual disability. Understanding stroke, why it is important. If you're getting MI, either you will die or you will survive. You will not stay in between. But if you're getting stroke, there are chances you will remain disabled and your entire family would be dependent on you. And if you're staying on the wheelchair or on the bed, then the entire family will gonna suffer. So stroke will give you suffering. If you don't want a suffering, you have to visit a correct hospital on correct time. And the window period for a stroke thrombolysis is only 4.5 hours. So you need to understand that time. The time is extremely important when it comes to the brain. This we have already discussed. Dr. Akshay has already discussed how to identify stroke is by B fast. Any acute onset of balance issues, eye problem, any facial deviation, acute onset of vision loss. Sometimes I have ended up taking this talk with the ophthalmologist also in order to understand the possibility of stroke in the ophthalmic patients, because most of the time they are not diagnosed, or they are diagnosed later, and later on they are coming to the neurologist. Any facial deviation, any arm drift, arm tingling, weakness of the hand, any speech slurring of the speech, dysarthria, or difficulty in speaking, understanding speech, and the time is extremely important and it is crucial. So I'll just quickly rush through this. Modifiable risk factor, all we know. This we have to modify in the Indian setting for the patient, those who are coming. See, now understanding barriers for the stroke treatment. So if you'll ask me, I'm the neurologist who is working in all the setup. I'm working in tertiary care. I'm working in the even in the small setups like a nursing home. I've treated thrombolysis and taken care of the thrombolysis patient in the peripheral area of the Maharashtra, right from the Alibag, Ratnagiri, Mangaon, Mahad. There also I have given instruction on the phone and we have treated thrombolized patient. What is the problem in managing stroke is the barrier to the stroke treatment. First is reaching out. See, you need to understand in Navi, Mumbai, we have stroke ready center is Fortis Hospital, MGM Vashi. Second is MPCT Hospital, Terna, MGM Belapur Hospital, Apollo Hospital, and MGM Kamote Hospital. These are the stroke ready hospital. If you are leaving those and if you are going to some other hospital, like a nursing home hospital, and if the neurologist is not available, imaging is not done on time, so these are the barriers in the treatment. So understanding stroke and reaching to the correct hospital is extremely important. At the same time, you need to have a services available, CT scan or MR. If you are working in the peripheral area, CT will do. If you are working in the very big shot hospital, definitely you will need MRI because most of the patients are highly affluent patients. They have a lot of questions to answer and we have limited time to give it to the stroke patient because we have to do everything fast. So we have to go for a MR. You need to have an experienced thrombolyzer, that is nothing but a neurologist who will guide you. Even on the phone, that is also okay. His presence is not required. So experienced thrombolyzer for thrombolysis is extremely important. And awareness and time. So the time period is only 4.5 hours, that is for IV thrombolysis. Mechanical thrombectomy, we can extend on basis of the large vessel occlusion on the basis of the patient's symptoms. So time is brain. Dr. Akshay has already discussed this. Every minute, if you are wasting 1.9 million neurons, if the neurons are dying, what will happen? The patient will remain paralyzed throughout his life. So he will definitely going to age. If every 1 hour of waiting in the ER, patient will going to age by 3.6 years of his life. You need to understand the statistics. So by doing IV thrombolysis, what we are achieving? See, if I'll be talking about 8 trials, I will not go in detail. Why the trials have come up in the market since 1995. The first trial was done on the acute stroke thrombolysis with the help of Altiplase. That was in 1995. Trial came because of the use of thrombolytic agent. There are only 2 thrombolytic agents which are available and used, and they are government approved for a treatment of the stroke. One is Altiplase and second is tenecteplase. We don't use streptokinase. We don't use retiplase. So only 2 drugs are approved, that is Altiplase and tenecteplase. I'll be discussing about this. How those drugs will be acting. So if you're getting a blue color ischemic core, one is penumbra and one is oligomeric area in the brain. If, for example, the artery is blocked, the entire green part of the brain is affected. Blue is already dead, 100% dead. What we can salvage by giving IV thrombolysis is penumbra and the oligomeric area. So the paralysis would be less, the recovery would be better. We have seen a lot of patients, those who are thrombolized on time, if their ICU time or a hospital time, otherwise without thrombolysis is 7 to 10 days in the hospital. If you're thrombolizing within time, on the day 2, day 3, we are discharging the patients. So understanding this, what is happening at the brain level, it is extremely important. So in stroke management, ER, they take a vital sign, medical history, NIHS assessment. They tell us the NIHS assessment. As Vishal sir said, we need only 2 things, patient's sugar and patient's blood pressure. Patient's blood pressure is more than 185 and 110. That is again a red flag for giving thrombolysis. We have to bring down the blood pressure. Then only we can give thrombolysis. Now, which imaging to do? If you are in the peripheral setup, you are 100% sure about the patient. We are dealing with a stroke patient, you do CT scan. That is enough. CT is done only to rule out bleed. If you have to see that insular ribbon sign, most of the times in the early strokes, we don't get such signs. But if your radiologist is picking up that sign and giving you reports on time, then it is really good thing that it is very difficult to get such things in the peripheral setup. Only in the big hospital this happens on time. Second thing, if you're in the big hospital, the stroke protocol is already set. For example, the lot of big hospitals in Navi, Mumbai, we have a stroke protocol, something called as a MRI stroke protocol, where we do ADC diffusion, we do SWI images, we do flare. So 4 images are done followed by MR angio. That help us to give us the quick idea about what kind of stroke we are dealing, what is the duration, diffusion flare mismatch, and what is the arterial pattern. Because MR angio does not need a contrast. Stroke mimic we have already discussed. So peripheral setup, if you are in Karjat, Khopoli, Alibag, Raigad, Mangaon, Mahad, or if you are in the Ratnagiri, best thing to do is CT, if you are a physician, if you are thrombolizing. So we have done training for a lot of physicians in those areas. If you are in the bigger setup, better to do the MRI. So now in IV thrombolysis, inclusion criteria only 3. You need to understand this. The acute onset of stroke with the onset period within 4.5 hours. Second, patient should have an ischemic stroke. Means CT should not be showing a bleed, MR should not be showing a bleed. Sometimes patient they come, Madam, आपको तो पता है stroke है, आप medicine क्यों नहीं दे रहे हो? Problem with us is, unlike cardiologists, we don't have a small ECG to do. We have to do a big thing. We have to do either CT or MR. Patients don't understand that. So ultimately we end up telling them, oh no, first imaging is required, then only we can give, because we have to rule out whether it's a ischemic stroke or we are dealing with the hemorrhagic stroke. And the age should be more than 18 years. So patient should be an adult patient. This is extremely important slide. You can just take a photo of this. If you are thrombolizing in your setup, ही माझ्या मोबाईल मध्ये पण याचा फोटो ठेवलाय मी, because most of the time I also do cross check. So exclusion criteria, first thing is BP. The BP should not be very high, 185 by 110. Patient's glucose, if it is low, you have to correct it. There should not be any arterial punctures taken. So the contraindication, basically I'm talking, in such cases, you should not go ahead with the thrombolysis. Active internal bleeding, patient is having bleeding diastasis. So sometimes patient will give history that I'm having this problem, I'm already on the blood thinner, I'm already on the anticoagulants. The heparin taken within 48 hours. This happens especially in patients, those who are post-bypass or post-PTCA. They are already received heparin and post-PTCA they get a stroke. So in such kind of cases, we cannot do thrombolysis for the patient if the APTT is elevated. Recurrent use of anticoagulant. Patient is on anticoagulants like INR is more than 1.7 if the patient is on warfarin or acetrom, and the PT is more than 50. There are sometimes nowadays we have started using NOACs, that is rivaroxaban, opixaban, and dabigatran. So that history is also important, whether the patient is on those medications or not. And telling that to the neurologist is extremely important if such kind of patient is coming to you. So that is current use of direct thrombin inhibitors or a direct factor 10A inhibitors. Patient has a history of recurrent head trauma, previous 3 months history of stroke, history of intracranial bleed, patients having symptoms suggestive of subarachnoid hemorrhage, patient is having intracranial neoplasms, AV malformations, aneurysms, recent intracranial or intraspinal surgery, or a malignant stroke. Malignant stroke means a stroke which is larger stroke involving more than 1/3 of the MCA territory, means 1/3 of the one part of the brain. So in such cases, the risk of bleed is more. So which drugs are approved? Alteplase and tenecteplase. There are only 4 slides, each drug each. So I'll be talking about alteplase therapy. So it is available through Boehringer company, and it is coming in the green, and you can see the green color labeling, and it has got 2 vials inside. One is powder formulation, one is liquid formulation. So what you have to do if you are a staff in the ER doctor has to be observant about how the sister is doing mixture of the 2 vials. That is extremely important. So the ER person has to be trained in seeing that, or has to be trained in giving the injection. So the liquid has to be dissolved in the powder with the help of plunger. And second thing, then once the liquid is entering in the powder, slowly with the help of these palms, you have to roll it and gently it will mix. You're not supposed to shake it. If you're shaking it, the viability of the drug goes down. The patient will not improve. Slowly, slowly you have to mix. Once the solution becomes very crystal clear like a water, then only you have to infuse. So what is the dose of alteplase? So the dose which is approved by different guidelines, which I'll be talking about, is 0.9 mg per kg of body weight. So initial 10% we give bolus, rest of the 90% we give over period of 1 hour. But this photo also you can take in the ER, it is extremely important, because in this slide, if you see more than 100 kg weight, so you can see down. So if the patient is more than 100 kg, there is a plateau for giving drug, more doses. You can just give 90 mg of drug. So sometimes you will end up seeing obese patient, 125, 130, 150, you cannot give more than 90 mg of drug to the patient. This is the thing which you need to understand. So 9 mg is bolus. Wo 10% calculation karne tak bhi you get palpitation. So I have kept this chart ready. So you can see the 10% and the infusion, everything is ready. The sister is not confused. You can give it immediately. See how Altiplace came into the market. So when I have taken lectures on the stroke in the periphery, a lot of physicians, those who are doing thrombolysis, MD physicians, they're doing thrombolysis in the peripheral area. They ask, madam, why to give only in 4.5 hours? Why to give only Altiplace? So why the drug has come into the market? There is a worldwide randomized multi-central controlled trials have been done. And after the so many years or maybe decades of the efforts, the drug has got approved. The first study came in 1995, that was ECAS-1 trial. After that, NINS trial, ECAS-2, Atlantis. So this is very important trial which has given a landmark for the use of Altiplace in stroke patients within a window period of 4.5 hours. They compared placebo with Altiplace. Altiplace has given better response. That's why drug has come into the market for a use only within 4.5 hours and with a dose of 0.9 mg per kg of body weight. So when it comes to a AHA, American Heart Association and American Stroke Guidelines, dose approved is 0.9 and the tenecteplase dose approved is 0.25 mg. But there is a technical clinch here which I'll discuss later on. The eligibility, as per what I have told before, we take eligible candidates. Then the next drug got approved and came into the market after 2022. And it has taken it has become very popular within short span of time because it's just a bolus drug. You don't have to give infusion. Sometimes patient come at 4 hours. You have to do your CT, you have to do your MR, and again you have to give that 1 hour infusion of Altiplace, which is not possible. So we end up giving tenecteplase. It is less costlier because the cost is around 25 to 30,000. For Altiplace, cost is around 60 to 70,000. So the affordability is also important for the patient. We think of that. We think about time period. If the patient has come very early within 1 hour, definitely I would go for Altiplace. If the patient has come later, I'll go for tenecteplase. But individualizing therapy as per the patient's complaint is extremely important. How tenecteplase has come into the market? After this, most important ACT trial was the first trial which has given approval for a use of tenecteplase. Second trials, those who came was the TASTE trial, ATTEST-2, and Canadian guidelines and ESO guidelines. So all these guidelines, I will not go in detail. They have shown the certain group of patient we use Altiplace, certain group of patient we use tenecteplase, whether the tenecteplase is superior, whether it is inferior or it is non-inferior. So they have got the data saying that the drug is not inferior to the used in the stroke patient as compared to the Altiplace. So you can use this drug very well looking at the availability of the drug and the affordability. So the drug got approved. TRACE-2 trial says same thing when it is we are comparing with the Altiplace. A lot of Indian trials also came into the market after 2022. So I'll be just going through the Indian trial. These are the Indian open-label multicentric trials. We showed that tenecteplase is also useful within 4.5 hours of the window. And even it is useful in the patient, those who have got a large vessel occlusion also. So this is the Lenvoy trial. This is also Indian trial which came. And that also showed the efficacy of tenecteplase. But a lot of Indian trials, they have put up a dose of 0.2 mg per kg of body weight. So if you are in India, if you are thrombolizing, better to go with the Indian guidelines of 0.2 mg per kg of body weight. And we see the improvement. What we see is NIHS score. We see the Barton score. And there is something called as recovery in form of MRS score. MRS is modified Rankin score. So if all the scores are improving, we know our patient is improving and the disability is less. So Canadian guidelines also came with the approval of the drug and acute ischemic stroke in 2022 and within 4.5 hours of the onset of the stroke. Drug got DCGI approval in 2023, 27th of October. So this is how we treat and we manage our patients. I think the post-thrombolysis bleeding manifestation would be taken by the next doctor. So we'll be discussing that. So in conclusion, definitely you can go for alteplase, tenecteplase. In Indian setup, tenecteplase I generally prefer depending on the affordability of the patient, availability of the drug. It is a bolus dose. It has got a larger half time. It has got a greater fibrin specificity, and it is a greater resistance to the action by PAI. So these are extremely important things what we look for, and we choose the drug accordingly, and we give the medication, and we look for a response and this. So after 24 hours, we repeat the CT scan, we look for a bleed. If there is no bleed, then we continue antiplatelets. Unlike in MI, we load patient with the blood thinners right away, immediately. But in the stroke, we give thrombolysis within 4.5 hours. We don't give any molecule. After 24 hours of thrombolysis, we repeat imaging. Imaging is not showing any bleed. Then we start patient on the blood thinner, and then we manage patient further on the blood thinner. Unlike in MI, how we are managing patient. That is also extremely important. Thank you very much. Any questions?
Madam, blood thinners, which one you use? Ecosprin or anticoagulants?
Sir, if the patient is having small vessel ischemic stroke, ideally it is better to give Ecosprin than Clopidogrel if the stroke size is small, and that we give for 3 weeks followed by single antiplatelet, because 3 weeks of giving dual antiplatelet reduces the risk of recurrence of the stroke. As we know, any stroke patient, they can have a recurrence risk around 20% in first 3 weeks. If you are managing them with dual antiplatelet, the risk is less. But on the contrary, if the stroke size is big, the chances of hemorrhagic transformation is more if you are expecting. It is better to manage initially patient with a single antiplatelet and the high dose statin. Thank you.
Aarti, excellent talk. One question for you.
Sir.
See, when patient is arriving late after 4.5 hours, don't you see the DWI images and flare images? If flare images are clear, and why do, I think we can thrombolyze patient up to 12 hours if the flare images are clear. And
So, sir, basically here we are talking about there's something called as a wake-up stroke, or in certain patients where we get something called as diffusion flare mismatch. For example, if the patient has got stroke at 10 o'clock and if he is coming to you at 6 o'clock, ideally the stroke, most of the time it evolves and it will show changes on the diffusion, ADC and the flare, all three imaging aspects. If the patient is having problem only in the diffusion and the ADC is not showing changes, means here we are dealing with the time frame of between 4.5 hours to 6 hours. So that is the what you call as the gray zone. Gray zone, it is the neurologist's decision whether to thrombolyze or not. We as a neurologist, we are more towards pro-thrombolysis. हम लोग को thrombolysis करना पसंद है. We are really liking that because we don't want our patient to get bedridden. At the same time, we don't want our patient to get a bleed also, because bleeding management, again, it is really difficult for us because it can cost a life of the patient. If patient is within the gray zone, it is very important to take a decision, and to thrombolyze, it is better because the outcome is also better. And we also have an imaging documentary evidence that the flare is not showing any MRI changes or any changes of the infarct which is more than 6 hours. So we have one documentary evidence. So if anything goes wrong also, we have something documented. This is the reason, as a benefit of doubt, we are giving it to the patient. And if you are doing anything for a goodness of the patient, definitely it will give you a good benefit and the patient will improve. So we do thrombolyze such kind of patients. And patient, those who are coming, the protocol is very fixed. If the patient is coming more than 4.5 hours to the ER person has to do MRI only. Don't do CT scan in those kind of patients, because we are not understanding the diffusion flare, what sir said accurately. So MRI, MR angio, and if we have a window of mechanical, we will do mechanical or we will do IV thrombolysis.
Aarti, I got a suggestion for all of you. All your staff should be trained for the protocol, NIHSS. And everybody has got a smartphone, many of you got 2 smartphones. Keep one dedicated for clinical purpose, and there is one app called as a Calculate by QX. I'm repeating it, Calculate by QX. Download it, keep it separate, keep it as your home screen. Because you will save a lot of patients, you can implement a lot of early thrombolysis if you have got those NIHS score on your front screen, and you can assess the patient regularly in the time frame. At the same time, whatever the contraindications which you are told, that can come as a single contact in your phone, that these are my contraindications for stroke. So 1 to 10, depending upon the frequency you can get. And this is something new because NOACs, many people are on NOACs. So if they are on NOACs, is it a strong contraindication for thrombolysis?
So is it like, sir, if the patient has taken the last dose, for example, today morning, and if he's coming to me with the symptoms of the stroke in the afternoon, I would definitely think about not giving thrombolysis to the patient. If the medicine is taken 48 hours prior, patients INR, APTT, generally we don't go for, especially in the patient, those who are on NOACs. APTT would be mildly deranged in such kind of patients. And the problem what with dabigatran, we have something called as a reversal agent, iradenuzumab, which is available. So once I was in the Nanavati, I think Akshay must be knowing, patient was on dabigatran, we had given antithrombol, means reversal agent for a dabigatran. So reversal agent for dabigatran was given, after that we have given the thrombolysis to the patient. But problem is what with rivaroxaban and apixaban, we don't have, sir, any reversal agent. So if the drug is taken within 48 hours, better not to thrombolyze. They are the good candidate for a mechanical thrombectomy. But if it is taken beyond 48 hours, means 2 days prior the drug has been taken, we can safely thrombolizing, but telling the patient the risk of bleeding would be more as compared to the other patients. And giving antiplatelet is not a contraindication for IV thrombolysis. If the patient is on ecosprin, clopidogrel, and he has got a stroke, you can thrombolize that patient safely. There is no contraindication for thrombolizing patient, those who are on dual antiplatelet or single antiplatelet. Thank you very much.
Thanks, Dr. Arti ma'am. Now that we have reviewed IV thrombolytic agent and treatment protocol, let us move to the practical aspect of managing an acute stroke patient. Dr. Balaji Zawar, DNB Neurology Resident, will now present a case of acute ischemic stroke treated with IV thrombolysis.
So, good morning everyone. I am Dr. Balaji, DRNB Neuro Resident in Apollo Hospital. So, I will be discussing our case which has came to ER in a window period, and we have lysed it. As you can see, the age of the patient was 85 years. And before giving the brief in the case, I would like to say the challenges which has faced as a internal medicine resident, as doing my MD from a periphery of Tamil Nadu. So out of 10 of 8 patients which were coming to ER were not affordable for even for the altiplase or tenecteplase. Tenecteplase was not that much used that time. So altiplase, out of 10, only 2 of the patient we would have opportunity to lyse. And we don't have even the facility of MRI, the 3 Tesla MRI and other thing, the deep imaging. So we used to do the CT, and most of the time we will be play as a safe. So it was a big learning for me to work in the Apollo and to know all these things. So we will go ahead with the case. This is a case of 85 years old male, hypertensive, right-handed, presented with the acute onset, right hemiparesis, facial weakness and slurring of speech was also there. At the time of presentation, patient's BP was 150/90, onset of symptoms at around 8 a.m. and presented to ER at 10:15 a.m. That was within window period. So this was the MRI which was done within, hardly we will do like 15 minutes. So this part you can see. So this area you will be seeing. Again I will play. So this area you can see. So this was the MR angio, in which you can see there is a distal segments of MCA, that is M2, M3 segment has been occluded here. So so in brief, there is a 84 years old male, no contraindications for IV thrombolysis, evolving left MCA infarct, occlusion of a distal branches of left MCA, NIHSS was around 12, and onset from symptoms was 2 hours 15 minutes. So the 84 years male, no contraindicated for IV thrombolysis, evolving left MCA infarct, occlusion of the distal branches, NIHS is this, so we went for an IV thrombolysis. So altiplase was given, so dose was calculated. The total dose was 62 was the kg was the weight of the person, 0.9 was the, and we have given in the 2 doses, the total bolus was 10% and remaining 19% over the 1 hour. Close BP monitoring was done and patient was shifted to ICU. So it was the post lysis after 24 hours CT was done. Here you can see barely any changes and there was no bleed, no hemorrhagic conversion. So this is the patient. So he was improved and he was obeying the commands. So this is the this is the DWI sequence where you can see there is barely any change. Post CT was done. So no acute infarct is seen post. So this was the case which we had done. So now the sir will take over and he will be doing a brief talk.
Thanks, Dr. Balaji. As we know, no treatment in neurology is ever truly simple, and the brain.
Okay.
So, Dr. Vishal will.
I will continue with the thrombolysis. See, most of the aspects are taken care by Dr. Aarti. So my talk was actually the white, black and grey. So I think white, black already covered by Dr. Aarti and grey, most of the part is covered. So some questions, whatever some dilemmas we try to address. So I will quickly, some slide I will skip. So as mentioned, before 1996, stroke was not treatable. This was the protocol: admit the patient, just do CT scan, diagnose stroke and admit the patient. Maybe we can start aspirin and all. I think our senior physician know all this thing better. But after 1996, after thrombolysis trial, this is a new dawn in stroke, and stroke became treatable entity. Initially before up to 3 hours, and then after some trials up to 4.5 hours. So these are so many evolving data, trials, and we are getting new recommendations. Golden hour still 4.5 hours. For thrombectomy it is 6 hours, and it is extended up to 24 hours. Dose, everything given, case already discussed by Dr. Balaji. So in this patient, actually, we have reversed the stroke. Another patient, door to needle time was 30 minutes. You can see the evolving stroke in the right MCA. And this was the post-thrombolysis. Actually, you can't see any stroke. There is no change. There was only ischemia. This patient had MCA occlusion. Again, after thrombolysis, he opened up. So timely done, it creates a wonder. So thrombolysis is a very powerful treatment. Age is a limitation, and we are crossing the age barriers. This patient was 85 years old. We have thrombolized 90 years, and 93-year-old also we have thrombolized. And all these patients are doing, they were doing pro-tree life. So after thrombolysis, we could give them functional lifestyle. So indications already given, will not go through that. Contraindication, very important. Uncontrolled blood pressure. Suppose the BP is more than 200 and we have given labetalol and we controlled it and we could control it, we can thrombolize. Suppose BP is again shooting up, so this is a candidate. I think we should be come on back foot for thrombolysis. Recent head trauma, recent MI, recent GI surgery, recent major surgery and GI bleed, they are contraindication. Now, these are the things, but there are sometimes some situations where we come across whether to thrombolize or not. Because sometimes everything will not be in a guideline, and unfortunately, most of the patients come to us, they will be in the gray zone. So let us try to find and address these issues. What happens a person coming with a mild stroke, NIHS only 3, whether to thrombolize or not. So here we have to see whether that stroke is disabling or not. Suppose a person is having left-sided minor weakness and NIH is only 3. I will not thrombolize. But same patient, right-handed, having right-sided weakness and not able to write. This is a disabling weakness for that patient. So changes, right? I will thrombolize, left, I will not thrombolize. So mild stroke, NIHS low, if disabling, we should thrombolize. Non-disabling, we should not thrombolize. Actually, there is a contraindication, grade 3. Mild stroke with large vessel occlusion, expert consensus is there that IV thrombolysis should be done because ultimately these are the patient, ultimately not now, maybe after few hours they are going to deteriorate. So here something we have to consider, non-disabling but major vessel occlusion. Sometime a person come to ER with NIHS, I would say dense hemiplegia. We do MRI, after 10 minutes, 15 minutes we examine, patient gets recovery and you can see patient is lifting. So actually suppose we get functional recovery, so we should not thrombolize. In fact, it becomes one of the contraindication if it is rapidly improving sign. But suppose it has improved, but still he is having disabling weakness, like power was 0 and it became 2. But still it is not good for him, so I would thrombolize such patient. Rapidly improving sign, but still patient is having significant disabling weakness, can be thrombolized. Severe stroke, less than 1.5. Now suppose a person having NIHS 20-25, whether to thrombolize or not. Suppose CT is showing more than 1/3 territory and aspect is definitely more than 7, I will not thrombolize, but patient is having NIHS score only 25, but CT imaging is otherwise perfect. So this is not a contraindication. So clinically severe stroke is not a contraindication for thrombolysis and it can be done in selected patients. Wake up stroke. Most of the time we see patient in early morning, they come to ER at around 7 and all, and the last seen normal is at around 9. So we calculate that time from 9. Patient went to bed 9 and since, so it is almost 6-7 hours from the last seen normal. So here we take sometimes call based on imaging. We do diffusion, flare. If there is a mismatch, sometimes we may consider for thrombolysis, or if there is a major vessel occlusion, this becomes the candidate for thrombectomy. So we have level 2A recommendation in such patients. Treatment, sometimes 4.5 to 9 hours. Again, it becomes doubtful, but sometimes some centers, they are doing no intravenous thrombolysis actually, but sometimes with penumbra, there are trials. Some people are in our setup, we are not doing this. So, seizure at the onset. Most of the time, seizure can be a manifestation of the stroke. So, we have to differentiate Todd's palsy versus seizure. So, MRI helps us by localizing that there is a diffusion restriction. But sometimes stroke itself can be a manifestation of the seizure. Seizure can be a manifestation of stroke. So in these patients, seizure is not an absolute contraindication. We can thrombolize such patient. Only concern was, suppose a patient is having seizure, Todd's palsy, and we are thrombolizing, so we should rule out. But by we have MRI and all, we are most of the time confident that seizure is not that weakness is not Todd's palsy. Stroke mimics. Sometimes it is difficult on CT scan to diagnose multiple sclerosis, demyelination. But suppose you thrombolize them and after 24 hours they turn out to be a demyelination. Nobody will challenge you. And such patients don't have high risk of bleeding because brain is not that big. So stroke mimics 2A we can actually. Higher age, actually up to 80, more than 80 years, the thrombolysis window is around 3 hours. Because in elderly there is high chance of hemorrhage, but higher age is not a contraindication. As I mentioned, we have thrombolized 90 years, 93 years also, and with good outcome. So age is not a limiting factor. We should consider patient's physiological age. 93-year-old, he is doing most of the activities independently. Why not to thrombolize? Pre-existing disability. A person is having an old stroke and now he is recovered and having some disability, maybe other thing. So if it is functional, MRS score is more than 2, we can thrombolize. No relative consent, it becomes difficult. So we can justify it. Nobody will challenge you that relative is not there, we have not thrombolized. In emergency, we can take a call. In fact, in some Western countries, there is a protocol that relative can't deny thrombolysis. It is a hospital responsibility to thrombolize. In Spain and all, they directly take patient and just thrombolize. Only patient has some will that I don't want to thrombolize, then only they will not thrombolize. In India, we don't have such, but if there is no relative, suppose a person come to a hospital in this area, for family is not available, we can take a call. Microbleeds, when we do imaging, so there are some side effects of the imaging also, I would say, we get lot of information. अज्ञानता में सुकून बोलते हैं हम. So sometimes we have some limited information and we can confidently thrombolize. The once you do imaging, we get lot of information, but sometimes it reduces your confidence also. We see lot of micro bleeds and all. They are good signs, but actually they increase the risk of bleeding. So sometimes if there is a more than 10 micro bleeds, we should not thrombolize. It is a relative contraindication, not an absolute. Now coming to the unknown platelet count, we thrombolize and patient is having thrombocytopenia after maybe CBC report will come after 3-4 hours. So not a problem, but we know that patient is having thrombocytopenia because of some malignancy or some anything, liver disease. So we should not thrombolize. Antiplatelet, monotherapy, double antiplatelet, even patient is taking ticagrelor. These are not a contraindication. In fact, most of the patient coming to us for thrombolysis, they are having some other risk factor, cardiological problem. They keep taking antiplatelets. This is not a contraindication. Low molecular weight is a contraindication. Again, it is full therapeutic dose. Suppose a minor dose we can consider by doing APTT and all, but therapeutic dose, it is a contraindication. NOACs. Nowadays, we see a lot of patients taking dabigatran and rivaroxaban. So again, Dr. Aarti has stressed this issue, but just to cut short, dabigatran, we have agent available, Praxibind, and within, just give the injection, within 5 minutes we can thrombolize. Some patient, our colleagues, they are doing it, and we have not done it, but we can do it. In Mumbai, Navi Mumbai, in a tertiary, we have a facility of all these things. Suppose I order this Praxibind, within 1 hour it is available in Apollo. So we can consider such patient for thrombolysis. But this is not possible for other neoanticoagulants like rivaroxaban, then apixaban. Their reversal agent is not readily available, not reliable. So here we follow the timeline. Suppose patient is taken a last dose of anticoagulation more than 48 hours, then we can consider them for thrombolysis. Otherwise, we should hold the thrombolysis. Now, chronic kidney disease. It is not a contraindication. You can go ahead and this is a European guideline. They say you should, there is no dose recommendation, dose modification also. You can thrombolize the patient like we do other patient for, we consider other patient for thrombolysis in CKD. CLD means chronic liver disease. So problem with CLD is patient will have deranged INR, patient will have low platelet, which become the contraindication. But we know that patient is having all these things, definitely we will screen for that. And but suppose patient is having CLD of mild variety where decompensation is not there and this contraindication is not there, so we can thrombolize by doing platelet count and by doing INR. Systemic malignancy, relative, not actually depends, again, platelet count, how much is the thrombocytopenia and all. Coagulopathy, if INR is less than 1.7 with warfarin and all, we can thrombolize. Otherwise, we should hold the thrombolysis. Suppose a patient having any small procedure in non-compressible site, then it becomes the relative contraindication. But suppose the person is having compressible, suppose some facial injury where there was a bleeding, but we can compress it, then that is not a contraindication. We can go ahead with thrombolysis. Recent major trauma, not involving the head, it becomes relative. But again, it is where is the trauma? If it is a non-compressible site, it becomes contraindication. GI bleed, within 21 days, we should not do thrombolysis. But if it is a past GI bleed or genital urine bleed, we can thrombolize with explanation to the patient. Menstruation, most of the patient, young female, they come with having active menstruation. That is not a contraindication. Only concern comes when there is a menorrhagia. But still, again, it is not a contraindication. We should keep a gynecologist, we should involve them, and we should keep some blood ready. But these are not a contraindication. Unruptured intracranial aneurysm. Sometimes we do MR angio, we see aneurysm. So it is not a contraindication. But 2A recommendation we have for the thrombolysis. Same thing about AV malformation which are unruptured. MI, again, it depends where is the MI and how, when is the MI. If it is non-STEMI, we have a 2A recommendation for thrombolysis. If it is STEMI involving the inferior and right side of the myocardium, 2A recommendation. But if it is become anterior MI, anterior wall MI, then it becomes slightly risky, and we have 2B recommendation. Means some risk of the cardiac rupture or whatever, it will be there, so that becomes the some relative contraindication. Dose depend. Suppose a person, most of the time we see cardioembolic stroke, patient is having heart attack, and same thing brain attack. Sometimes the clot forms, sometimes the situation comes. So here we should not use the thrombolysis dose of myocardial infarction. Like cardiologists, they use tenec triplase more than 30, 1 milligram like that. But for stroke, the dose is 0.25. So this patient can be thrombolized with that minimum dose, and with that, whatever the cardiac intervention they want, they can do that. LA thrombus. Suppose we know that there is a LA thrombus, then it is a relative contraindication, but to rule out LA thrombus before thrombolysis is not recommended. We know that patient is having LA thrombus and patient is having stroke, then it becomes relative contraindication. Otherwise, it is not recommended to screen all patients for LA thrombus. Infective endocarditis, known patient of infective endocarditis, there is a risk of patient is having this patient problem is most of the time they are not thrombi. They are actually septic emboli. They will not respond to the thrombolysis. And second, there are sometimes mycotic aneurysm, and there will be increased risk of bleeding. That's why person having known infective endocarditis causing stroke, it becomes relative contraindication. Actually, the guidelines say don't thrombolize such patient because two reasons. Most of the time, the septic emboli will be not true infarcts, true thrombi, and there will be mycotic aneurysm, so risk of bleeding will be slightly higher in such patients. Known person of aortic arch dissection, we should not thrombolize. In fact, we have thrombolized one of the patient where window period we did, and in ER itself, after some time, we did some evaluation, then we found to have aortic arch dissection. Luckily, patient was okay, but we know that there is aortic dissection, so we should not thrombolize. But if we thrombolize and later on we know that it is aortic dissection, so it becomes a contraindication. Intracranial dissection, suppose MCA is dissected, basilar or intracranial vertebral, then they are contraindication, but extracranial cervical dissection, they are not the contraindications. Prior intracranial bleed, this is very important because guidelines say if there is an intracranial hemorrhage, we should not thrombolize, but we should see closely in this aspect. What is intracranial bleed? Bleeding in the brain. It can be because of aneurysm. Suppose a person is having a ruptured aneurysm, clipping or coiling done, why he should rebleed? AV malformation, we have treated the AV malformation and there is a bleed. Why he should bleed? So here also we can segregate the patient. A patient is having traumatic ICH. We can consider this patient for thrombolysis. But patient is having hypertensive induced bleed and there is no reason for the bleed. Suppose a patient was taking at that time dabigatran and there was a bleed. And now he is not taking dabigatran, he came with a stroke. And we can consider this patient for thrombolysis. But again, guideline, it becomes 2A, 2B. Pregnancy. Pregnancy is not a contraindication, but if we see that disabling stroke is more problematic than the side effect of the whatever bleeding, we should go ahead with the thrombolysis. 2B recommendation is there. Same thing is about peripartum period up to 24 hours of the delivery. Pediatric stroke, I will not go into detail. Shekhar sir is here to address this issue. And I will stop here. Any question? I tried to cover most of. There are a lot of other things. I thought there would be too much. That's why I not covered. But these are the common dilemma. When I used to be a DM resident and MD physician, these were the question I used to face. So I tried to include all these things into my talk. Apart from this, suppose you have any problem, any question or any query, we can discuss. There are other things also here like sickle cell disease, but it become impractical. So this is a relevant relative gray zones in IV thrombolysis. I will stop here. Yes. Actually, what happened now? What is the problem with the stroke is I will come to the side. Why stroke? You can one simple observation. Cardiologists use same tenecteplase in higher doses, and most of the patient they are not worried about bleeding. But our patient, we use 1/4 dose. Still, we are worried of the bleeding because infarcted tissue is weak, and there is a high risk of intracranial bleed. A stroke, which is recent stroke, there is a risk of bleeding. Suppose a stroke is not recent, remote symptomatic stroke, we can thrombolize the patient. And in fact, we have last time Dr. Pawan Oza was there. He has thrombolized the patient twice within, I think, 3 days, because there was a recurrence of stroke in different territory. And most of these thrombolytic agents, their half-life is not that much, maybe 24, 40 hours, whole effect will go. So we don't have guidelines for this thing. It becomes a relative contraindication, but we should select a case-based discussion. It's like that.
Thank you, sir.
Your topic, gray, black and white,
Yes, sir.
pertaining to this, can you just elaborate?
So gray, white, black. Actually, white is, we know, clear-cut indications. Patient is more than 18-year-old, within window period, no contraindication. So he is ideal candidate for thrombolysis. Black means outlier. He is out of window period. There is a malignant infarct. There is a uncontrolled blood pressure. There is a contraindication. So these are clear-cut area. We are happy to see such patient. We know we don't have to think too much. But these gray areas, CKD, CLD, treatment decisions become difficult. So we have to think a lot, and sometimes we have to tweak the guidelines, and we have to take the case-based call. But suppose something outlier is there and we are following the guidelines, something negative happens, nobody will challenge you. So that's why gray and white, white and black, they are most important. If we are, if we are neglecting them, then it becomes difficult.
Thank you.
Thank you, sir. Now we will go to the next session. That is, when managing an acute stroke patient, we are always mindful of potential risk of hemorrhage. While the stroke is a medical emergency that demands timely intervention, the very treatment we administer is a small proportion of unfortunate patients lead to intracerebral hemorrhage. So you might have got an idea that our next topic will be discuss the management of thrombolysis-induced intracerebral hemorrhage. I would like to call Dr. Shekhar Patil, sir, my guide, and he is a practicing adult pediatric neurologist at Apollo Hospital. खींच लो, हाँ मैं पकड़ा।
Okay, good morning. So now that the patient has actually presented to the ER, and from the ER we have done the imaging and we actually thrombolized. So now we are going to look at the complication, the potential complication of intravenous thrombolysis. So I'm going to talk on management of thrombolysis-induced intracerebral hemorrhage. So before we look at that, we need to understand what is the epidemiology. So how many patients of actually thrombolysis end up having intracranial bleed, and how many of them really require some treatment or intervention that can actually alter the outcome, and do all bleeds do poorly? That is what we need to know. And what are the risk factors when we consider patients who will likely bleed, and what do we do for managing such scenarios? So we'll look at symptomatic ICH. Generally, in all the proportion, we are talking about 2 to 7% of all patients who end up having the thrombolysis will end up with a intracranial bleed. Now, 82% of the bleeds occur within the first 24 hours. So the post thrombolysis protocol of a 24-hour CT scan is primarily to pick up on these patients, but you can actually alter the protocol. You can actually look at the neurological deterioration and think of imaging them earlier, which is what we did just last night. So 9% of bleeds do occur after 48 hours, and probably within the 24 to 48 hours, another 9%. So we're talking about 80% approximately within the first 24 hours. Now, when we look at the radiological features, we actually classify them as hemorrhagic infarction, grade 1, grade 2, parenchymal bleeds, grade 1, grade 2, and then extra ischemic. So bleeding at a site different from the ischemic zone. That is what we are also looking at. So, look at this particular slide here. So actually you're seeing a small speck of blood here. This is a petechial hemorrhage, confluent petechiae. So this is HI1, this is HI2, and then you have the parenchymal bleeds. This is the one which we are actually looking at, which will be the one of maximum concern. This is type 2. And then you have the extra ischemic. So the ischemia is here, but the bleed is at a different site. So this is a different patient. So what are the predictors? We look at elderly, we look at glucose, because the sugar will definitely alter the endothelial lining, which will predispose you to the risk of bleeding. A high NIHS score, renal impairment, congestive heart failure, atrial fibrillation, and a very strong, large, visible infarct size. So these are probable predictors of the post-thrombolysis bleeds. So we look at these scores, and these are the scales that we are using to predict. But what is the simplest one is this one, which has practical purpose, because it has a high specificity of 60%. Almost all are that specific only, and a good sensitivity of 80%. So what you can look at is this EGAN score. So early infarct, glucose, atrial fibrillation, and NIHS score more than 10. So if you actually follow this, so 13 is your cutoff. If you have 2, of course, you'll have 25. So then you have a higher risk. So if your score is less than 13, you will actually look at a standard monitoring. Score is more than 13, you look at intensive care at a much more closer monitoring, not just 24 hours. So the monitoring usually begins half an hour for the first 6 hours, then hourly for the next 24 hours. And whenever you find that there is some neurological deterioration that comes through, or a new neurological sign that emerges, that is the time that you actually go ahead and do imaging to pick up these complications. So we know that alteplase has a short half-life, but why does it actually cause the bleed? Because it leads to a consumptive coagulopathy. So some centers actually follow the principle of identifying these patients who will be at a risk. So you do the so you look at the fibrinogen level, a baseline fibrinogen level less than 200, or a drop in the fibrinogen level within 6 hours of more than 200 predispose you to the risk of bleed. So just the coagulopathy is primarily the factor leading to the bleed. Now, why do we actually have the hemorrhagic infarction? You actually have the RBCs which extravasate, and the parenchymal hematoma is actually a bleeding from an injured vessel. This is what we are actually worried about. This can occur even after thrombectomy. And we are also concerned about the reperfusion injury. So you actually open up the vessel, the infarcted tissue is at risk, and you will bleed within that infarcted area. So we need to know about this pathway primarily because of the intervention. So where does the alteplase act? It actually is like inhibiting plasmin formation, and the other ones, which we are the corrective ones, they are going to activate the extrinsic or the intrinsic pathway. So there is a protocol for CT scan after 24 hours of thrombolytic therapy. Earlier scans are warranted if there is a neurological deterioration, and clinical monitoring is absolutely essential. So that's the reason after thrombolysis, you tend to shift the patient to an ICU to monitor the patient periodically. So if you do encounter a bleed and you are within that 7% who have bled, then what would you do? You would actually control the blood pressure. You would offer the same thing as in an ICU. So you will monitor you will provide cardiovascular and respiratory support. You will monitor for neurological deterioration. You will offer treatment for raised intracranial pressure, and at the same time be slightly concerned about the seizure. A new seizure after a thrombolysis could also herald a potential bleed. So what do we do if I were to actually reverse that? So I need to reverse the coagulopathy. That is the problem. So we have Praxbind for when you are actually looking at Pradaxa, so you can actually use that. So that's for dabigatran. But for everything else, what we should be doing is use cryoprecipitate. So cryoprecipitate is the only thing which actually has some proven benefit. Everything else has unproven benefit. So platelets, FFP, vitamin K, prothrombin complex. So the potential for benefit for correction is unclear. So what you should ideally be giving is cryoprecipitate. We can consider using the activated factors. You can also consider a pause, which is the tranexamic acid, but be mindful of thrombotic complications with tranexamic acid. And you can, so the thrombotic complications can occur at sites different also. So just last week I saw one who had given a single dose of tranexamic acid and had retinal arterial occlusion. So you have lost vision because of that. So you can have potential complications which can be serious and more disabling than actually the stroke, which eventually would have probably improved. So the other part that we actually look for is how do I prevent the expansion of hematoma, and when do I call in my neurosurgeons? Do I call in my neurosurgeon for each and every bleed, and which are the patients that so you should be very selective of the ones that you would probably call your neurosurgeon. The ones where you have the cerebellar hematoma, ideally, yes, everyone should be offered the decompression. You can probably also consider decompressive craniectomy instead of trying to evacuate the hematoma. So that's the option. So the outcomes in the long run, when we talk about the hemorrhagic infarction, grade 1, grade 2, as well as the parenchymal hematoma, grade 1, they generally will not have a worse outcome. So the parenchymal hematomas, grade 1, will deteriorate in the early phases, but later on at 3 months, the outcome will be good. The only concern is about the parenchymal hematoma type 2, wherein they will experience a 50% mortality, and in the long run, yes, they will end up having a worse outcome. But the proportion of PH2 in the overall context of 7% is negligible. So we generally would not really encounter this on a regular basis. So in summary, thrombolytic therapy leads to 2 to 7% of symptomatic intracerebral hemorrhage. The pathophysiology is coagulopathy and a breakdown in the blood-brain barrier. Predictive scores are available. We should try and use them to predict who is going to end up with the bleeding. Reversal of coagulopathy is the treatment of choice, and with a selective neurosurgical intervention, and the outcome is worse only for the type 2 hematomas. Thank you.
Thank you, Shekhar sir, for that wonderful session. It was short and brief. If there are any questions, we'd like to take it. I think in the interest of time, we'll end this session and we'll move to the next one.
Yes. Thank you. Now we'll move ahead to the next session.
Any question on thrombolysis? We can discuss maybe after next session, or now also a few questions we can take for whatever the discussion we had in last session.
So now we will move ahead with the session 3. So after completing the discussion on IV thrombolysis, now we move on to our next session, that is mechanical thrombectomy and ICU management of stroke. For this session, I would like to invite our chairperson, Dr. Bharat Agarwal sir, Dr. Anjali Palvia ma'am, and Dr. Kapil Chavre sir. So Dr. Bharat Agarwal sir is a consultant physician critical care specialist at Apollo Hospital, Navi, Mumbai. Dr. Anjali Palvia ma'am is a senior consultant in medicine and echocardiologist affiliated with the MedCity Hospital, Kharghar and Medicover Hospital. She has a special interest in the fitness and functional medicine. Dr. Kapil Chawre sir is a practicing physician in Ulve and a visiting consultant at Apollo Hospital. So some patients with the acute ischemic stroke do not respond to sufficiently to IV thrombolysis, and in a certain situation thrombolysis may be contraindicated. In such cases, endovascular intervention play a crucial role in re-establish cerebral blood flow. So I would invite Dr. Vishal Chaple sir to deliver a next talk on a mechanical thrombectomy in acute ischemic stroke. He will outline the indication, techniques, contemporary approaches in a mechanical thrombectomy, and will also brief touch upon endovascular strategies to stroke prevention.
So we'll the next session about thrombectomy, intervention in acute ischemic stroke and ICU care. So mechanical thrombectomy has changed the dynamics and treatment in a stroke patient. Any patient of the stroke, if there is artery occlusion, until we don't revascularize, patient will not recover. By either you do thrombolysis or thrombectomy, but ultimate goal of treatment should be the recanalization. If artery is blocked, we should open it, otherwise patient will not improve. So what are the treatment options? Thrombolysis and more than 4.5 hours. If it is large vessel occlusion, we have mechanical thrombectomy. We can do up to 24 hours, but for best result, we should do earlier, because more the time lapse from the onset to recanalization, more is the tissue lost and we may not get good recovery. So as early as possible. What are the intervention now we have available and we are doing it? IV thrombolysis, endovascular intervention, we have intraarterial thrombolysis, we have mechanical clot retrieval with stent retriever, we have penumbra system where we aspirate the clot, and sometimes acute angioplasty and stenting also we have to do. I will start with a case. Last month we did this case. A 52-year-old male, hypertensive, presented with right hemiplegia, aphasia, last seen normal at 2 a.m. and he came to ER at 5:30 a.m. Power was around upper limb and lower limb around 1 to 0. He was not moving at all. He was total globally aphasic. He was not understanding anything. So he's not following command. NIHS we calculated it was 20. Blood pressure was 150/90. So again, this patient, MRI was done. MRI was showing evolving left MCA stroke with left M1 occlusion. You can see the occluded left MCA and evolving stroke in the left hemisphere. So this patient was a candidate for thrombolysis. So immediately we started with the thrombolysis. Where is the marker? And we have given tenecteplase in this patient, 16 milligram bolus dose, and immediately we shifted patient for mechanical thrombectomy. So guideline don't say you use thrombolysis and you wait for recovery and not recovery. It is a bridging thrombolysis. You thrombolyze the patient and don't wait for recovery, shift the patient. That's what the guidelines say. So this is how we do thrombectomy. Thrombectomy is done under local anesthesia. I start under local anesthesia, and suppose patient is cooperative, I just continue with local anesthesia, and sometimes patient is restless, I have to give anesthesia. We put a sheath here, we do diagnostic angiogram, we take our catheter, balloon guide catheter into the carotids, then we enter into the occluded segment with the microwire and microcatheter. Here you can see the clot, we are crossing it with a microcatheter. Then through that microcatheter, we pass our stent retriever and we catch the clot and we remove it. That's how we do thrombectomy. This is the preparation. When the patient comes, we activate the cath lab. our staff, generally we have 24 hours cath lab staff in our hospital. We have that liberty. So they keep everything ready. Our infusion sets, everything is ready. By the time patient comes, our anesthesia team also comes. So immediately, within no time, I would say by the time patient is shifted 10-15 minutes, so we are not wasting that time also because we arrange other thing into the cath lab. We have all materials available. We use infusions. Then we take, in this patient I have taken groin access, you can see. And we attach the catheters. And to reach MCA, it takes hardly 10 to 15 minutes if patient anatomy is straight. In this patient, young patient, straight anatomy, it hardly took 10 to 15 minutes. And this is the actual thrombectomy. First step is angiography. Here you can see the, excuse me, where is the marker? Okay, sorry. So here the ICA, the occluded segment, I took my stent retriever. First I took the microcatheter, I checked that MCA is open there and here it is occluded. So this is the occluded segment. So this is a solitaire stent retriever I am deploying into the occluded MCA segment. I deploy it. You can see the stent is opened. And then there is a balloon here. That catheter contains special catheter. It is an internal carotid artery and we are occluding the artery by putting a balloon. Once we engage the clot with the stent retriever, I occlude the artery, I create negative suction and remove I check that everything is okay and then I remove everything. And we check whether artery is open or not. In this patient, after first pass, still artery was blocked. Again we have to do the same thing. We have to go inside, take microcatheter, micro wire. Under vision we do everything because we do in brain the arteries are not supported. So there can be perforations and all. So I enter into that occluded segment, you can see. Again I check that artery is open, distal, and this part is occluded. So again I deployed the stent retriever right from the open artery up to here. So our stent is almost 6 mm by 40 cm. So this will cover whole entire segment. Now here I did a different technique. Here I pinched the clot and same thing I did and opened the artery. So this artery I could open up in second pass. Total procedure took almost 45 minutes for the recanalization. This was the clot retrieved this stent retriever and this is the clot removed from the artery. So we do on-table dynacity to see everything is okay. This patient, next day, he started moving his right upper limb and lower limb. In ER I showed you, that was a day prior before taking the thrombectomy. This is the next day morning. You can see the right upper limb movement are there. And still he is aphasic, but he started moving the limbs. He started following simple axial command. He was initially totally globally aphasic. In thrombectomy or any stroke, we don't get dramatic recovery. Our aim is not improvement. Our aim is to prevent the progression of the symptom. So this is a follow-up. After 3 weeks now, I did a video call to see how he's doing. So now you can see the patient is okay. And he's speaking, he understands. He still have some comprehension problem. It will take some time, maybe 3 months, 6 months to improve, but his activities are now independent. You can see upper limb is moving. There is right minimal facial palsy. Power is almost normal. He can walk independently. He will get up now. So long video, I just cut short it. Okay. So timelines here, they are very important. A patient of left MCA evolving stroke coming to the hospital at midnight. He developed at 2 a.m. in coming early morning. Onset to presentation to the hospital in this patient is 3.5 hours. Door to IV thrombolysis time is 40 minutes. Onset to groin puncture time is 4.5 hours and artery to recanalization. Onset to recanalization time 5 hours 15 minutes. So we could get a good recovery because we could recanalize the vessel within 5 hours 15 minutes. So that's why most of the brain we could salvage. It was only ischemia, there was no infarct. So these are the different techniques. So in this patient I use this stent retriever with this balloon I was talking about. We have a lot of stent now. Now there is a grassroots trial and Indian stent is also coming with I think cost will come down in future. And this is a penumbra system where here I catch the clot. In this penumbra system what we do, here you can see the clot is there. I am not deploying stent here. I am just taking my microcatheter at the clot. I am engaging the clot. and I am just putting is attaching to the pump or a mechanical suction, and artery will open up. So this is another technique. Both are equally effective. So some say that this is better and that is better. It's not like that. Sometimes we have to use both. Sometimes I have to take the aspiration catheter and stent because to get better aspiration. So we call it solomra. So both are equally effective. Often case-based selection, and some people are more comfortable stent retriever. They are doing that. But both are approved. We have level recommendation for that. Now coming to the anesthesia. Generally, thrombectomy, only painful structure is when I remove the stent, that MCA, that is painful. Sometimes patient moves and I generally give fentanyl and generally it settles. So preemptive, I give fentanyl before doing thrombectomy. Suppose I am doing conscious thrombectomy. But suppose sometimes patient is having left MCA stroke, they are moving, they not respond. So roadmap is not proper, so better to do anesthesia. We do generally laryngeal mask airway, and suppose I find that patient will need ventilator for maybe 24-48 hours. So I put a mechanical ventilator directly. Identifying the ideal patient is very important, and identify the salvageable brain tissue, we call it penumbra. That is the ultimate the tissue target we are having here. So ideal case scenario with a level 1A recommendation, a patient having a walking, talking patient, occlusion of major ICA, MCA, major vessel occlusion like M1 segment occlusion, age more than 18 years, NIHS more than 6, aspect more than 6, and within 6 hours I could start the thrombolysis. These are the ideal case scenario. But lot of patients who are outliers, like I mentioned, concomitant IV thrombolysis. We don't wait for thrombolysis. Even patient started with the Actylize, it takes 1 hour to finish, and we ship the patient. We discontinue that and we do thrombectomy. So during that time also patient should get benefit of thrombolysis. And there is sometimes the hospital don't have thrombectomy facility, so they should thrombolize the patient and don't wait for recovery. Just ship patient for thrombectomy to save the time. And that is the recommendation. Try to get CT angio, MR angio as early as possible once thrombolysis is done. And if you don't have creatinine report, no need to worry. You can just go ahead and nobody will challenge you if why you have done CT angio in a patient is having a creatinine 3. Because it was emergency, we have recommendation. Less than 6 hours, no need to do perfusion or any DW flare mismatch. Generally we don't do because there is a penumbra by default. But more than 6 hours, this is the same patient, I'm just showing different patient. This patient, but if it is crossing the window period more than 6 hours, then we have to establish the penumbra by doing diffusion flare mismatch, by doing perfusion, by doing rapid, and ultimately we have to take a call on case to case. So this is a patient where ICA was occluded. You can see the ICA total occluded and MCA was also occluded. So we opened the patient artery by doing thrombectomy. Everything is opened up. Sometimes we do thrombectomy for distal arteries also. Like we can do thrombectomy for the M2, M3 regularly we do, but we can do thrombectomy of M3 also. We have small stent retriever. Normally we don't do, but in a patient is having aphasia and small stroke, but it is affecting the language area. So we have a small stent retriever. We can go and we can remove the clot from there. So in this patient, patient is having a language dysfunction, aphasia. So one branch, this branch was not totally filling. Now it is filling. So you can see this is occluded somewhere. There is no flow. So I have to deploy the stent retriever here and open the artery. In this patient, you can see the flow. There are paucity of the branches, and here you can see good TK3 flow. So sometimes if stroke is disabling, small artery can be opened up. Tandem occlusion means suppose the carotid is also narrow and MC is also occluded. We can thrombolize. Only thing is in such patients sometimes we have to put a stent. So stroke, thrombolysis and putting a stent becomes a bit risky. We try and avoid, but sometimes we have to do that. This patient having IC occlusion, you can see some streak is there. I opened up by balloon plastine. I can see there is a lot of thrombus here. I put a stent because there is no way to go up, so I have to put first stent. Then I have entered into the brain. You can see the MC is also occluded. Again, I have to do thrombectomy by putting a stent retriever. So it is a tandem occlusion, and ultimately we could open the artery. Most of the trials for thrombectomy, thrombolysis, they are for anterior circulation. But same guidelines and same data we apply in a posterior circulation. There are specific trial for posterior circulation. So we are doing thrombectomy in posterior circulation. This patient was having a basilar artery occlusion. You can see proximal basilar. There is no flow at all. And opened up by doing thrombectomy. This patient was having top of the basilar syndrome. Again, in first pass, we opened the artery. You can see there is no flow. They look simple, but actually the presentation is very devastating. This patient actually present with locked-in syndrome or very, very severe NIHS. Sometimes we have to open the vertebral artery. Here, the vertebral artery is occluded, and we opened up by putting a stent here, and ultimately the flow is restored in the basilar artery. So thrombectomy can be done in any major vessel occlusion. Even small vessel can be occluded if it is salvageable bent tissue is there. Now this thrombectomy, you can see the PCA. PCA is occluded. No flow here, no collateral, white area. So after first pass, I could open the PCA also. Extended window up to 24 hours we have, but again we are very much choosy in such selecting patient because if we cross the window, there is always a risk of this. If there are good collaterals, then we take such patient. Sometimes we do intra-arterial thrombolysis. Here 1B, 2B or 1C recommendation, but sometimes we have to do. I remember a patient having a cataract surgery in just in afternoon and evening. For that they have stopped the dabigatran. They came within window period for thrombolysis, but they were not, the ophthalmic surgeon was not keen for any thrombolysis. So we gave them option. I put a catheter into the ACA itself, crossing the ophthalmic artery, and I gave the thrombolysis there, so that there will be no local side effect and only whatever the dense medicine, whatever we could deliver those into that occluded segment. Sometimes we do. A typical situation, again, to do or not to do, that is a question. So we again discuss, we have a lot of discussions before taking patients. Sometimes we do DSA and we take a call that he is not a candidate, we should not do it. Pre-existing morbidity, if patient is having an independent lifestyle, we should give him fair chance. Low NIHS, if large vessel occlusion, and the patient is having hardly 3 or 4 NIHS and patient is having a MCA occlusion and patient coming within 3 to 4 hours. Thrombolysis, if it disabling, we have to do, whether to do thrombectomy or not, it becomes difficult. So we have to give them option, we have to closely watch them. Suppose there is a deterioration, we take them for thrombectomy. Trials say you should do thrombolysis because almost 18% of such patients, they do deteriorate. High NIHS is not a contraindication. Collaterals count, yes, collaterals count. This was the patient having a good collateral. You can see this artery is occluded, left side, but right is virtually giving everything. These are the patients having a good outcome after doing thrombectomy, even in an extended window. But same true thing is not true. This patient recovered. You can see this was the post thrombolysis and this is next day. This is a contrast staining and some minimal hemorrhagic conversion, but patient recovered well. She was a very young patient. You can see the age. I think she was very young, almost 19 or 20-year-old young girl. She is normal now. Sometimes some unfortunate patient, you do everything, they don't recover. He is the patient having IC occlusion and left IC is not showing any collateral. These are the candidates where we actually, with time, we have decided not to do, not keen. But ultimately, when you enter, then only we know such information, we get such information. Even after opening, you can see the, maybe outcome may not be good in this patient. BP, yes, once we open the artery, everything changes. We don't need a natural increased blood pressure, we reduce blood pressure. So we try to reduce it to less than 180, maybe 130, 140 if we open TK3 flow. Because again, recanalized artery, high blood pressure, there is a risk of bleeding. I just quickly go through sometimes we do thrombectomy and this is acute setting. But there are a lot of other occlusive lesions which may cause recurrent stroke. So I just quickly show the interventions, what we are doing and available, not routinely for strokes. Here is the patient having watershed stroke because of severe narrowing of the carotid. And there was a stroke. If we see carefully, there are collaterals, few collaterals, but this is the area. This area, you can see, the area which is not getting blood supply from this artery, and again this was not able to supply. So this is the watershed zone. And there was the infarct in this patient. And we do carotid stenting, this simple procedure under local anesthesia. We put a filter device so that balloon angioplasty or whatever manipulation we do, it should not go into the brain. And we put a self-expanding stent, we remove stent. Total procedure takes 30 minutes, patient under local anesthesia. And maybe day 3 we discharge that patient. This is the patient after stenting. And you can see the circulation brain again improved after putting a stent. Sometimes intracranial stenting we do, but the recommendation is suppose there is recurrent stroke or very total occlusion causing watershed, then we do intracranial stenting. Here is a patient having MCA occlusion. You can see there is severe narrowing. Patient was having 2 stroke in the past. This time we treated him. Not before that because it was not diagnosed. So we do DSA. We found that there is actually severe narrowing in focal narrowing, and I crossed with micro wire. Then I put this coronary stent here. You can see balloon, small stent, and then we deploy it, ballooning of the stent, and you can see the artery become normal. This is the pre and this is the post. Then sometimes we have to do basilar artery stenting. Near total occlusion, basilar artery. This patient will not respond to the medicine. You can see the artery hardly, I would say 1 mm or thin streak is there. We just go and put a stent, and some timely done, we can salvage the brain. So I will stop here.
Thank you, Dr. Vishal. One question from the audience. Now, compared to a acute MI situation, when the patient is taking of PAMI, they say don't thrombolize, we straight away go to PAMI. Why do we using thrombolize and then shift for a thrombectomy? What's the difference?
So 2-3 differences are there. First of all, heart don't bleed, and heart we have a lot of penumbra there, or for the intervention. Suppose I do delay intervention in brain, maybe after a few hours also, outcome may be dramatically different. Second thing, the PAMI, everything is readily available. They don't need CT, MRI to diagnose, so they can salvage the tissue. Here diagnosis,
here also,
everything.
Sorry. Here also you're doing your thrombolysis or you're doing your thrombectomy after the imaging. Correct. So once you've done the imaging, the decision between thrombolysis and thrombectomy. Correct. So here you're saying you start the thrombolysis and then we take for thrombectomy. Okay. Compared to a PAMI where they said don't thrombolize, straight away shift to the cath lab when it's available. So if you see your timeline here again was hardly difference of 40 minutes. So what is the rationale to thrombolize and then shift for thrombectomy?
See, sometimes there are 2 things here. There are certain distal branches which are occluded. Every artery I can't open. So by giving thrombolysis, you get that sometimes distal occlusion can open up. Second thing, the clot, sometimes they say it is very tight, and with thrombolysis it becomes soft and it is easy to recover. In fact, I am happy suppose patient is not thrombolized because risk of bleeding is very minimal. I have to be very careful when a patient is having thrombolysis. I have to puncture in a single puncture. I should be very much careful before manipulating. So I am happy, but guidelines say we should thrombolize. Maybe we don't have now, maybe in future may come, there are trials where direct thrombectomy. Problem is infrastructure as of now, I think. So like PAMI is established treatment, everybody knows PAMI, every small hospital also have, but thrombectomy is still not available. So there are trials, there are sometimes the recommending, but it's not in the guidelines now.
Okay. Very nice representation. I have one question. Suppose we have done a thrombolysis, like you have done a thrombolysis, and after that, what is the time period you want to wait to go for the mechanical thrombectomy? What is it like?
There is no recommendation said you should not wait. Just start thrombolysis, shift the patient.
Okay. Yeah. So you don't wait for the clinical outcome of the thrombolysis?
Because that is the time we are waiting.
Yes.
After 1 hour, suppose no recovery, we are wasting the time.
Yes.
So most of the time, what happens, ma'am, we start thrombolysis in ER, we shift the patient, and we do angiography. Sometimes we know that artery is recanalizing, then I just do angiography, I just shift the patient to the ICU.
So ideally, each patient should come to 100% people, they should come for mechanical thrombectomy.
Large vessel occlusion, window period, thrombolysis, thrombectomy, that is the guideline.
Yes,
but sometimes it becomes difficult to do everything practically. We have a lot of things, their guidelines don't say, like consent, clearance. Still, we are lucky that we are very supportive management. Some in emergency situation at night, we get a lot of clearances. So we could do all this from it. It's not possible that within half an hour patient comes and he has to pay. But we have very supportive management, I would say. So due to that, I think we can do some patients, which otherwise not possible in other hospitals.
Okay. Thank you so much. Any other questions?
Yes, sir. Yes, sir. Nothing is 100%. Even thrombectomy, 100% nothing. So we say that if suppose I do thrombectomy in 3%, one will have dramatic, nobody will realize there is a stroke like I showed. Some patient will recover with time, maybe after 3 months, 6 months, slowly, will have some disability. 1/3 patient may not recover completely. That is the guideline. So 42, 43%, 50% around, you can say good recovery. Lot of other dynamics are there. How much tissue we can salvage, how much time from onset to recanalization. By that time, we can't compare with the baseline MRI because suppose most of the time this is 2 hours from the baseline MRI. So final outcome ultimately depend how is the penumbra and which ultimately we know after few weeks or months. Yeah, these are the guidelines based on that. So they have recommended that. So that guidelines come based on the studies. They have done direct thrombectomy, they have done thrombolysis with thrombectomy, and they found some statistical significance. That's how the guidelines came. Yeah, it is favorable, sir. That's why we are doing it. Sometimes I have a liberty that I am a person deciding thrombolysis and I am doing the thrombectomy. So sometimes I know that I am able to take this patient within 15 minutes in cath lab. I generally directly give them option of thrombectomy. Very rarely I do such things.
One question from my side. What is the cost for thrombectomy in your setup?
So cost for thrombectomy, we should divide into two. I see such patient comes with a major stroke. There is definitely even if you don't do any intervention, they will need some hospital cost. We'll not discuss that. So cost of thrombectomy as of now, it comes around 5 to 5.5. I would say we do thrombectomy in that range. Actually, here majority is a material cost. More than 3 lakhs is a material cost. Till that it is not because suppose we have to do aspiration catheter, cost will increase to more than 1.5 lakhs. So we don't have liberty like cardiologist having doing everything within I think 50-60,000. Everything comes within lakhs in here. But still, I think 5.5 lakhs, and we are saving his other hospital. If you calculate everything, I think we should consider stroke not a 1 or 2 day expense. We should consider at least 3 months of expense. If you calculate, actually we are giving preventing disability, we are preventing hospitalization. So maybe in time, we have grassroots trial now where Indian stent was tested. So they have good results. Maybe in few years we will have Indian stents, thrombectomy devices. So maybe we can play around that, and we will have thrombectomy in a reasonable, I would say, this thing.
Hello. Is there a tough war between interventional neuroradiologists and neurologists in this?
No, it's not war, sir. Actually, it's a friendly discussions. So, see, everything is evolving, sir. Now, because of stroke, I think more of a neurologists are into the intervention. Now we have dedicated FNB course into the this thing, where we can apply in our institute also. We have sufficient number, so we can apply for that fellowship also. So it's not like it's a friendly discussion, it happens.
So is the concept same, open cerebral is better than a closed one?
Can you elaborate, sir?
No, in a chronic situation, after the thrombosis has occurred, like it, I see the route is being followed as it was in case of cardiologists. It started with thrombolysis within 6 hours and then went in how to open the coronaries at any point of time.
Yes.
So same thing I see that it is coming
As of
up.
now, it's very early to say for brain. So, see, most of our intervention, they are based on cardiac intervention. I have to say catheter. Sometimes I use that stent, and I'm more happy than you because I can do within the stenting, intracranial stenting within 1 lakh budget. I can do because I'm using coronary stent. Suppose I use same brain stent, the cost will increase to around 1.5 to 2 lakhs. So the cardiologists have that liberty. So I think they have more years of the practice and with time and availability of the techniques, and they can do that direct thrombectomy, direct PAMI, and we don't have that liberty at present.
Yes, so it is a matter of time, I think.
Maybe, we can't say. See, 1996, before that, stroke was not treatable. Then came the thrombectomy, then came tenecteplase and thrombectomy. So now, whatever we are actually, day by day, we are evolving. 3 years back, I would say 2019-20, thrombectomy was possible up to 6 hours. Then come the Dawn diffuse trial and we got the approval up to 24 hours. So everything is evolving. We are having good devices. Within no time, I would say 10 to 15 minutes, I can reach the MC. I don't have to struggle in young patients and all. So because of good devices. So I think everything is changing. So with time, everything may shift. We'll see. But as of now, we are following whatever guidelines we have, sir.
Thank you, Dr. Vishal. We'll get to that. Thank you so much.
Thanks, Dr. Vishal, sir. Now we will move to next session, ICU care in stroke cases. Significant hemodynamic changes occur in the setting of acute stroke, and these patients require vigilant monitoring and specialized care in the ICU. Optimal outcomes depend greatly on timely and appropriate critical care management. I would now like to invite Dr. Swadeep Sen for his talk on ICU management of acute stroke. Dr. Swadeep Sen, sir, is a consultant, Critical Care Department, Apollo Hospital, Navi, Mumbai. He will provide valuable insights into the principal and practical aspect of ICU care for patients with acute stroke.
Thank you, Dr. Silva, for the nice introduction. I'm Dr. Sivadeep, and I look after the ICU in the Apollo Hospital, Navi, Mumbai. First of all, thank you, Dr. Vishal, for inviting me in this scientific sessions on the acute stroke. It is nice and privileged to have a talk on a lot of neurologists over here and a lot of physicians over here. I'll try and give an intensivist versions how I look at it as the kind of somebody comes in acute stroke in the ICU. This is the outline of my talk. So we'll talk about the ICU triage and the initial stabilization, the hemodynamic and the respiratory support. We'll talk about the preventing secondary brain injury, what is the aims and how do we do it, and cerebral edema and the brain protection. Starting the discussion of the ICU triage and the initial stabilization. Who requires to be stayed in the ICU? The admission criteria is most of the patients with acute stroke, they come to the ICU. But if you go by the guideline, anybody who after the stroke who has some unstable vital signs or hemodynamic instability should come to the ICU. Anybody who receives thrombolytic therapy or thrombectomy post-reperfusion, they should be monitored in the ICU with a serial monitoring of the NHS score, their neurological status, the GCS, and for the next 24 hours. Anybody who after the stroke who has a GCS of less than 9 or some reduced consciousness, they should be coming to the ICU. Or anybody who has an NHS score more than 10 with a high stroke disability should come to the ICU. What do we do in the ICU? Who comes to the ICU, we monitor the vitals. That is the basic purpose of having somebody in the ICU. We monitor BP, pulse, temperature, saturations, and all these things. We send a baseline labs, complete blood count, the coagulation parameters, glucose. One important thing is the troponin I. For all stroke patients, it is important to send a troponin I because it has been stroke in the case of the ischemic stroke. If the troponin I is elevated, that has been found to be associated with a poorer neurological recovery. And we review the images and we take a call as per guidance by the neurologist. The time into the disabling ischemic stroke, it has already been discussed. I am not going into details of that part. So within less than 4.5 hours, the IV thrombolysis or endovascular therapy, depending on the CT angiography report. If the CT angiography is large vessel occlusion, then the endovascular therapy can be done. Beyond 4.5 hours, less than 6 hours, then mechanical thrombectomy or endovascular therapy is indicated. Even beyond, the latest guideline says, even beyond 6 hours, we have a late window period depending on some imaging modalities and all that. So Dr. Vishal has already highlighted about that part. I'm not going into details. Reperfusion strategy, Dr. Arati has already spoken about this. Tenecteplase is the new molecules which is being used for the last 3-4 years. So it is simpler, it is faster. We do not need to wait for the altiplase like altiplase for more than 1 hour to run. So it is time saving. So our door to perfusion time becomes shorter. And there is, if we go by the guideline, recently published guideline, there is a strong recommendation to use tenecteplase as an alternative to altiplase in acute stroke. We need to mindful about the dose part, so 0.2, 0.3 milligram per kg body weight. Thrombectomy window, again, Dr. Vishal has spoken to. I'm not going into details that. There is a Dawn criteria and diffuse 3 criteria. Based on that thing, we know that we can do a thrombectomy even beyond 6 hours period. So previously, wake-up stroke is a kind of complete no-no for any kind of revascularization therapy like thrombolysis or thrombectomy. But nowadays, even the wake-up stroke, we can do some MR study, diffusion perfusion study, and we can see that the way that we can, this candidate, that gentleman or that person is suitable for any mechanical thrombectomy or endovascular intervention or not. Now coming to the ICU management. Post-thrombolysis, patients require intensive 24-hour surveillance. So initial 2 hours post-thrombectomy or post-revascularization, they require neuro checks every 15 minutes after the bolus. And subsequently after 8 hours down the line, for initial 24 hours, there's a kind of, we need to monitor his GCAs, vitals, and the most importantly, blood pressures for all patients. For all practical purposes, we usually hold for any kind of, we try to hold for any kind of interventions, especially the interventions like putting an NG tube, arterial line, central line, Foley's catheter, and all those things for initial 24 hours. If the patient is sick, we obviously do it, but we try to avoid as much as possible for the initial 24 hours. Red flags, it is again discussed by Dr. Sekhar over here. So we need to have anybody who has been started under thrombolytic therapy, be it in the endovascular treatment or be it in the thrombolytic treatment. We need to know that what are the red flags. So we need to stop the thrombolysis. So anybody who is maybe on antiplase therapy who has already been started on altiplase, but if there is a new onset headache or vomiting or neurological worsening by more than NHS goes more than 4, or develops some seizure, or BP goes more than 180, or any change in the pupil, we need to stop the thrombolysis. We need to quickly shift the patient to another CT scan to look for the bleeding. We can give cryoprecipitate immediately to reverse this reverse. That is the only one important, only one standard treatment for thrombolytic therapy. And we should quickly lower the blood pressures less than 140 millimeter. One important thing is the large hemispheric infarct. So that is one thing that has not been discussed so far. So maybe you can just have a highlight. So one thing is that so anybody with a malignant MCA stroke or somebody with a large stroke burden, so they are at a very high risk of developing cerebral edema. So even though that there is first of all, the patient gets debilitated because of the stroke itself, because the blood vessel got occluded. So that causes some amount of disability. Along with that, whenever there is a stroke happens, in the surrounding area, there is some edema happens, and that causes secondary brain injury, and that makes the patients neurologically down. So we need to be aware of that fact. So infarct involving more than 50% of MCA territory, they are more predisposed to have a life-threatening cerebral edema. The peak edema, we need to be mindful, the peak edema happens post 2 to 5 days after the ischemic stroke. After 7 days, usually starts coming down. So we need to have a kind of repeat CT scan after 24 hours for detection of the early edema and to understand before any clinical deteriorations happen. So that is why for anybody with a stroke, you usually do another CT scan 24 hours down the line. What do we do for anybody who has a malignant MCA stroke? So the most important intervention to save somebody's life who has developed severe cerebral edema and got a neurological disability is the decompressive cranectomy. One important thing is over here is that if you see the number needed to treat. So NNT so NNT is one important thing probably we need to discuss over here. The NNT for decompressive cranectomy to save somebody's life whenever somebody develops malignant cerebral edema is 2. So I'll just highlight what is NNT is. I hope most of you people know, but just for discussions. So in some time back, it was being discussed that how many patients will actually recover after the post thrombolysis. If we go by the guideline, if we go through all the recent articles, the NNT in favor of thrombolysis to have a favorable neurological outcome, the MRA scale 1 or 2, is around 10. So that means that we need to thrombolize 10 patients to have one patient have a good functional neurological outcome. So that is the benefit of thrombolysis. If we talk about the decompressive cranectomy to save somebody's life, is the NNT is 2. That means if we do 2 patients decompressive cranectomy, one person will be able to save life. That is the impact of having a decompressive cranectomy in terms of saving somebody's life, and that is the impact. So, but whether the decompressive cranectomy gives a good functional outcome or not, that becomes a very difficult thing. Most of the people where we do a decompressive cranectomy, the patient gets salvaged, but what is the functional outcome at 90 days or at the end of 3 months? If you see the recent one of the review articles that we are reading probably I think few days back, so it all depends on the patient selection becomes the most important things to determine the overall functional outcome. It depends on what time we have done. The decompressive cranectomy needs to be done within 48 hours a period of time, but the earlier is the better. It depends on the time when I'm sending the patients for the decompressive cranectomy. What is the functional status at that point of time? So that determines the outcome. So there are a lot of things that determines. But overall, the functional outcome, it is not very clear. So most of the time we end up having a decompressive cranectomy. They save somebody's life, but they remain bedridden for beyond 3 months. So the MRA scale that we talk about that as a functional outcome is not very, very good. Coming to the hemodynamic and the respiratory management, so that is the kind of core issue things. Blood pressure target, it depends on the patient population. Somebody, again, as all of you know that, anybody who has undergone any reperfusion strategy, post-reperfusion, we need to keep the target as blood pressure 180 by 100, 105. Post-thrombectomy, the target blood pressure is around 180 by 85, 180 by 100. If the thrombolysis doesn't happen, we do not take any reperfusion strategy, then we do not lower down the blood pressures very, very significantly. It is important to lower down the blood pressure, not to lower down the blood pressure more than 15-20% of the baseline that with which he comes. So there is a kind of permissive hypertension that we need to do to prevent the further ischemia. If somebody is neurologically stable, obviously, then we can restart the antihypertensives to maintain the. We can restart all the antihypertensives if the BP is more than 140 to 90. But if somebody is neurologically stable, not very high NHS score, but somebody who is a very high NHS score, we do not make the blood pressure normalize within 24 period of time. So this is the NNS2 trial which talks about that there is an open label multicentric trial happened over more than 800 patients that talked about the intensive versus less intensive management of the blood pressure, where the blood pressure has been normalized 120 versus 140 to 180, and it has been found that the more intensive treatment group was associated with a higher number of major disability at 90 days. If we do the MRA score at the MRS 1 and 2. The same thing happened, same trial, the Identify trial is recently published in June 2025, which showed that the intensive blood pressure control versus non-intensive blood pressure control doesn't have very much neurological difference. The drugs that we use to reduce the blood pressure for somebody. One important thing is the hypotension. Hypotension is important to prevent. Anybody who has a malignant MC-related stroke or anybody with an acute ischemic stroke, we should not let them to go in hypotension. So we should maintain a little bit higher blood pressure by giving crystalloid, optimizing the volume status, giving some vasopressors, whatever it likes for initial 24 for 48 hours. Coming to the ARA protections and the ventilator management. First of all, anybody who is who is maintaining the oxygen saturation more than 95%, 94%, there is no need for any supplemental oxygen. Supplemental oxygen has been found to be harmful for all subset of the patients. If we try to maintain the oxygen saturations 99%, 100%, it doesn't help, and there are a lot of people they get harmed because of this hyperoxia, because we in any injured part of the body they develop a lot of oxidative stress. So it is not indicated. So anything less than 95, we try to maintain 94, more than 94%. Intubation indications are very standard. So anybody who has a GCS of 8 or less, PCO2 of 60 or PCO2 is more than 50, there becomes a standard indication to put somebody on a ventilator, or somebody who is not able to maintaining their airway. So that becomes an indication to put somebody on ventilator. It's important to intubate somebody or put them on a ventilator, even though their GCS is low. It is important to put them on a ventilator with a with a deeper plane. So that all of them needs to be kind of given a good general anesthesia, good muscle relaxant. It is not right to make them struggle during our intubation, because that increases the intracranial pressure at the time of intubations, increases the intubation surge. So that usually increases the overall outcome. So we need to know that part. What is the ventilator management? Again, it is very standard. We keep our oxygenation target more than 94%. We try to maintain normocapnia. We do not maintain the PCO2 less than 35. We maintain that PCO2 of normal around 40. Hyperventilation is strict no-no in patients with acute stroke. Unless somebody who has an acutely coned, then we can do a transient hyperventilation. Otherwise, we need to maintain the carbon dioxide level around 40. And we should continue the low tidal volume ventilations and all these things. Now coming to the secondary brain injury preventions, which is one of the important aspects on preventing the disability. First is the control of the fever. Anybody who has developed stroke, develops fever because of any reason, be it because of this infection, because of this central fever, it is not good for the brain. So we need to maintain the normothermy of 36 to 37 degrees centigrade. We can use the paracetamol, we can use the hypothermia, the cold devices, cooling devices and all those things, but it is important to maintain the normothermia. There is no role of therapeutic hypothermia in any patients with acute ischemic stroke. So we need to, again, it is a strict no-no. Glucose control, again, a very important part in the overall management. We should maintain the normal glycemia in these patients. Very strict glycemic control is harmful. Anybody who is diabetic, non-diabetic, it is important to keep up target blood sugar around 140 to 180 that we just try to maintain for all those patients. If we try to maintain a very strict blood sugar control, there is one trial that happened in the nice sugar trial which initially showed the kind of good neurological outcome, but again that has been, it is again become outdated with the subsequent trials. Fluid management, again important to know, again I'm telling all these things why with a kind of intensive ways to take care of that part. Anybody with an acute stroke goes in a positive fluid balance, that worsens the neurological outcome. So we need to keep an eye on that part as well. Whenever we give fluid, we need to give isotonic crystalloid solution, be it in a normal saline, be it in a ringal lactate, be in a plasma-lite, whatever we use. We should avoid hypotonic solution like 5% dextrose or half normal saline. All those things we should not use, and we should maintain the euvolemia. It is very, very essential. Anybody who comes developed acute stroke today, tomorrow is 3-liter positive, that develop a worse neurological outcome. Seizure treatment, again, everybody knows that. So anybody who has guideline doesn't recommend the kind of universal prophylaxis of universal seizure prophylaxis for all patients with a stroke. But we need to treat the clinical seizures with levotiracetam or phenytoin, whatever is the depending on the institution policy. Seizures are more common in somebody with a cortical infarct, so we need to be more vigilant over those things, but there is no prophylactic antiepileptic we need to be given. Dysphagia is one important thing that we all screen for all patients who develop stroke, especially MC-related stroke. We screen them for the dysphagia because it is common. If it is present, then it increases the risk of aspiration pneumonia, and then it becomes an overall poor outcome. So anybody for initial 24 hours, if they do not have any bulbar dysfunction, then that is fine. If there is a developed some bulbar dysfunction, we need to be very, very careful. Early VT prophylaxis is mandatory for all patients with a MC-related stroke. So for whoever, suppose somebody has undergone thrombectomy or thrombolysis, then for initial 24-hour period, we give a mechanical thromboprophylaxis, like in terms of DVT pump or compressed stockinets like that. We give a DVT pump only. Beyond 24 hours, it is important to start a pharmacological prophylaxis. And the options is enoxaparin, 40 milligram, or unfractionated heparin, we can, depending on whatever we are comfortable with. Last thing is the managing the cerebral edema and its complication. As I have told earlier, peak edema risk occurs 2 to 5 days after the large hemispheric stroke. So we need to be mindful about that part. Anybody who has an infarct more than 50% of MC territory, or NIH score more than 15, or age less than 60, the younger patients, they are at higher risk of developing cerebral stroke. ICP monitoring usually do not do in our center, but there are standard indications over there. But there is no trial which has been told about that the ICP monitoring has improved the outcome. But anybody who has clinically significant having cerebral edema, and clinically we find that it's important, we can identify somebody who has a raised ICT clinically for most of the patients. It is important to use a stepwise pattern or stepwise treatment plan for those patients. Tier 1 is to maintain the head end of bed elevated 30-40 degree centigrade, 30-40 degree. We need to give it sedation, we need to maintain a normothermia, we should avoid hypotension, and we avoid hypotonic solution. Tier 2 comes with osmotherapy, either mannitol or 3% saline. And if somebody is refractory, then we go to the stage 3, then we can use the hyperventilation or barbiturate coma, all those things we can use. Hyperventilation, again, I have told we should not do, it works for very transient period. Optimal patient positioning is important. We need to maintain the head elevations 30 degree. Neutral neck alignment is very important. It's anybody who stays in the ICU with acute stroke, if the neck comes like this and he has developed a stroke over there, that means the right-sided carotid is occluded with the neck like that. So it is important to have a neck alignment straight. And anybody on a ventilator, they need to be managed. Even though their GCS is low, they need to be put on good sedation and good analgesia on a ventilator. Regarding the choice of the osmotherapy, we can use mannitol, we can use hypertonic saline. The choice depends most of the time. That the choice depends on the person, the neurologist, the center, the experience, and all these things. There is no clear-cut benefit over the mannitol over the hypertonic saline, but there is some patient-specific preference. But it is important to avoid concurrent use of both the agents. We can use either mannitol or hypertonic saline. We should not use both together. Mechanism of action, I'm not going into details. Hypertonic saline, what it does, it just takes the water out from the cell, and then it increases it expands the intravascular volume. So anybody who is hypotensive, it is better to use 3% saline. Mannitol, it becomes an osmotic diuretic, so sometimes they are associated with volume depletion. So anybody who is hypotensive, it is better not to use mannitol. The choice depends on the type of the patient, as I have discussed. 3% salines are more commonly used. Somebody 3% saline is safer, so that is most important thing. So for all practical purpose in our ICU, we use 3% saline for anybody who is having the raised ICP due to any reason. Especially somebody who is hypotensive, somebody who has some renal impairment, somebody who is come with a trauma, we usually use 3% saline. Mannitol, the major risk of having mannitol is the dyselectrolytemia. They may develop hyponatremia, they develop hypernatremia. We do not have any control of the sodium. Most prominently, they develop acute kidney injury. If we give mannitol, we do not take care of the volume status. A lot of people, they get shifted from outside to our ICU with AKI after administration of the mannitol. We need to be careful about that part. And the problem of having mannitol is to have a rebound ICP. For all practical purpose, what we do, we use 3% saline as a kind of standard, for raised ICP management. We use mannitol as a bolus whenever when we need an acute drop in ICP. Like suppose somebody is herniating, I'm shifting the patient to the OT, I give a bolus of mannitol of 300-400 ml, and then we shift the patients to the OT. Mobilization is again one important thing we all know that most importantly the physiotherapy and the physical rehabilitation becomes an integral tool in overall outcome, but it is important to avoid mobilization for initial 24-48 hours for all patients with acute stroke. There's an AVAT trial which showed that the early mobilization within 24 hours after acute stroke has shown worse neurological outcome. So we need to be mindful. Thank you. Thanks a lot.
Any questions from the audience? Dr. Savdeep?
Thank you. Thanks a lot.
Savdeep, just one question. Yeah. About your DVT prophylaxis, you do your CT, you find microhemorrhages. There is some hemorrhagic conversion. When would you want to start your low molecular weight heparin after that, or keep it only on pneumatic devices?
No. So the thing is, the microhemorrhage, so microhemorrhage is not very prominent. So microhemorrhage is not a problem at all. But suppose somebody has developed acute IC bleed, and then they come to the ICU. The guideline recommendations is that we can start the LMWH. You are talking about the LMWH. So LMWH after 48 hours if the bleed is not increasing. So after 48 hours you can start. So if the bleed is not increasing, we can usually do a serial scan. So depending on that we can start.
Thank you.
Thank you.
Very nice representation. Thank you very much. Yeah.
Thank you, madam. Thanks all. Yes, sir. Somebody who has developed raised ICT will find it clinically. The GCS will drop. If the neurologically it is warranted, then another CT scan is required. If neurologically is not warranted, probably we do not require. If the patient is fine, talking, doesn't have any sign of the raised ICP, the GCS is fine, neurologically is improving, we do not need to do have. If the dysphagia persists beyond for 24 hours, we put a nasogastric tube and then start feeding. Okay, thank you everybody.
Thank you, Dr. Swadeep sir. Thank you, Dr. Bharat sir, and thank you for Dr. Anjali ma'am. We now move to our very special part of today's program, the inaugural function. It is my privilege to invite our esteemed dignitaries to the stage for the inauguration. I would like to call upon Dr. Kiran Shingote sir, Unit Head, Apollo Hospital, Navi, Mumbai. Dr. S.V. Kulkarni, Senior Physician and President of Maharashtra Association of Physicians. Today, Dr. Ravi Shankar sir is not available. Dr. Shekhar Patil sir is a Senior Neurologist at Apollo Hospital. We are deeply honored to have them inaugurate this CME. Their presence underscores the importance of collaborative efforts in improving outcome for stroke patients across the region.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा सर्वकार्येषु सर्वदा.
Yeah, hi, good afternoon. I'll not disturb much. I know this is an academic program and a lot of this discussion is not related to what I do on daily basis. As a responsible organization and a leader in India, 3-4 things I would like to really say today and commit as a new city, young city, this part of Maharashtra. A lot of medical education and capacity building is not happened over a period of time. We have a highest number of medical college around us, but that setup where technology, skill set, infrastructure readiness is there is what our responsibility, and we are committed to do that. When as an administrator, when we see a specialty, we compare as a part of global what you say, capacity building. We compare specialty and infrastructure on what is available best in the world. So when we talk about that, we talk about skill set and manpower ability, we talk about infrastructure, and we talk about how the specialty growth happens. Now, when I start this, when neuroscience is compared, I'm not going to talk specifically about a stroke and stroke-related program, but what I'm going to talk about entire neurosciences. When we say what required to do successfully, one is definitely skill set, and skill set doesn't mean neurologist. What we saw Suhadeep talking about, it is about a collaborative efforts, neurosciences, which will have a diagnostic, therapeutic, surgical side of it, and rehab, as Dr. Nitin is also around. So capacity building at doctor level is there. Capacity building at nursing level, because you saw a result when you have a dedicated nursing dedicated ICU, when there is a paramedical support system, there is a nursing support system, even housekeeping. So unless until you build that capacity across all level, it is very, very difficult to do that. So that is first part of it. At Apollo Navi Mumbai and around, we are responsible and we are trying to build that across. When it comes to the infrastructure, as we saw, it is important to get patient as early as possible in hospital. That requires dedicated ambulance system awareness. We have seen a lot of time patient or families are not aware what to do. So a lot of efforts are done to go to the societies, community, and educate them what it means as a stroke or emergency. So we are trying to do that. We are trying to create the infrastructure to make more awareness, create the ambulance networks, create the 106 is definitely a number which people can remember. So that is something we infrastructure for outside hospital, what we say pre-hospitalization. When it comes to the emergency and then therapeutic and diagnostic support system, we are equipped. I guess barring a SPECT, which is going to be there in next 2 months, we have already ordered that, and gamma camera and SPECTs, which is integral part of your treatment. So that will be available in Apollo Hospital Navi by Feb this year. So in terms of infrastructure, starting pre-care to hospitalization, diagnostic, therapeutic, and intervention kind of work structure, we have everything available. At the same time, post-hospitalization, most of your patients will be chronic and they require support. So for that, home care and the rehab facility, we have started that. So as a part of responsible organization, we are trying to make that everything available. And most important part is at the end, education and research. We have started, I guess your first student is already here. So we'll have an educational program, both in terms of DNB and fellowship program across all the areas, and similarly a lot of research projects also be part of us. So this is what I really wanted to all of you to know and participate wholeheartedly. It is not Apollo. What we try to do is not Apollo, and not that because we are sponsored and that is where I am. No, that is not the answer. Answer is we are a young city. We started recently, maybe 30, 40 years. Traditionally, Mumbai had a lot of medical or colleges. Navi Mumbai has now private medical colleges. It's our responsibility to develop specialty in a sense where we compete internationally and we don't lack any infrastructure, skill set, and maybe a global presence. And I see that happening with the airport around. Maybe we will be a health city associated with health at track and us. And there are a lot of institutes. When I was talking to a couple of people outside, Government of India and Maharashtra is investing a lot in this part of city, and I think long term all of us will be part of it. Thank you very much and best wishes for our program. Thank you.
Thanks, sir.
Good afternoon, everybody. Thank you, Apollo. Thank you, Kiran, and organizing such a nice program. On behalf of API Navi Mumbai City Branch, I thank you all for such a wonderful event. And if you go back to Adam's textbook of neurology, in the first chapter of the editorial itself, he has said that a neurologist learns neurology stroke by stroke. So this is what stroke by stroke has started. Akshay and Aarti, they really opened the innings very well. And on top of it, the way in which the subject has been built up is really very nice. And last but to confess, because my son is also here, even though general medicine is my wife, my first love was neurology. And I was with Dr. B.S. Singhal in 1983. And I am exactly a sandwich between Shirish Valsankar and Satish Khadilkar. I was between the two neurologists. I am very happy that after 42 years, I can do something like a thrombolysis. at a primary care level. Aarti is one of the witness of that. Small centers like Khopoli, Alibag, Paint, Mahad, they should start doing thrombolysis at the very basic level. And friends, I'm very proud to tell you that this whole program will be now even can be done at all the district places of Maharashtra also. Once I circulated this news to my API Maharashtra people, they are insisting that we should have something similar, but a compact one at all the district centers. So I wish you all the best. Thank you on behalf of, again, API Navi Mumbai City branch. You have to excuse me because I got another AI event to catch up. Thank you.
Thank you, sir. Now we will go ahead to the session 4. After the acute management of stroke, we now move to our next session, medical management of stroke. I would like to invite our chairperson for this session, Dr. Vishal Kini sir, Dr. P.S. Shinde sir, and Dr. Resham Kukreja ma'am. So Vishal Kini sir is working as a consultant physician diabetologist at Kharghar for 18 years. P.S. Shinde sir is a senior physician practicing in Alibag region and his own hospital, Lakshmi ICU and nursing care in Alibag. Dr. Resham Kukreja ma'am is a consultant physician practicing in Navi, Mumbai and attached to Tehna Hospital and MGM Hospital and runs her own clinic. One of the most common and the practical dilemmas we face in selection of the antiplatelet agents and determining the optimal duration of therapy after acute stroke. To address these important questions, now I would like to invite Dr. Neeraj Jain sir. So Dr. Neeraj Jain sir is a consultant neurologist at Apollo Hospital and he is a head of department of a esteemed KEM Hospital, Mumbai. So sir will give a talk.
Thanks Dr. Vishal and the organizer for inviting me for this talk, and thanks the chairperson for the time you spend in your busy schedule. So this topic is very important from the medical perspective for all of us actually, because we are dealing with the chronic patients who had stroke or who had ischemic heart disease, and day in and day out we are using antiplatelets. So I think we must be aware about the recent guidelines, because most of the patients, as we are aware, that they are on double antiplatelets for duration which is not defined. And we don't see into the details of the stroke, what happened exactly and what kind of stroke it is. So that's why this topic is very important and relevant for all the practicing physicians. So I'll be interpreting the recommendations, distinguishing the antiplatelet therapy difference between the initial therapy and the long-term therapy, and the key evidence which support this. So I would be discussing about the key trials which because of which we have come to this recommendation which we practice today. These are the standard guidelines, how we come to the level of evidence and the recommendations. So as we are aware that the stroke is very, very common. The total stroke risk per year in US is around 8 lakhs, out of which most of them are ischemic stroke, and equally there is high risk of TIA, which are also in one way, they are sort of minor strokes. In India, though there is a scarcity of the data, but around 108 to 172 per 1 lakh people per year is a incidence rate, with crude prevalence of 26 to 757 per 1 lakh people. So this is a daily problem. And in fact, in KM also we do see, at least we do thrombolysis of around 2 to 3 patients per week, and mechanical thrombectomy as well. So it is a daily affair. out of all the strokes, most of the patients have ischemic stroke. Out of the ischemic stroke, the non-lacunar strokes are more common, around 77%. Out of the non-lacunar stroke, the common ones are basically the cryptogenic as of now, because we have been investigating patients, and at the onset many times the patient remains cryptogenic. But the other common etiologies are cardioembolic or large vessel occlusion. This is important in any stroke patient when we label that what is the type of stroke, whether it is a territorial or a watershed stroke, what is the mechanism of the stroke, and what are the risk factors. So these 4 points we need to identify in every patient to decide about the long-term therapy. So now coming on to various drugs, this is the standard chart which we use to read in physiology. So there are various drugs which are available which act at the various point in this chart. Aspirin, a gold standard, inhibits the COX-1 enzyme, and the ticlopidine and clopidogrel, they interact with the ADP pathways. Whereas some of the newer antiplatelets like apixaban, iftamab, and tirofiban, they act with GP2B3A receptor pathway. The new one, as we are seeing here, is ticagrelor, which also acts with the ADP pathway, and it is also P2Y12 inhibitor. And the action is slightly earlier as compared to clopidogrel. I will be coming to details of that later. So these are the various agents which are available. Some of them, like prasugrel, we don't use that much in neurology, and some of the agents which are apixaban, iftamab, they are available in IV preparation. Usually, sometimes they are used peri-procedures. Clopidogrel and ticagrelor, they both are the drugs which act on the ADP pathway, but the difference is that clopidogrel is a prodrug which has to be metabolized by certain enzymes to convert into the active metabolite, whereas ticagrelor is an active drug. So there are some guidelines, recent guidelines, in which ticagrelor has been approved for stroke use, and that's why we need to be aware of this. So aspirin, a lot of trials in the dose ranging from 50 to 1300 milligram per day. It is an irreversible blocker of COX-1 enzyme. In high dose, it can also inhibit COX-2. Within 48 hours of a stroke, there is 30% odds reduction of recurrent ischemic stroke. The number needed to treat is 140. So definitely it is beneficial. The risk of major bleeding is very less. Now, in primary prevention, so when patient has not suffered anything, so whether it is indicated, so usually in US there was concept of polypill, just patients having diabetes, heart disease, and they just take aspirin for primary prevention. But actually aspirin is usually not indicated for primary prevention. The only indication is when the 10-year cardiovascular risk score is about 10%. Then usually aspirin can be used for primary prevention of stroke. Otherwise, in most of the patients who have suffered TIA or stroke, then aspirin should be used. Now, aspirin resistance, there is one concept. Biochemically, it is basically elevated thromboxane A2 levels and rapid platelet plug formation. So, it is very difficult to define. The first step is to exclude the non-compliance. Real resistance is less. Resistance is higher with lower doses of aspirin and entry-coated aspirin. And treatment options include increase the dose, add clopidogrel, or switch totally to clopidogrel. Clopidogrel dose is 75 milligram per day. It usually takes 4 to 5 days for the antiplatelet activity to show its full effects. Loading dose, not universally recommended, but sometimes yes. 12% of people may not respond to this drug because of CYP2C19 genotype, which is common in Asian populations, and there is a large trial which has been done in Chinese patients. So this we need to be aware, and co-administration with other PPIs can reduce the effect of clopidogrel. Aspirin versus clopidogrel, lot of trials. Clopidogrel is slightly beneficial in patients who have concomitant peripheral arterial disease, diabetes, or in those with past history of CABG. So when to use combination? I will be coming to some trials later, but then the usual situation in which that combination can be more effective. In high-risk cases of TIA or minor stroke, severe symptomatic intracranial stenosis, symptomatic extracranial or intracranial arterial stenosis causing artery-to-artery embolism, strokes attributable to aortic arch plaques which are having high intensity, high-risk atrial fibrillation, So usually in atrial fibrillation, always anticoagulation, but sometimes when the patient is not eligible for anticoagulation, then yes. Ischemic stroke with acute MI and intracranial and extracranial stent implantation. So these are the situations in which DAPT may be used. Long back, this combination was very widely used, aspirin plus dipyridamole. Still, it is available with the name of Agrenox. So, ESPS2 trial, which was done in Spain, it showed that the combination of aspirin with dipyridamole was more effective than either agent alone in stroke prevention. The common side effect is headache, and bleeding is lesser with aspirin. Silestazole, another drug very commonly used in our daily practice for the peripheral artery disease. Many trials have been done in Japan and the Eastern world, and the dose is 100 milligram BID. It interacts with the PDE3, which is the phosphodiesterase 3 enzyme. In Picasso trial, it prevented more stroke in patients with previous ICS or cerebral microbleed. So what I feel the place of silestazole is mainly in the lacunar stroke for long-term prevention, because the risk of bleeding is less, apart from the standard therapy what we use in usual practice. So then I will be discussing some of the trials, how the treatments have evaluated over last 25 years. So aspirin plus clopidogrel in long-term stroke prevention in patients who have long-term. So the anti-thrombotic trialist collaboration, which was published in 2002. So it showed that the antiplatelet therapy alone was associated with 23% reduction in the odds of all strokes, and when used in combination, but the odds reduction in which the meta-analysis, there are a lot of meta-analysis, it was only 13%. The clopidogrel is associated with lower risk of GI hemorrhage, and combined vascular risk was not significantly reduced compared to treatment with aspirin among patients with previous stroke which were treated in the Capri trial. So this trial demonstrated that it is not beneficial in the long term. Then another trial, 2002 to 2005, it was done, lot of patients, 15,000 patients. In the patients, there was a subgroup in which there was history of stroke or other vascular disease. There was significant reduction in this primary endpoint of stroke. SPS3 trial, these are the major trials. There are a lot of other trials, but so in this particular trial, which is different from all other trials of stroke, because the patients which were included was of lacunar infarcts, which we don't talk that much. The trial was terminated early because aspirin plus clopidogrel was associated with, not associated with significant reduction, and there was doubling of the major hemorrhage. So this, because lacunar strokes we see very commonly, and that's why we need to be aware that lacunar stroke, every person does not require double antiplatelets. Match trial, another trial which was done on almost 7,000 to 8,000 patients, comparing aspirin clopidogrel combination versus clopidogrel, and over 18 months, the primary endpoint of composite vascular outcome was not significantly reduced. It was not significant, and the bleeding and the intracranial hemorrhage appeared to increase only after 3 months. This point is important because we are talking about the duration. So in long term, the hemorrhage risk is high, but in short term, the hemorrhage risk is not that high when you use DAPT. So the conclusion of the trials which involved aspirin plus clopidogrel, they have led to the conclusion that DAPT with aspirin clopidogrel is not recommended for the long-term primary or secondary stroke prevention. It is contraindicated after lacunar stroke. However, the findings from the MATCH trial suggested that acute short-term treatment with this combination is still possible, usually within 3 months. Now, what happened when a patient comes with an acute stroke, that is a short-term, immediate. So there are a lot of trials in this area in which there is non-cardioembolic, for the non-cardioembolic minor stroke or TIA. These two pivotal trials we do talk about a lot, the CHANCE trial and the POINT trial. Both trials are included similar patient. The CHANCE trial was done in mainly the Chinese group, and the DAPT group had significant reduction in 90-day stroke rate. Whereas the POINT trial, the similar trial across the world, and the composite vascular endpoint and the stroke rate at 90 days were significantly reduced. So depending on these trials, which were done in this decade, the AHA guideline came up with class 1 recommendation for patient presenting with minor cardioembolic, non-cardioembolic ischemic stroke with less than 3 NIHS or high risk TIA. So the DAPT with aspirin clopidogrel should be initiated within 12 to 24 hours, and it can be considered up to 7 days after the symptom onset and continued for 21 to 90 days, followed by monotherapy. And lacunar stroke again have a contraindication for this combination. Now in large artery atherosclerosis, again, when there is a large artery like carotid artery atherosclerosis is there, a lot of trials have been done based on the outcome of the major trials, SAMPRIS, in which they had basically a medical arm as well as the stent arm. The guideline gave class 2A recommendation of DAPT with aspirin clopidogrel for up to 3 months, in which patient has recent stroke or TIA with severe symptomatic intracranial stenosis, up 70 to 92%. So these are very high risk. So that's why up to 3 months they have recommended. I think one trial which has been talked about is when patient comes with an acute stroke, and that is a very non-disabling or a very minor stroke with very less disability, only mild facial deviation or something, what to do? Whether you will thrombolize? So you have to see obviously the mechanism of a stroke. If there is a LVO, then yes, because patient might progress, you do not know. There is a trial which compared antiplatelet with IV thrombolysis. So this PRISM trial compared DAPT with intravenous thrombolysis, and they found that in patient with non-disabling stroke, when the high-risk feature of a stroke progression such as large vessel occlusion or capsular warning syndrome is absent, when the patient is not rapidly progressing, then it can be considered. Sometimes you have a major contraindication to thrombolysis, that time also we need to remember. Then the new drug ticagrelor has been used in stroke recently. A major trial, Socrates trial, which is done in 2014 to 16, ticagrelor was compared with aspirin in with minor stroke or high risk TIA, and there was non-significant reduction in the primary composite vascular endpoint or ischemic stroke, but in subgroup analysis, DAPT had better efficacy. So, and again there is a THELS trial. So they have recommended in a high risk patient, it can be used, but there is slightly high risk of intracranial bleeding. So the recommendations, I'll just come to the main recommendation, what we usually practice. So DAPT with aspirin plus ticagrelor can be considered in patient with recurrent stroke while on clopidogrel or carrying a CYP2C19 allele associated clopidogrel resistance. So if you suspect, commercially clopidogrel resistant testing is available, but then usually most of our time it is not practiced because this combination is not commonly used. What we use commonly is aspirin plus clopidogrel. So this combination but can be used. I think so. Whenever patient comes with TIA or ischemic stroke of non-cardiac origin, usually what we need to do is find the mechanism of a stroke. The combination of ASA 75 to 160 milligram plus clopidogrel daily in the first month after TIA or minor stroke is superior to aspirin alone. And the combination should not be used for secondary stroke prevention beyond 1 month. So this is important timeline. And usually the combination, all three can be used, either aspirin, clopidogrel once daily or combination of dipyridamole plus aspirin. So now we come to a case scenario. So he is a 65-year-old male present to office 1 day after being discharged from the emergency room, admitted to ER with right-sided weakness and disturbed speech of 60 minutes, symptom fully resolved. He was diagnosed with TIA and 75 milligram of aspirin was added to his treatment. Past history, hypertension, diabetes, dyslipidemia, and already he is on optimal medications. CT scan is normal and carotid Doppler shows a bilateral minor plaque. So this is a standard score, how to prognosticate such patients. So this is ABCD2 score in which the components are age, blood pressure, clinical deficit, duration, and diabetes. So his patient score comes to around 6 because he has all risk factors. So there is a 30-day stroke risk of around 15%. Neurological examination at present is normal, BP, pulse and everything is normal, and other risk factors are well managed. So how would you manage? So whether only aspirin, discontinue aspirin or change, continue aspirin and add clopidogrel, or discontinue and start combination of dipyridamole or ASA or ticagrelor. So what is the opinion of house? how do we manage this patient? He has a high risk of stroke in the coming 1 month. So what do you think, Vishal? What? Yeah, so this patient definitely has a high risk of stroke in next 30 days. So DAPT is advisable. Now you can choose among, you can discuss about clopidogrel or dipyridinol, but clopidogrel is usually what we use. So we would add clopidogrel to the present therapy. So the 30-day stroke risk according to this score is around 15%, urgent, aggressive, and aspirin, clopidogrel, ER plus ASA are all equally recommended for long-term stroke prevention. So usually we should, the third point is we should plan the double antiplatelet therapy for 30 days, and beyond that the guidelines do not recommend. Beyond that we should come to the single antiplatelets. Other risk factors need to be taken care of. Now, if this same patient had a recent history of GI bleeding or a lower risk of TIA, if the ABCD2 score was 3, then what would you have done? So we would have used only a single antiplatelet. So this is very important because so that we are aware and we should not harm the patient in long run. So the recommendations, these are the standard recommendation coming from AHA, ASA. In all patients with non-cardioembolic ischemic stroke or TIA, antiplatelet therapy is indicated. Aspirin, clopidogrel or combination of aspirin plus dipyridinol is indicated for secondary prevention. And in patients with recent minor non-cardioembolic or high-risk TIA, DAPT should be initiated early, at least within 7 days, and continued for 21 to 90 days, followed by single antiplatelet therapy. 90 days is usually, beyond 1 month is usually in patients who have large artery atherosclerosis with high plaque burden. And those patients who have, the 2B recommendation is for the ticagrelor, in which those patients who have high risk and clopidogrel resistance is there. The last point, harm, if you see the red one, for patient with non-cardioembolic ischemic stroke or TI, the continuous use of DAPT for more than 90 days or usual use of triple antiplatelet therapy are associated with risk of hemorrhage, so it should not be used. I think we have already covered, so thank you.
Thank you, sir. I think I cannot stress how important antiplatelets are in day-to-day life. So thank you for telling us when to stop, because वो continue previous medications में वो चलता ही रहता है.
Yeah.
And
I think that is very important message.
Yeah, yeah. So thanks a lot, sir. So, but I just had one simple question. There we also see patients where we cannot give antiplatelets with ITP and increasing liver diseases on the rise. So can you just give us a substitute and then how to?
So if antiplatelets are absolutely contraindicated, then I think it is very difficult to prevent stroke, because antiplatelet anticoagulation would be difficult. But I think a low dose of aspirin or sometime a middle way can be silestazole, which has low bleeding risk, and it can be used in lacunar stroke. But then the trials have not shown that much preventive rate. But I think the single antiplatelet in a lower dose should still be fine. In patients who have GI side effects or GI bleeding, clopidogrel might be slightly better. Clopidogrel monotherapy.
Stroke as well as.
I agree with you. Very difficult patient, but you always need to identify the cause of a stroke. If there is something other thing treatable like a severe carotid stenosis or other thing, at least that much you can deal with.
Thanks a lot.
Thank you. Thank you very much.
Thanks, sir. Another frequently encountered challenge in stroke management is deciding when to use anticoagulant. Should we initiate heparin or warfarin or newer oral anticoagulant, and in which clinical scenarios? These issues will be addressed by our next speaker, Dr. Yatin Sangvekar, sir. Dr. Yatin Sangvekar, sir, is a consultant neurologist at Kokilaben Dhirubhai Ambani Hospital, Navi, Mumbai, and has his clinic in Thane.
Good afternoon, everybody. So, very nice presentation so far. At the outset, I would like to thank Vishal sir and Apollo and the entire team of organizers. So, my topic is simple, anticoagulants, very few indications, mainly cardioembolic stroke. As sir has already described various types of strokes, almost all the other types of strokes, antiplatelets become the primary line of treatment. Only cardioembolic strokes is where we think of anticoagulation. And among cardioembolic strokes, mainly we look at atrial fibrillation as one of the risk factors for strokes. And my topic today's program would be becoming like a cusp where we are now going into secondary prevention of stroke also. Till now we were talking about acute treatment of strokes. So moving. Yeah. So I'm just going to go case by case scenario basis. So mainly cardioembolic strokes, atrial fibrillation. If we are coming across a patient who has a stroke, in the MRI we are seeing a pattern which is more like a cardioembolic stroke, where we are seeing multiple arterial territories, more than 2 arterial territories are involved. And we don't know that the patient has had a history of atrial fibrillation, or we don't see on ECG that the patient has atrial fibrillation. Then in such cases where this patient is presenting with stroke but without any history of AF, the recommendation, that is class 1 recommendation, is that we have to search for AF in such patients. So the class 1 recommendation is that we have to search for it. So at least a 24-hour Holter is recommended. In fact, a longer 72-hour Holter is recommended in such patients. Now, these kind of patients we are seeing more often in past few years. We don't know whether COVID or COVID vaccine or the lifestyle post-COVID, whatever is the contributory risk factor, but we are seeing more younger, middle-aged strokes which are coming up, which could be grouped into a category called as cryptogenic strokes or something like embolic strokes with undetermined source. So this is another category of embolic strokes where we cannot for sure ascertain a cardioembolic etiology, but then these are called as ESUS, embolic strokes of undetermined source. In those cases also anticoagulation becomes the line of treatment at times. So in those patients where the history of atrial fibrillation is known, of course, anticoagulation becomes the line of treatment. In such cases, what we have to see is first we have to we have to rule out IC bleed if the patient is already taking an anticoagulant. Then we have to look at the severity of the stroke by assessing the NIHS score. Then we have to look at the Diener's law, the age-old law, where when to start anticoagulation becomes a bigger question in such patients. So the law that we have been studying since years of 13612 is when to start anticoagulation, but it is not always possible to follow that law. So then early anticoagulation is sometimes warranted if the NIHS is very low, then we can start within 48 hours also. If the NIHS is low, if we cannot see a large infarct, or if there is a higher recurrence risk that this patient might throw a repeat stroke immediately, if there is no need of gastrostomy, if there is no need of any carotid surgery, if there is no hemorrhagic transformation on CT, if the patient is clinically stable, if the patient is young, if the blood pressure is fairly controlled, if there are no microbleeds on MRI, we can go ahead for early anticoagulation and not follow the law very precisely. Whereas we can delay the anticoagulation starting whenever the NIHS score is very high, wherever there is a large infarct, when there is a low recurrence risk, if the patient is elderly, if there is a need of gastrostomy or any surgery, if there is already hemorrhagic transformation seen on CT, all of these are, if there are microbleeds, then there is a risk in starting anticoagulation early. So in such cases, we wait and delay the anticoagulation. So this is the Diener's law, where if there is a small stroke or only TIA, we start the anticoagulation right on day 1. If there is a mild stroke, if we go by the NIHS score, less than 8, then on day 3, between day 3 to day 5. If it is a moderate stroke, if the NIHS is between 8 to 16, then we start around day 6. And if it is a large stroke with NIHS more than 16, then we start around day 12. So easy to remember, 1, 3, 6, 12 is the rule. Now, if we have to look at recurrent stroke risk in such patients, this CHADVAS score helps us to know that the higher the score, that we know that the risk of any thromboembolism, be it a stroke or any other systemic embolism, increases. So we know that the higher the Chadwell score is there, we have to anticoagulate these patients, and accordingly we have to take the decision. So warfarin, our age-old molecule, becomes the first line of treatment. It's a very easily available molecule, very cheap, and in our socioeconomic status, where maximum number of the patients come to us, warfarin becomes the first line of the treatment. But is it always that easy to maintain a patient on warfarin? All of us know that in our clinical practice it is not that easy, because it has a very narrow therapeutic index. It has several drug and food interactions. It also requires constant and frequent monitoring of anticoagulant effect. A lot of times we have to repeat INR testing, and in fact that adds to the cost. Eventually the cost comes out to be the same in the end. There is marked variability in time during which the INR is maintained actually into the therapeutic range. Now this becomes a very important thing. The time when the patient spends into that therapeutic range between 2 and 3 INR is important to actually prevent a recurrent stroke. And there is also influence of genetic variability in the clearance of the drug. And if at all this patient has to undergo any other surgery in the future, then the slow offset of action becomes a bigger problem in future. So warfarin is not always a very good drug for us in such patients. Also, if we look at this, there is a very narrow therapeutic window. If the INR is less than 2, there is a very high risk of repeat stroke. Once it crosses 3, there is a very high risk of bleeding. So maintaining INR, even if it is a cheap drug and easily available, it becomes a big headache for us to maintain this INR in the therapeutic window. Another issue is that, so in India, achieving target INR, like I told you, is becoming difficult because the diet is sometimes very, high vitamin K foods are there, and it becomes difficult to counsel patients for diet when they are on warfarin. The other over-the-counter drugs like NSAIDs especially are being consumed by patients without our knowledge, which can interfere actually in the metabolism of these drugs. And there are lack of standardized laboratories. So I would share one example I had. So very intelligent, in fact, I would not say intelligent relative of a patient. This relative did lab testing in 2 labs. One lab showed INR high, went to his local doctor. This doctor in good faith gave vitamin K, stopped warfarin. 2 days later developed stroke. The next day he had also sent the sample to another lab which showed in fact subtherapeutic INR, and which was probably the right report. So we don't know how much to rely on which lab whenever we are testing INR. So this becomes a practical issue when we are dealing with reliability of INR reports. And another problem with warfarin is initial paradoxical procoagulation effect. So in fact, initially warfarin will cause rapid inhibition of natural anticoagulants, which are protein C and protein S, before it actually causes inhibition of coagulation factors. So this imbalance can sometimes cause initial prothrombotic potential of warfarin. So this can in fact be counterproductive. And if we look at certain data, even if the INR is maintained, the complications can still occur. So this was one of the trials where we could see that even if the INR was maintained, patients still had ischemic strokes or systemic embolisms. There were even complications, even if it was in the therapeutic window. There were major bleedings, intracranial bleedings, GI bleedings. So this was in Aristotle trial, the data out of it. So warfarin doesn't become a very good option for us in treating such patients. So we have to treat the patient as a whole. We cannot just look at the thrombosis and ignore the bleeding complications also. We have to treat the patient as a whole. So what are the goals that we want in oral anticoagulation for stroke prevention in AF patients is that, of course, we want a reduction of long-term stroke risk. This is the ideal goal. We also want a reduction in post-stroke mortality. That is what we want. But at the same time, we don't want any intracranial hemorrhages. And we don't want any other systemic bleeding also. So for that, if you look at the recent literature, NOACs are becoming a better molecules as compared to warfarin in reduction of intracranial bleeds also, and in reduction of other major bleeding also. So if we compare other meta-analysis where the NOACs are compared with warfarin, If we compare even stroke prevention, we look at this meta-analysis where almost all the NOACs are faring better than warfarin in terms of stroke prevention. But in terms of major bleeding, in fact, rivaroxaban did not fare better as compared to warfarin, but other NOACs, in fact, dabigatran, both the doses, 110 BD, 150 BD, fared better. But apixaban fared much better as compared to warfarin in terms of major bleeding complications. So apixaban becomes a safer molecule as compared to warfarin and other NOACs. Although there are no head-to-head trials comparing all the NOACs together, so it would be very difficult to comment on which NOAC is best among all the NOACs. Majority of the trials are comparing every NOAC with warfarin or every NOAC with aspirin or other antiplatelets. So if we look at the recommendations for oral anticoagulations for stroke prevention, NOACs are preferred in as compared to warfarin. But of course, this is where there is non-valvular AF. If there is a valvular AF, if there is a mechanical wall, of course, warfarin is the only choice that we have. But in other non-valvular cardioembolic causes of stroke, NOACs are preferred. And if the patient is not being able to maintain the therapeutic range on warfarin, if this is less than 70% of the times the patient's INR is in the between 2 to 3, then the class 1 recommendation is to switch to NOAC, and class 2A is to then counsel and educate the patient. And in fact, it is harmful to switch to antiplatelet therapy if the patient is not maintaining INR. So in fact, most of the times, out of frustration, sometimes patients stop that and go back to their old aspirins, but then it can be harmful. So again, the same thing, NOACs are recommended in preference to aspirin as well and warfarin in AF patients. It has already been discussed, whenever thrombolysis is considered, it is not recommended if the INR is above 1.7. And in TI or stroke patients, a combination. Now, this is an important point. For secondary prevention, the combination of oral anticoagulation along with antiplatelets is not recommended. In fact, it can be harmful. So sometimes it becomes a big problem that the patient has a cardioembolic stroke, but also has an atherosclerotic disease. So should we add anticoagulant and antiplatelet in addition to that? Becomes a big question. We might add that in good faith for the patient, but that can in fact be a harmful thing. So if we have to ascertain what is the etiology of that particular stroke, and if the patient has had an AF, for that stroke is cardioembolic, then we have to anticoagulate this patient and antiplatelet should not be added. If the patient is a newly diagnosed atrial fibrillation and there is a previous history of stroke, then if again all the NOACs have been studied, but this is mainly apixaban which was studied, where it fared much better to prevent a recurrent stroke or TIA as compared to warfarin, and even in terms of complications also to prevent any bleeding episode. So almost 19% of this trial population did experience previous stroke or TIA. So apixaban was compared with warfarin. In terms of bleeding also, the apixaban was much lesser as compared to warfarin in terms of bleeding complications. Then there was a meta-analysis of all the NOACs individually compared with warfarin. Almost all favored all the NOACs in when they were compared with warfarin. So Aristotle compared apixaban, Engage compared endoxaban, Relay compared dabigatran, and Rocket F was comparing rivaroxaban. So we can see almost 14% risk reduction was there for recurrent strokes and systemic embolism. So all NOACs are faring better than warfarin. Only cost is becoming an issue, which also with time is not a major issue now. And in terms of complications also, 49% risk reduction was there in hemorrhagic stroke. So almost all the NOACs were better as compared to warfarin. Only systemic bleeding, sometimes dabigatran and rivaroxaban is associated with GI bleeding more as compared to other NOACs and warfarin. So this was a very good article which had come in 2014, where there was, it has addressed the misperceptions of aspirin efficacy and safety, which may perpetuate actually underutilization of anticoagulants in atrial fibrillation. So the fear of bleeding used to be there, and that is why anticoagulants are underutilized at times. But then the repeat stroke, even if there is a smaller stroke, if it is a cardioembolic etiology, we sometimes feel that it has not caused major disability. And let us put the patient on dual antiplatelet. This might be safer than anticoagulation, whatever criteria we keep, age or socioeconomic status. But then actually that might in the long term be a harmful thing if the patient next time has a larger stroke. So underutilization might be harmful. Stroke in clinical practice, all the NOACs same? Like I said, there is no head-to-head comparison, but definitely apixaban confers a favorable effect when compared to warfarin in terms of both preventing strokes and systemic embolisms, and as well as in terms of preventing the bleeding tendencies. NOAC or aspirin, another trial, Everose trial, also again apixaban fared much better. I'm not going to go much into detail of all these trials, but almost all the recent trials have shown that apixaban is safer in terms of reducing the bleeding complications and almost equivalent to other NOACs in terms of preventing strokes and other thromboembolic events in stroke patients, AF patients. Now, there is always this clinical dilemma also at times when we have to switch the anticoagulants. Now, like I said, if the patient is not maintaining therapeutic range of INR, so if the patient is already on warfarin, when to switch to anticoagulants? So we have to repeat INR. If the INR is less than 2, we can switch immediately to the NOAC. If the INR is between 2 to 3, we have to wait one day and then start the NOAC. If the INR is more than 3, then we have to stop, repeat the INR until it is less than 3. And then follow these two till we start the NOAC. Because immediately starting NOAC without doing INR might be harmful in such a patient. If the patient is already on NOAC, we have to switch to warfarin for whatever the reason is. Then we have to do it, we have to continue the NOAC until the INR is again above 2. So we have to keep checking the INR. Once the INR is above 2, then we stop the NOAC and continue warfarin. Whenever the patient is on any unfractionated heparin and conversion is to be on NOAC, we can do it immediately for the next dose. Same is for low molecular weight heparin. Next dose, immediately we can convert to NOAC. From NOAC to other way also, low molecular unfractionated, next dose we can directly shift. From NOAC to NOAC also, immediately for the next dose we can switch. From antiplatelet, we can start NOAC immediately, there is no waiting period. Now coming to one point, what is the indication of anticoagulation in non-cardioembolic stroke? So like I said at the outset, all the non-cardioembolic strokes, majorly antiplatelets is the main line of treatment. But in our clinical practice, we see and we almost are doing it also in our clinical practice that the patients are put on low molecular weight heparin at the admission itself when the patient is admitted in our stroke units or in our ICUs. So this is a practice going on. So most of the times we do it at times for the insurance purpose also because some injectable has to go on. But most of the times I would also say we have to continue it for DVT prophylaxis also. So it is not always wrong to put your patient on low molecular weight heparin right at the admission, whatever be the etiology of the stroke, but then it should be in the DVT prophylaxis dose. But there are only very few indications in non-cardioembolic strokes where anticoagulation is indicated, and these are those large artery stenosis, whenever the thrombus is seen in a large artery stenosis, whenever there is a PFO with a DVT, whenever, like I said, there is embolic strokes with undetermined source, whenever APLA or other vasculitides are there, whenever the patient already has a hypercoagulable states, if there are arterial dissections, then again, the recent literature for arterial dissection also shows that dual antiplatelets are equally effective. So again, that becomes now a gray area for anticoagulation. Venous infarcts, venous sinus thrombosis with venous infarcts, anticoagulation is the line of treatment, and for some thrombophilias also. But in that, I came across this recent meta-analysis. Now, this is the Chinese study, so we always take it with a pinch of salt. But this was studied in Asian population. So they have studied low molecular weight and they have compared it with antiplatelets. And they found that in fact, initially low molecular weight heparin did show some benefit as compared to antiplatelets So, mainly it was to prevent the early neurological deterioration and recurrent strokes early. So the efficacy, they had a subset of all the trials. The subset that they studied was actually large vessel occlusions. In large vessel occlusions, again, as we know, that anticoagulation might have benefit. So in such patients, early deterioration, as the patient is admitted on day 1, day 2, day 3, we see deterioration in the power. In such patients, anticoagulation might be beneficial in addition to antiplatelets, but then the guidelines actually say if it is non-cardioembolic, antiplatelets are the mainstay. So the efficacy of aspirin in acute ischemic stroke has been validated through large trials, but only for those who have early neurological deterioration or recurrent ischemia after receiving antiplatelet therapy. Some benefit might be there, and this meta-analysis, of course, did show that. In patients with non-cardioembolic stroke, especially those having this kind of deterioration, only early benefit was seen. So early benefit between 0 to 6 months, the benefit was there. But if we look at the long-term benefit, there was actually no major benefit. So if we look at the long-term outcomes, antiplatelets and anticoagulation given initially were the same. So the current situation is that anticoagulation therapy has not been recommended in non-cardioembolic ischemic strokes because it increases the risk of bleeding and instead of actually reducing the risk of neurological deterioration or recurrent ischemia. Therefore, choosing appropriate patients and paying attention to the start and duration of treatment is very important. So the key takeaway is that early intervention can help prevent fatal consequences in patients of atrial fibrillation. NOACs are associated with better efficacy and safety versus warfarin in patients of AF or in TIA. Apixaban definitely confers a better favorable effect when compared with warfarin and also when compared with other NOACs. And the benefit of restarting NOAC was higher for prevention of ischemic stroke than the bleeding risk, but then we follow the Diner's law for that. And re-administration of NOACs may be even restarted 4 to 8 weeks if there is a bleeding complication in these patients. So this can be delayed up to even a month or 2. Thank you.
Thank you, Dr. Salvekar. I actually went back to my internship days when we had no option and we had to start the patient on warfarin, and in the back of our heads we knew ki ye kabhi na kabhi from rural areas they would come back with some bleed. But yeah, thank you for reinforcing and telling us all and increasing our confidence to start apixaban where it's needed for cardioembolic strokes. Any questions?
So, sir, as it will. Yeah. So, sir, as sir mentioned, in TIA, the guidelines say that the dual antiplatelets are ideally advised for first 30 days. After that, single antiplatelet has to continue. So, either clopidogrel or aspirin can continue, but lifelong, sir.
Yes. So, the confusion is whether to start anticoagulation or antiplatelets. Here the concept to be understood is that there are two kinds of thrombi. One is the gray thrombus, which occurs in the arteries, which is fibrin rich and platelet rich and fibrin deficient. Whereas a red thrombi, which occurs in the vein, is fibrin rich with which traps large amount of red blood cells. So if it is atrial fibrillation, antiplatelet is of no use. Okay, so if you are suspecting a venous thrombi or one in the heart, you have to anticoagulate. In atrial fibrillation related embolism causing a stroke, aspirin will have no use. So you have to anticoagulate. Yes. And the other question people get scared of is when you are using warfarin, which is effective especially in valvular cases of cardioembolic stroke. So there when you start giving warfarin, the first 1 week is a procoagulant state where there is increased incidence of coagulation. So in this situation, there is always has to be an overlap. When you are starting warfarin, you have to give first 5 days overlap with heparin and warfarin together. So protein C and S will get depressed in the first 5 days, which the heparin will take care of. Thereafter, you can withdraw the heparin and continue with the warfarin. The INR has to be kept between 2 and 3. 2 is effective anticoagulation and 3 is safe anticoagulation. So keep the target between 2 and 3.
Absolutely. Thank you.
Thank you, sir. Now we are moving ahead with the next session due to time constraint, like we are moving on to the next session. So thank you, chairpersons. And now we will...
Dr. Patankar sir was not there today, so we are just starting with the next session.
So the session 5 is atypical causes and the pediatric stroke. So as we all know, stroke is not limited to elderly. It can occur in young adults and even in the pediatric population. These cases often involve atypical mechanisms and identifying the exact cause is crucial. Many of these patients require detailed cardiac evaluation and focused etiological workup to guide appropriate management. With the background, let us move to our next session on a pediatric stroke and atypical causes of stroke. So I would like to invite the chairperson for this session, Dr. Vaishali Lokhande ma'am, a senior consultant physician at Apollo Hospital, Dr. Shailesh Parikh sir, a senior practicing physician from Vashi and the founder of Parikh Nursing Home and ICCU Vashi, and Savita Gondhari ma'am, a practicing physician in Navi, Mumbai and a visiting consultant in Apollo Hospital. So as we mentioned, the stroke does not spare any age group. The stroke is a pediatric patient presents with a different etiologies, clinical pattern and the outcomes compared to adult stroke, making it essential to understand its distinct features. To discuss the pediatric stroke, we have with us expert in the field of pediatric neurology, Dr. Shekhar Patil sir, who is a senior consultant at Apollo Hospital for adult and pediatric neurology.
Yeah, so good afternoon. So I'm going to talk on pediatric strokes, but then we always assume that pediatric strokes are rare. But is that truly so? Why we miss it? So we are discussing the adult scenarios here. The children are actually waiting. They're knocking on the door that even I want to come in and be discussed in this room. So that's the reason we're actually having the session on pediatric strokes. And that is me. That is my practice in Apollo. So I'm always yo-yoing between an adult neurologist and a pediatric neurologist, and that is how my day goes through. So here what we are going to talk about, presentations in a pediatric setting, are they really different? Do we really carry a different set of risk factors for pediatric stroke? And is the management actually different? So let us just compare two different pediatric conditions and understand the epidemiology as well as then compare with the adult strokes. So we look at the pediatric strokes. You actually look at around about 10 per 100,000 between 1 to 16. If you actually go under the age of 1 month, we're talking about neonatal strokes or peripartum strokes. They're actually higher. And when you compare that, so if you look at this 10 and you're looking at 100 to 150, so Of course, the adult strokes outnumber the pediatric strokes by 10-15%, 10 to 15 times more. But with regards to the other epidemiology, looking at childhood epilepsy, so the stroke in adults, similar to epilepsy. So the childhood epilepsy is much more common and matching the adult stroke epidemiology. Look at childhood headaches, 8 to 9% of all school-going children will have headaches, will be migraine. Another 8 to 10% TTH. You compare that with the adults, so it will be a TTH group which will be always higher in adult world, and 10 to 13% will be migraines. So that is the basis where we are right now. And you look at the burden of cerebrovascular disease. So this is the cerebrovascular disease burden. Of course, when you look at this, it's really going higher. But even in this group, you are seeing this. 5 to 10, the less, but in fact 0 to 5, a slightly higher burden. So that's all because of the childhood variety. So let us look at the actual epidemiology. Some studies, 8 to 100,000, that is what I've said. Perinatal stroke, definitely much more. And the hemorrhagic strokes. When you talk about adult strokes, say, around about 85% would be ischemic strokes, 15% would be hemorrhagic strokes. But when you talk about pediatric strokes, 50-50. So 50% hemorrhagic, 50% ischemic. And then the bleeding will be more related to AV malformations. Now, pediatric ischemic stroke. So even the pediatric world decided to offer a trial of thrombolysis. But the problem is always about stroke mimics. High incidence of stroke mimics. Around about 25 to 30% of stroke mimics in any setting, any institute. So eventually, after a period of waiting for 1 year, the whole trial could enroll only a single child. So they decided to give up on the trial and use the adult data and apply it to pediatric population. That is where we are in the pediatric vascular team. What are the presentations? So these are the common ones. So you actually look at weakness, hemiparesis, facial weakness, ataxia, speech and language dysfunction, visual or oculomotor deficits, but you also have very uncommon presentations. So that is headache. So headache can by itself be a herald of stroke. Seizures, altered sensorium, irritability, behavioral change, confusional state, somnolence. So all these things are atypical. So one, they would actually not make the clinician think about a stroke. So you would not plan your investigations accordingly. You will always miss the timeline. So you will never end up having someone to come within 4.5 hour window period. So the chances of this patient being thrombolized is less. Of course, the long-term outcome in terms of MRS scale is better compared to adults. But we are missing out on a lot of kids who could potentially be thrombolized. Now the guideline is 18 years, but I'll show you a case which I have thrombolized as well. Now this is the risk factors for a huge list. Even I don't remember any of these. So we just have to know it theoretically that there is a huge risk. What is important to know about in terms of pediatric stroke? Think of blood and the entire circulatory system. So blood vessels, heart. That is where all your risk factors are. So look at adults. So you have actually the combination or individual risk, which will be probably most common. So most will be like a small vessel disease, large vessel disease, where we actually would take help of Vishal to go ahead and proceed with the thrombectomy. And cardiologically, so they are here to guide us to look for TE and look for other sources of ESUS if they are presumed ESUS. So in the pediatric world, what we are talking about is structural predisposition, acquired exposure, genetic, but so it's hematological, heart disease, arteriopathies, collagen defects, and acquired, which will again give rise to vasculopathy, arteriopathy. So that is the whole thing about it. One thing about what we discussed about this Be Fast, but also remember that Be Fast earlier was Fast S, and that is the seizures. So a new onset seizure could always be a seizure or could always be a stroke in a child. That is what we need to remember. So how does an acute infarct look like? Yes, positive on the DWI, negative on the ADC map. But then we're looking at a 6-year-old boy. Now these are all missed windows. So we have an acute seizure, new onset, aphasia, right-sided weakness. So these are typical for a pediatric setup. What we are talking about is Moya disease. So you can actually see this pattern here, and this is the lenticulostriate vessels, which are originating from the M1 segment, and they actually form a meshwork. So these, in the pediatric setting, will give rise to ischemic strokes. The same thing if you go to an elderly, so they, let's say they cross the age of 20 and have not manifested with stroke, then they'll actually come with bleeds. But there will be atypical sites of bleeding. So not your classical sites of hypertensive bleed. So they would actually come like temporal polar bleeds or somewhere in mesial temporal bleeds. And you could then think of that this is a Moya disease with now a hemorrhagic complication. So now this particular set I've just highlighted here because this is exclusively applicable to pediatric population because of low level falls. So we see kids who've just fallen off from the bed and they're not moving their limbs. So these are low level falls secondary to lenticulostriate vasculopathy. So this is actually picked up by Benjamin but published from India, and then we are actually having the calcification in the basal ganglia which affect the lenticulostriate vessels. The angulation of the lenticulostriate vessels and population under the age of 3 is different. So the mechanism of fall causes the shearing of these vessels and leads to stroke. So that is the mechanism in this kit. So completely different, can't do anything, but you just have to manage them with physiotherapy and a short 6-month to 9-month course of antiplatelet agents. So this is a 10-year-old girl. Now again, sport-related injury, acute left hemiparesis. But what is missing here, as you're not seeing the ICA at all, you're seeing an ICA here. The DSA was done, CT angio. So here we did the DSA, we confirmed the dissection. Now dissection in this setting is actually an arteriopathy. So what we are actually having blood vessels and related heart disease also. Now this is a setting which we are actually promoting here, that okay, if you have a normal CT and you actually do a CT and you have a child or adult with a stroke, you would proceed with thrombolysis. But the same does not apply to a child because you have 25 to 30% who are mimics. So in this case, this was a 9-year-old boy. Now this is a long time, so this was 2017 actually. 9-year-old boy, acute right-sided weakness, was sleepy. So it says that atypical presentation of somnolence. He presented at 3.5 hours. So it means that I can actually thrombolize because the window is there, 4.5 hours. And the CT scan is normal. What is important is this history. Now, how does this achieve relevance? Is that, okay, we did this, so let us say we want to do this, we did the CT, but we cannot thrombolize because of the mimics. So we did an MRI was normal. So we then went ahead and correlated this epilepsy in the dad, which actually was misinterpreted as epilepsy. But what it turned out to be, a CACNA mutation, so this is familial hemiplegic migraine, a most common variant or probably a stroke mimic. So this is something that in the pediatric world, this should strike you the moment it actually sees that, okay, I have a normal CT scan, a normal MRI, and yet I have someone who has weakness. Headaches may not be there as you would commonly see with other varieties of migraine. So stroke mimics, huge list, and that is the reason probably you do not get them within the window period, and plus awareness. So look at 100 or let's say 150 per 100,000 population, and we are still talking about awareness in the adult world. And look at a setting where I have only 10 per 100,000. Where will the awareness come through? So it means we have a long way to go to reach pediatric strokes and actually offer the same treatment that we can offer for adults. So clinical evaluation almost the same. So what we are actually interested is the timing of the episode, look for cardiac disease, look for sports injury, a common cause in pediatric work, cardiac and monitoring the signs of raised ICT. So these are the clinical markers that will tell us which vasculopathy we are looking for. So I would probably not go into that. So how do we go ahead? We confirm the stroke by neuroimaging plus vascular imaging, very important, not to miss out on stroke mimics. And we formulate our investigations based on the etiology. So the list of tests actually just keep on going on, but what we are interested is now doing something which we also, the management protocols remain more or less the same. The investigations, yes, etiology based, thrombophilias, sickle cell disease, they actually come higher up on the list. So thrombolysis advises caution, thrombectomy again with caution, and we follow the same rule, aspirin, clopidogrel, low molecular weight heparin in special situations like dissection. Earlier it was low molecular weight heparin, but now we are also following the same rule of dual antiplatelets, and they give the same results even for dissection. So even the role of heparin is actually reducing. So maybe venous sinus infarct, yes, you would. So thrombectomy, again we're doing the LVO or the Vance score, and we look at the complications as well. So I'll show you one case. Okay, so what we are seeing here is, now you'll see that, okay, this is the area which is, we are talking about an infarct. This is a DWI image. Probably here you can see that there was a slight narrowing there. You can see the vessels here, but you cannot see the vessels. Small white spots are emerging, so you cannot see them very clearly on this side. This is the flare. So the flare is showing a mismatch. Here you would probably appreciate the vessels more clearly. ICA. Okay, so here you are seeing the vessels here you are not. So you can see the cluster of vessels here, nothing on the left side. So this is someone who probably you can. So this is the person we thrombolized. So sorry, I'm just showing you the CT scan first. It sort of played that way. So this is the thrombolysis, post-thrombolysis CT scan, 24 hours later. And this is what, so you'll have to take my word for it. So if you can see, now focus on the vessels here, and then you can actually now start seeing some vessels on this side as well. Yes, of course, there are areas which are bare, but the artery has recanalized. So you need not actually demonstrate the entire opening of the MCA. Even the vessels, once that is done, it means that recanalization has taken place. So this is a 9-year-old kid. So 9-year-old kid can also be thrombolized, and it is just we are trying to extrapolate the guidelines towards the children. So for, like I was working for some time at MGM Medical College, and we have done actually in double digits now, like 15, 20 thrombolysis even in pediatric cases. So the same rules apply, the same game can be played even in the pediatric world. Okay, so the complications. So yes, decompressive craniectomy. So I'm just showing you how and when do we really intervene. So this is a CT scan. You're trying to draw this line, okay? You're seeing that there is this subfalcine herniation. You can see the ventricle here. You can see the caudate being pushed and crossing this midline. This is the area of the infarct. So this girl actually required decompressive craniectomy. And yes, we look at how does this help, and the question was that do we really improve the outcome? Now, I saw her last week. So this was done in 2010, and now she's 15 years beyond that. She's now 23, and she's actually using her right hand very well, functionally. So in a pediatric setup, all these complications also can be dealt, and the outcome is far superior compared to adults. Okay, so I'm just showing the bleed, which is also possible, and this is someone which we picked up. And what you can see, this is our Apollo patient only, and you can see these blood vessels. Okay, so this is an AV malformation. So 50% of bleeds. So etiology for bleeding, malformations, look at the blood, which means bleeding diathesis, look at injury, traumatic bleeds, and of course hypertension and bleeding within a brain tumor. So those are the hemorrhagic. So incidence around about 8 per 100,000 maximally. Remember, be fast plus the S because of the seizures. Think hard before you thrombolize because of the stroke mimics in a higher proportion in pediatric world. treatment paradigms are similar when we look at ischemic strokes. Hemorrhagic strokes, etiology-based treatment, yes. AVMs, you will do the same principle as you would do for the adult. And with respect to pediatric strokes, long-term outcome is almost similar, but in practice, probably far better compared to the adults. Thank you. Even adults.
Of course, adults too.
Not all strokes arise from conventional risk factors such as diabetes, hypertension, and dyslipidemia. A significant proportion result from atypical or less common causes, and recognizing these is essential for accurate diagnosis and targeted management. To take us through this atypical etiology, I invite our next speaker, Dr. Pradeep Tiwari, sir.
Good afternoon, everyone. First of all, let me thank Dr. Vishal sir for giving me this opportunity to talk about stroke risk associations. So I slightly changed the topic because we are trying to understand very rare causes, but I think it is very important to first understand very common causes of stroke and how are we going to fix it, right? What are the guidelines in controlling the blood pressure and controlling the sugar levels? Because still, if you take the typical causes of stroke, they still cover up more than 90-95% of all strokes. We will be touching about the atypical causes also, but most of them are non-modifiable. So let's see. Okay, so basically when we classify, we look at the risk factor for stroke as non-modifiable and modifiable. Non-modifiable is genetics, age, gender, race. So you can't do a lot about it, right? You are born with it. And modifiable risk factors are one that you can actually control: the hypertension, atrial fibrillation, diabetes mellitus, dyslipidemia, obesity, smoking, excess of alcohol consumption, and so on. So let me first tell you about the age. So as per AHA, the mean age incidence of stroke is around 69.2 years, telling you that probably this is definitely a disorder of old age, right? But then recently there has been an increasing prevalence of stroke in age of 20 to 54 years old. Especially after COVID, we have been seeing that a lot. Again, a lot of people ask why. Is the COVID vaccine responsible? Is the COVID responsible? As of now, there is no good theory to suggest that. But one thing is definite that lifestyle has definitely changed a lot after COVID. And there has been a very stressful lifestyle. Suddenly when the economy has gone up, everybody wants to work a lot. Everybody is uncertain about the future. And that adds to the stress, anxiety, and the other things usually seep in. But the trial, for most people keep asking whether COVID is responsible. There was a recent trial in Sweden, let me tell you, that said that vaccination was actually protective. There was no adverse increased risk of any cardiovascular event with vaccine. So if people are, telling you again and again this is more political agenda, then none of that is related to science, okay? So again, sex, obviously you might find it very difficult to hear, but female are more prone to having stroke. Lifetime risk of having stroke is more in females as compared to males. This is because of probably, when you take the younger strokes, females are on a higher side. When you take the old strokes, males are usually on a higher side. But overall, if you see, because of a larger lifespan, females are at overall more risk of stroke as compared to men, right? Indian context is slightly different. In India, the mean prevalence of age is around 63 years, which is much lower than that of the Western population. Also, in India, male was more predominant to getting strokes as compared to female. There have been certain races which have been predisposed to getting strokes, especially the blacks are at more risk of having hemorrhagic strokes and ischemic strokes as compared to the Caucasians. Hispanics, Latin Americans are also at increased risk of stroke. American Indians again was found to have more. Even in America, the Indian population is the one which is with more risk of stroke as compared to the Native Americans and the Caucasians. Genetic factors, lot of genetic factors can actually contribute to this. A big list of what all genetic factors can. I will just show you the slide. Certain important ones that definitely you need to know is this Notch3 gene mutation, which is responsible for something known as CADASIL. A lot of times, once I had 2-3 patients of cerebral amyloid angiopathy also, and there are certain MRI features that you can see. Most importantly, you need to know that in CADASIL there is an leukoencephalopathy, there is migraines, patient can have psychiatric manifestations, and dementia. Similarly, there is CARASIL, which is a non-dominant version, autosomal recessive version. So Notch3 gene is responsible for the CADASIL, but HTRA1 gene is what is responsible for the CARASIL. Then familial amyloid angiopathy, right? Normally a lot of them have a secondary amyloid angiopathy due to hypertension and diabetes, but then a certain amount of patients you will see there's no risk factors, but you will definitely find a lot of microbleeds in the brain. There is lobar hemorrhage, the white leukoariosis, the leukoencephalopathy, you can see dementia. So those patients are probably those who are suffering from the amyloid angiopathy. There's an autosomal dominant pattern of inheritance, and APP beta gene is what is responsible for that. COL4 gene, COL4A1 gene, again responsible for abnormal vascular formation, and their patients are usually at a risk of intracranial aneurysm, hematuria, cystic kidney disease, again associated with ADPKD and disorders also. LS-DAN loss is again a collagen, basically collagen type of malformation. Again, they are at predisposed risk of aneurysms, pseudoaneurysms, ruptures. Fabry's disease is again an X-linked disorder. You will commonly find angiokeratomas in these patients, very classical. Cataracts, neuropathy, and acroparesthesias, areas of less sweating on the skin, renal failure, all this can be a feature of Fabry's disease. Marfan syndrome, again a thing that we see in as a genetic disorder because fibrillin-1 gene is mutated. This is an autosomal dominant pattern. They are at risk of atrial dissection and cardiac embolisms. MELAS is yet another very important differential when you look at the stroke mimics. So it's a mitochondrial encephalopathy associated with lactic acidosis and stroke-like episodes. Mostly when you see a posterior area stroke and you are not, able to find out a cause to it, and you see the patient have a reversibility, there is some amount of renal impairment, probably you may think about MELAS. I had a chance to see 1 or 2 cases of MELAS during my residency at MAMC, but in real practice I have not found a case of MELAS as of now. Sickle cell disease, again, very important risk factor because sickle cell is there are clots that form in the arteries, capillaries. The patients are always at a risk of large as well as small vessel disease. And smooth muscle actin-4 gene mutation associated with Moya-Moya syndrome. Moya-Moya syndrome is again a very common, you will see there is a proximal carotid stenosis and there is a large amount of collaterals, classically giving a smoke puff appearance in the angio. So those patients are also genetic predisposing factors for stroke. These are other kinds of gene disorders. We can look over. Now coming on to the classical risk factors, hypertension by far is the most important stroke risk factor. And 50% of all strokes are basically attributable to hypertension. And blood pressure is basically classically beyond 160/90 is at a very attributable risk. Now, there was a lot of meta-analysis that was done here. I would make it very short. There's a detailed evaluation of meta-analysis, but the main point I would like you to know is, there are, in patients who are beyond 50 years, this is important. There was a large study done on around 10,000 patients, patients beyond 50 years of age, who had a pressure of more than 130 100 systolic blood pressure. They subjected into 2 groups. One is an intensive group where the BP was brought down below 120 and to a less aggressive group where BP was brought down to less than 140. What they found was definitely the arm which blood pressure less than 120 had a lower risk of stroke. This is very important. So when you are dealing with a stroke patient, blood pressure, be aggressive. That's the line. Blood pressure, be aggressive. Also, the second important thing that came out with this trials was that, not only the pressure, but fluctuation in pressure. Fluctuations in pressure. is also a very important risk factor for stroke. So this was a trial. You can see the data importantly, but most importantly, so when you are targeting stroke prevention, you want to give them an antihypertensive. It is said that you prefer CCBs. I usually prefer Silacar, mostly the calcium channel blocker family, because it is found that the fluctuations are less with use of CCBs, right? The cardiologist may say otherwise, but for stroke, that is what has been found to be more efficacious. So it always happens. I will write down Silacar, the cardiologist will come and write down telmisartan. So it keeps happening, but usually CCB is slightly better on the stroke risk panel. Now, diabetes mellitus is again a very important risk factor, and more than 20% of all deaths in diabetes is actually attributable to stroke, right? Definitely there is an increased risk that is obviously found. Younger patients have at more risk of getting stroke. But one very important thing that I would tell you, that they did a trial, just like BP, they did a trial in diabetes where they did a very intensive sugar control of HbA1c less than 6, and the other group where they liberalized it to 7 to 7.9%, and they found that actually 7 to 7.59%, the liberal group actually did better than the intensive group. So that is the target, and the trial said that pioglitazone was probably slightly better in controlling strokes. Although this is again subject to different studies are showing different data, but in this study they definitely found pioglitazone as again cardiologist will come and say ki cardiac edema badhega, load badhega. Completely okay with them, let them decide. But then the trial said that pioglitazone may be slightly better. So that is the take-home message, that BP, be aggressive. Diabetes, allow liberalization. That is very important. Take-home message that you need to carry. So this was again same thing. Atrial fibrillation, again, Yatin has already talked about it. I want you to know that not only atrial fibrillation, right? Even SVT was found with an increased risk of stroke. So this is very important. Not only that, patients with high pro-BNP, independent risk factor for stroke. So you need to know all this, because everybody knows about AF, but then even SVT and this was found to be a risk factor. Not only that, the trial carefully studied the ECG patterns, and they found that if there was abnormality of P wave on lead 1, V1, which reflects the left atrial contractility, this was associated with independent risk factor despite of being AF. The patient may not have AF, but still there's a chance of stroke. If that happens, a lot of time you get a stroke patient, you ask them to do an echo, they say dilated LA, but there's no AF. I would still take it very importantly as a risk factor, right? And I would definitely prefer anticoagulation in these patients, but then it's again, okay. And we already, I think, talked about it. The dabigatran is definitely, the apixabans and all are shown to have a better outcomes as compared to warfarin. This is important, the CHADS2-VASc scoring system that is commonly applied. So congestive heart failure 1 point, hypertension 1 point, age 2 points, diabetes 1 point, history of stroke or TI is a 2-pointer, vascular disease is 1 pointer, age 65 to 74 is a 1 pointer, beyond. So female is again 1 pointer. So you need to know all this CHADS2-VASc, and if you apply this, the risk stratification for atrial fibrillation, definitely anticoagulation needs to be preferred. Okay, now coming on to dyslipidemia. Dyslipidemia is definitely a risk factor. There was a relationship. The cholesterol, high cholesterol associated with stroke, but triglyceride was not associated with stroke. So this is what you need to know. There have been certain recent studies which are telling the otherwise, that cholesterol probably is not at all related to stroke. But then as of now, statin therapy definitely prevents you from stroke. So a lot of times patient ask, sir, mera to cholesterol normal hai, aapne statin kyun diya mujhe? Because they just Google up and said statin can cause myoglobinuria, statin can cause this. Statin still prevents stroke despite the cholesterol levels, because it not only controls the cholesterol level, what it does is a pleiotropic effect. It prevents the LDL oxidation of cholesterol, disallowing the cholesterol to get deposited inside the vessels. And there is what statins actually help. Despite having a normal cholesterol level also, we do give statins in prophylaxis of stroke, no doubt about it. Okay. And now this is all about statin. Carotid artery stenosis. Carotid artery stenosis, there is a lot of complicated data, but I would like you to summarize the whole thing in short. That is, if there is a symptomatic extracranial stenosis, you need to do the stenting for the patient. You need to do the stenting of the patient. Certain data says that if it is beyond 70% extracranial stenosis, go for stenting, very high risk of stroke. But intracranial stenosis, mind my words, extracranial stenosis, intracranial stenosis. Extracranial stenosis, go for stenting. Even if it's asymptomatic, more than 70% occlusion, you should opt for stenting. But this is not same for intracranial stenosis. If there's an intracranial stenosis which is asymptomatic, don't push the patient for stenting. That is what the data says. Because I have seen a lot of time patients come कि sir वो narrowing of M1, M2 segment आया है और डॉक्टर ने बोला इसका stenting करो, जबकि it was an incidental finding. There was no stroke. He apparently was getting the MRI done for migraine. Right? So intracranial, mind my words, extracranial stenosis, intracranial stenosis. Extracranial, high risk of stroke. If there is a symptomatic, there was a stroke, go ahead with stenting. If you find asymptomatic extracranial stenosis beyond 70%, go for stenting. But intracranial stenosis, if it is beyond 70%, symptomatic, go ahead with the stenting. If it is not symptomatic, don't go ahead with stenting. If it is less than 70% symptomatic also, you may opt for medical therapy management. Okay, diet and physical activity. Definitely Mediterranean diet is a diet which is rich in fruits, vegetables. You should stick to that. Definitely they have found to have a lower risk of stroke. Salt intake was again associated with increased risk of stroke. So consuming papad, achar. Diet में क्या खाएं sir? मैं बोलता हूँ single line. Papad, achar, chutney, bun. High salt intake is associated with increased risk of stroke. So this was a study they did. They basically did something known as metabolic equivalents, where they classified the activities of daily living into metabolic equivalents. How much energy does patient burn in during those activities? So a high metabolic equivalent was basically high physical activity. So they found out that physically inactive individuals, less than 600 meta-equivalent minutes per week, and those who had high activity, more than 8,000 meta-equivalents per week, for around 2 hours daily vigorous activity, they have 25 to 30% lower risk of stroke. This is very important. As equivalent to a statin or probably aspirin. Think about it. So again, a very important thing. Next, obesity. Definitely obesity has an increased risk of stroke. Waist-hip ratio was a major risk factor accountable for this. And alcohol consumption, there's a J-shaped curve. Mild, light to moderate alcohol consumption, which nobody does actually, is slightly protective for stroke. Less than 2 drinks in men, less than 1 drink per day in women. But more than that, there was increased risk of ischemic stroke. And alcohol consumption has a direct relation with hemorrhagic stroke. Okay? Smoking and drugs, definitely cocaine, heroin, amphetamines, ecstasy, all these are associated with ischemic as well as hemorrhagic strokes. I have patients who are, they go to gym, wear a very nice body, and I have now seen almost like 8 to 9 such patients, and most of them were consuming some kind of protein for building their body. I don't know, probably creatinine or nanzolone was there. They all were getting stroke. Sir, मैं तो इतना fit रहता हूँ sir, मेरे को क्यों हो गया stroke? ठीक है. Next, inflammation and infection. Definitely, inflammation was associated with increased risk of stroke. C-reactive protein was an independent risk factor, and HSCRP definitely, just like cardiologists have said, there's association with cardiac outcomes. It definitely has association with neuronal outcome as well. Inflammation in any form can give rise to stroke. We have seen strokes now after COVID with influenza, with ongoing fever, because fever is, when you have inflammation, there's a widespread systemic inflammation. And at times I have seen even the infection causes vasculitis and patients have stroke. So when the infection recovers, probably patient recovers. There have been vasculitic cases, like even the virus can, simple influenza viruses can cause vasculitis and can predispose to stroke. Okay. Newer risk factors, homocysteine is no doubt very important risk factor in stroke. So, but homocysteine, the problem is whenever we are screening for a stroke, like primary screening, most of us usually don't do. But when the stroke happens and we send a homocysteine is also an acute phase reactant. You may find an elevated level of homocysteine during an active stroke. May not be hyperhomocysteinemia. But definitely MTHFR gene mutation is very common in Asia. So always we see homocheck is on their list, or even a high dose B12 folic acid is always on the list of medications. Lipoprotein small a2, again, it is seen that lipoprotein A2 has a higher oxidation ratio, so it gets oxidized and gets deposited inside the vessels very easily. PLA2G7 gene is again responsible for this, and this is definitely a risk factor for stroke. Thank you.
Thank you, Dr. Pratik. There is slight change in program. Extremely sorry for the delay. Actually, we are running a bit late and it's lunchtime also. So slight modification I am doing. Extremely sorry, chairpersons and speakers. So now we'll take a panel discussion. After that, we'll take lunch break and we'll again gather together and we'll finish the program after some time. So I will thank you, the chairpersons. I will continue. Sorry for the this change in the program. I would like to call our panelist, panel discussion on management of stroke in real world scenario. So I would like to call on stage Dr. Ajay Kukreja sir, Dr. Sanjay Khare sir, Dr. Shekhar Patil sir, Dr. Patsalge sir supposed to join, somehow he could not come. Okay. So our panelists don't need any introduction. Sanjay sir, Khare sir, is a senior physician and in Apollo Hospital. Patsalge sir supposed to be there, not here. Ajay sir nahi hai. Dr. Ajay Kukreja sir है क्या? Call okay. Bahar hai? Okay. He will join. Meanwhile, we'll start with the discussion. So as we have discussed about ischemic stroke, it is too much stroke. So let's see its practical implication. A lot of problems we face when we take a stroke. We treat them, and actually the stroke is not only one-time treatment. They need hospitalization, they need recovery, and also they need lot of things to prevent, because first of all, why they got a stroke? There is some reason for the stroke. So we need to address those problems in the patients. So how our physicians, they do deal in the real world situation. So I will ask Ajay sir, first question. So which imaging modality you prefer whenever a person, a patient with acute stroke comes, which imaging modality you prefer in real world situation? We have liberty to everything, perfusion, everything. So what do you prefer?
If, sir, as you said, if we have basically if we go with the guidelines, then if we consider all the settings, then including the periphery, including the city, CT scan, and if just to rule out if there's a hemorrhage or not. If there's no hemorrhage, we immediately do a CT angio in the same sitting, so that if we get a thrombus in the artery, we can go ahead with the planning. But as sir said, like we have stroke protocols in our hospitals, we have stroke codes. If you have an imaging modality, what we follow MR stroke protocol in our hospitals, because we have the ability to do the MRI very quickly. We just take a few sections, we do diffusion weighted, and we get the idea, and we go ahead with the thrombolysis, because we get a penumbra we also get the how big is the penumbra, because that way we can increase the window period also, if at all in select patients. So MR diffusion weighted, along with later on we can plan the CT angio related benefits, but at least for immediate thrombolysis, if we have a good stroke protocol, then we can do an MR diffusion weighted and go ahead. But considering other centers, CT angio, maybe, depends. So it is very center specific.
Okay, thank you, sir. Actually, we have liberty to do everything right from perfusion middle of the night. So
Yeah.
it is not possible every time.
Yeah.
So now I will ask Shekhar sir. There are a lot of stroke mimics. Middle of the night, we get a patient having a patient with NIHS. First, we have to see whether it is stroke or not. So how do you approach a stroke mimic in emergency setting? And what are the strategy to avoid unnecessary treatment of such patients?
Yes, so first thing is actually look at the common causes. So hypoglycemia, hyponatremia, even hyperglycemia per se, you can have a setting. So you would probably look at the metabolic parameters, calcium, magnesium, and look at your MRI. So in a setting where you are thinking that this could be a stroke mimic, you will have to confirm it by a better modality than just a normal CT scan.
Yes, sir.
Then you should be showing an abnormality on a DWI, ADC, and matching and comparing in all the sequences. So we do a limited stroke protocol, but even there you will have to choose the patient and then do formal imaging or complete it the following day. So you do the confirmation and then you can proceed with the treatment.
And suppose a person with a posterior circulation stroke comes. We know it is a stroke, but MRI don't show anything.
Yeah, so this is a common setting. So we also need to understand the limitations of the MRI. So if you strongly consider that, then it's commonly seen with vertebrobasilar insufficiency, as we used to label them. But we're talking about someone who has a persistent vertigo and is probably throwing up, vomiting, and you're not showing those. So you can actually increase the B value of the DWI imaging. You can do a coronal one sequence on the DWI and try and look for whether you can pick up something in the posterior circulation. You can also probably, this will be like a later on thing. So maybe you still think that, okay, I'm not being able to thrombolize him, but I would still want to confirm it. Then the next day you probably repeat it again. But at the middle of the night, probably asking for a better B value and a coronal sequence can help you decide on the acuteness.
Yes, sir. So we are actually doing that, and sometimes day 1 MRI remains normal in posterior circulation. Day 2, day 3 MRI shows something. So we repeat in such patients. So now, after acute management, I will ask Karis sir. Sir is more into the lifestyle management apart from all these things. So, sir, what are the practical challenges, especially in real world when you practice in your clinic, not in Apollo, in your clinic, with integrating lifestyle intervention and patient education and controlling their risk factor like hypertension type? How will you tackle? Because I saw your patients, they are very particular. So sometimes next month sir का appointment है तब जाना है उसके बाद ही हम आ पाएंगे because so how do you manage all these things?
I'm an absolute Hitler. So, there's no denying the fact. So before we start into the things, so this is the second Vishal Shikhar partnership, guys. So first Vishal partnership and Shikhar partnership is in those music directors, and this is the second one. And the second point I would like to make is every time I send my patients to either of you, they come back with notes. I'm so envious about Shekhar's handwriting. Yeah. This guy's got amazing handwriting, something which I always envy. So anyway, so the thing is, as physicians, we should all be asking ourselves, can I do something which is better, which can improve my patient's lifestyle? And yes, so I was just going through Shekhar's presentation. He's shown those 5 red balls, about adults having more problems with stroke. Almost every of those 5 balls, if you trace them, they all relate to obesity or with increased BMI. Is that not so? So hypertension, dyslipidemia and all that. So the first thing is we physicians, we should ask ourselves, am I doing enough? Is my patient's blood pressure really under optimum control? Is my patient's sugar under good control? Are the lipids fine? What about the uric acid? What about thyroid? What about lipids? What about hemoglobin? Am I really doing enough? Because when I keep telling my patients that there is nothing called slightly pregnant. Either a girl is pregnant or she's not pregnant. Simple. In the same way, either a person is a hypertensive or he's not a hypertensive. So if my current guidelines, and Mahesh will correct me if I'm wrong, the Indian guidelines are the blood pressure should be 140/90. If it's about 150, thoda sa blood pressure, ignore it, they're all a load of bullshit. It has to be 140 or below. Patient's HbA1c has to be below 7. The lipids LDL has to be below 100 or 70 if there's a secondary prevention. I cannot accept a hemoglobin which is less than 13 or triglycerides which are less than 340. Uric acid, us physicians, we really ignore uric acid. And as per the latest recommendations, uric acid in Indian people with pro-stroke settings ought to be below 6.6. And surprisingly, it is allopurinol which helps better than febuxostat. So if I am doing all these things for my patient, then Vishal, I'll say that I have discharged my duty properly as a physician. And I'm very sure that if I really have a diligent control over all these metabolic factors, people will probably have less affliction to obesity and come knocking at your doors. Am I right? Am I wrong?
Yes, you are right, sir. And again, one acute question to sir. So you diagnose, as you mentioned, we do CT scan and all aware. So suppose you diagnose a patient, you are not in hospital, and you want to thrombolize. So what you do? So where you are one of the patient, they get CT scan done, you manage, you get a CT scan done, no, there is a stroke, and he's a window period. So what are the challenges you face in thrombolizing such patient? You are not in hospital, you are not in hospital. Like we are full timers, we are in Apollo. Somebody will take care. We are there. So how do you handle such
Understood.
situations?
So this starts from so for getting a good thrombolysis, for getting that success, all the everything should be ticked. Everything should happen in a sequence. Only then you get a good result. So the sequence is a number of things that happen from the patient thinking about whether it's a stroke or not at home, because they are in denial. Now that you gave me that the patient has already been diagnosed with a CT scan, and the patient has already done a CT scan, but the patient should get an ambulance to reach early. And as soon as the patient reaches the hospital, we have to follow the stroke protocol, announce a code stroke. Now, I think very few hospitals have a code stroke. If the patient is going to a nursing home, then they will be referred from the nursing home to the hospital. That takes another half an hour to 1 hour. So we are losing on the window period there. So one is probably awareness, more awareness about creating more awareness about the stroke part itself. Now people are getting more and more aware. Second is availability. Like you call Apollo ambulance, it comes fast, but that is not how it is outside. And similarly, having a code stroke and following the code stroke. Like many of our hospitals also have code stroke, but it is not followed in the same way. So following the code stroke properly, and then the MRI happening, whatever, the CT, the MRI happening, and the neurologist seeing and advising what is to be done. All these have to fall in a sequence to get a good thrombolysis. That is how it is. So all these are hindrances when it comes. Now we have less problem of the patient agreeing to thrombolysis because they are more aware post-COVID. Otherwise, we have to convince the patient, we have to give you this medicine. They ask 10 questions. The cost is the biggest factor. But all these hindrances are there.
Yes, sir. Actually, stroke ready hospital concept should come, and it should be actually like heart PAMI. Even patients know that PAMI has to be done.
Yeah.
They come that nahi, PAMI karna hai. So stroke we still somewhere
we
we
should
are
have a
lacking
stroke
the
unit,
awareness
a
and
specific-
infrastructure also.
Yes.
So stroke ready hospital should
Yeah.
be increased. So, sir, now we have seen lot of newer molecules and all. So now GLP-1 agonist. So I have a question for both of you. What is your take on GLP agonist?
It's a wonderful drug. They are wonderful group of drugs. Primarily they act on obesity. But as sir said, if you ask us, the root cause for everything is obesity. It's a disease. We consider it as a disease. And we didn't have any weaponry to deal with it till now. But now GLP analogs are wonderful. When obesity comes down, all the other things come down. If we have studies which show that even the stroke risk significantly comes down, almost around 14% when we start on GLP analogs. Along with cardiac benefits, along with renal benefits, even if the patient is a non-diabetic, we are talking about a non-diabetic stroke patient, there are benefits for stroke. So obesity, if it is there, we have to treat it. So that is where GLP analogs come in play, and it is something that cannot be missed. You have to, it is the other way around also now, right, left, center, we are using GLP analogs. I write it at least 2 in a day. So, but you have to be aware of the contraindications of pancreatitis, ischemic neuritis, and psychiatric disorders, which we miss on. But otherwise, they are wonderful drugs.
Sir, what is your take on GLP-1 agonist?
So, putting it very simply, this drug was brought in as an anti-diabetic medication. Then people started finding out it has a lot of anti-obesity potential, and now things are so beautiful, Vishal, that actually there is a tremendous amount of neurological betterments after using these molecules, all unintended. People never even realize that there are going to be so much neurological improvements. So at this point of time, even as we are speaking, there has been huge amounts of data which actually show that GLP-1 analogs, whether it is semaglutide or tirzepatide, which are in use actually, not only do they reduce obesity, they also reduce the sugars, the lipids, the blood pressure, and a lot of anti-inflammatory properties are something which we just don't think about. These molecules basically work by anti-inflammatory mechanisms. We have had patients whose psoriasis has gone away, rheumatoid arthritis, the drug requirements have gone away, hypothyroidism doses have come down. So then people started wondering whether there are additional benefits or not, and now at this point of time, there is humongous data which actually show that these molecules are found to be of tremendous benefit in Parkinsonism, Alzheimer's disease, dementia, migraine. Not only that, there has just about 72 hours ago, there was a journal, neurology, there's a publication in neurology which said that epilepsy has found to be of tremendous benefit in using this. The potential comes down. More importantly, these molecules, they also reduce the stroke outcomes, because in fact it has been published in AIJCA, Indian Journal of Anesthesia. So in which there has been shown that even in a non-diabetic person and obese person, if you give these molecules, the incidences of strokes have come down by 27 to 29%. So how do these molecules work? Because GLP receptors are not only in the adipose tissue and the skeletal tissue, they are dispersed all throughout the body, particularly in the brain. So what they do is basically they reduce the inflammation, they reduce the apoptosis, they increase the neurogenesis, they reduce the amyloid tangles inside the neurons, they reduce the Ta and the Tau and the Ra proteins, which are supposed to be anti-inflammatory. They have a tremendous role in neuroprotection and by reduction, by improving the adipocyte function. How do they work? They work at the level of pericytes. Pericytes are around the vascular endothelium. And vessels kahan pe? They are there everywhere in your body. So especially at the blood-brain barrier, these pericytes are activated because of GLP analogs. And that's why you get a huge amounts of benefits. If I'm not mistaken, in the next 1 decade, it will emerge that GLP analogs will be having tremendous role in either prevention or treatment or PARC and dementia.
Yes, sir, you are very true, because we are seeing, sir, a lot of trials are coming in neurology, also in stroke prevention. That's why I deliberately included this question for a discussion. Now I have a question for...
so after 3 months, the patent of these drugs is getting over.
Now they must be costly,
semaglutide.
yeah. Okay.
So yeah, so the cost will come down to maybe around 4,000 a month. So you will see many obese people suddenly getting thin all over your surroundings and neighborhoods.
Now for Shekhar sir, I have a question. So in practice, we see prescriptions where a lot of neuroprotective agents are advised, like citicoline, paracetam, then now sovaltide. So I just want to ask cerebroprotein and so many drugs. So what is your take, Shekhar sir, in acute, actually a stroke management, stroke management, how they help?
So pre-96 era, when we had nothing much to offer, this is what we were offering at that time. So it's primarily more of a hope than really actually seeing a benefit. But when we look at the new medicine now, sovaltide, so that is slightly different. So here you do have trials to show that there is benefit. So it works on the same, like it's an endothelin receptor and agonist. So what it will do is actually have reduction in the inflammation. It probably will have reduced apoptosis. So it will probably remit the infarct. That's the mechanism of the drug. And you have to use it as an injectable. Boluses is what we do. And if you really compare their outcome at the end of, so sometimes in gangliocapsular infarcts, which we have seen together, we do see that by the time they're ready to go home, the degree of improvement is actually better than what we would have expected and not thrombolyzed. So post thrombolysis, if I were to give an offer something, at the moment that's probably the best that I can offer. I'm not saying that's really good, but that's the only thing that I can offer. The other ones, purely from the prescription perspective, definitely no proven benefit.
Okay, that's true. I have a lot of questions, but I think we'll restrict here. I will also, in our audiences, suppose anybody you want to ask any question to our panelists, you can ask. Otherwise, sir, for you, sir, for obesity, what do you recommend? A person, obese stroke patient, comes to you, how do you manage him? Counsel him, that is more important, and then how to...
So first is get my priorities right. We Indians fare particularly badly because we have a condition called TOFI, in which we are thin outside but fat inside. So compared to a Caucasian, let's say a Polish person, he looks huge. He's all muscle, right? Whereas over here, we may be appearing thin, but we are all fat inside. So actually, if you see the BCA analysis, we have got tremendous amounts of obesity. So the first thing is, don't consider a person as non-obese just at the look. He may be obese actually. And as just somebody said, we Indians fare very badly as far as metabolic disorders are concerned. Our ability to fight ischemic heart disease is very poor. We are immediately prone to kidney diseases, malignancies and all that. So obesity is something which should be taken very seriously. That's the first message. Second is, of course, you see what is the amount of liability involved. Is this guy already having arthritis or sleep apnea or ischemic heart disease or strokes or diabetes? I'll have to be very aggressive with the person. I and Nitin, we are running this program in Apollo, and which is a multi-team directional program. So the person is enrolled into that program. And then depending upon the layers of his affliction, I decide whether to put him on GLP analogs, when to do the SIA, obstructive sleep apnea test. So there's a whole hierarchy to it. Pharmacotherapy, we are in our infancy at this point of time, but let me tell you, in the next 10 years, this is going to be the decade of metabolic medicine. I'm telling you right now, you guys. Pharma industry all over the world is coming out with molecules left, right and center. So right now we have semaglutide, we have tirzepatide. In another 6 months, we are going to have an oral GLP analog called oporlifron, which is by Lilly. We are going to have retatripide, which is a triple drug analog. And we have now probably Mesmer, which is going to be once a month shot. We have another molecule which not only decreases the adiposity, it stimulates the skeletal muscle. So all these are wonderful molecules in the future. We are going to have monoclonal antibodies against obesity. So the next decade is going to be metabolic medicine and anti-obesity medications.
Yes, that's true. It's actually epidemic of sedentary lifestyle and all these things. Okay, thank you, panelists. Any question?
One thing, every time you want a weight loss is not only going to be adipose tissue. So when you lose 10 kilos of your body weight, about 8.5 kilograms is adipose tissue, 1.5 kilograms is going to be skeletal muscle loss. You have to accept it. At the same time, you can do with it, because every time I put my patients on GLP analogs, I make it a point to tell that Charlie to exercise. That helps. High protein intake, that helps. So at that particular leverage, if the patient loses weight, it's not really much of a problem. I don't see too much of sarcopenic. There is hair loss, by the way. Most people don't realize that after using GLP analogs, along with weight loss, the person is going to lose hair also. But even that hair loss comes back under control after a couple of years, a couple of months or something. Add something?
To our patients, when we start on these medicines, at least I add a protein powder because it is expected. But these companies, when they show the data, they tell us that when they have studied, there is something called as lean body mass, there's something called as fat mass. They have studied and shown that there is only fat mass reduction, there is no muscle reduction actually. But practically we see it, like you said, they get sagging. But like sir said, if you compare an Indian and a European, if I cut the arm of an Indian and if I cut the arm of a European, you will get a lot of muscle mass in a European. That's why they can digest alcohol well. But that is not the same with Indians. This is called as Yagnik-Yugvik phenomenon. We have Yagnik sir in Pune. He had done this study along with Dr. Yudvig in Russia. So the point is that sarcopenia will be there. You have to start the protein powder from the start and the patient should exercise. That is a compulsion. But the benefits far outweigh.
Questions? After you achieve a particular target of weight loss, do you reduce the dose, or if the patient opts out to stop the drug, will it recur obesity?
Yes. So it's a lifetime drug.
Would it be going with the low dose or same dose?
So it depends. If you have achieved your target dose, so there are certain patients like young people, 20-25-year-old, coming down from 100 kgs to 70 or 60 kgs. They are keeping their diet and exercise well. Even after stopping the drug, even after a year till now, they have not gained weight back. But depends on your lifestyle management. If the lifestyle is bad, it is going to come back. There is no doubt.
I would beg to differ. 100% this is a one-way street. before I start the patients on generic analogs, I make it a point to tell that guy that you are going on a one-way street. Please don't stop the medication. The minute you stop medications, you're going to regrow whatever loss you have accrued. So it's like this thing, I mean, do you stop your anti-thyroid medications or anti-diabetic medications or statins once you achieve a particular level? You can't. This is also the same thing, it's a drug. You can't stop reducing its release. You have to, it's a lifelong thing. People are going to regain. After bariatric surgery, people have regained obscene amounts of weight because they have not been able to follow up the lifestyle modification. So this is a drug, believe it. And you stop the drug, you are going to lose the benefits. So I make it a point to say no reduction in doses, no discontinuation, otherwise face your recurrence. There's no doubt. There's no doubt about it.
Thank you.
Okay. Thank you all. We'll take a lunch break and we'll gather maybe in 20 minutes. We'll try to finish as early as possible. Thank you for your understanding and patience. बता दिया वो अपना वो हाँ हाँ चल रहा है आप आए नहीं अभी नेक्स्ट टाइम अपन न्यूमरेटिक करेंगे पूरा करते Welcome back, everybody. I just want to invite again, please, we'll resuming the session. Please, Vaishali ma'am, Savita ma'am, and Parikh sir, please come on the dais. We are starting with our next session. The same session we are continuing. Cardiac evaluation of stroke by Dr. Mahesh sir. Mahesh sir is a senior interventional cardiologist practicing Apollo Hospital. He has his own clinic in Seawoods. And he has worked in multiple other hospitals also. So, sir, please come here.
I'll try to make it very short. Basically, whether it is coronary artery disease, peripheral vascular disease, or cerebrovascular disease is one spectrum. So, all risk factors, they overlap, whether it is hypertension, diabetes, smoking, physical inactivity, obesity, they all contribute to cerebrovascular disease. So whenever we encounter a patient with stroke or acute myocardial infarction or acute thrombosis, so it is one and same thing. The basic principles of management are same. Whether it is thrombus, we have to dissolve it or we have to take it out by either thrombectomy or thrombosuction. So why cardiac evaluation is important in patients with stroke? Basically, once we say it is cardiac source of embolism, the whole management changes very rapidly because the role of antiplatelets goes down. if there is thrombus in left ventricle or left atrial appendage, or the stroke is because of some embolus, the anticoagulation is must in such cases. There is very minimal role of antiplatelets. So there are trials whether we should give antiplatelets or anticoagulation. So anticoagulants are more effective when there is thrombosis. So basically, history is very important. Whenever patients come to you with stroke or any vascular event, so for as far as heart is concerned, we should ask for palpitations. So when palpitations are from lower chambers, like left ventricle or right ventricle, these are very prominent palpitations. But when it comes to the atria, whether it's atrial fibrillation, flutter, supraventricular tachycardia, majority of the patients, they say that I have got some flickering sensation in neck or supraclavicular region, or some sort of anxiety, feeling of transient giddiness. So palpitations are has got different varied presentations. History of syncope or pre-syncope in recent past, or say 5 years back, 10 years back, particularly in those patients who have conduction disturbances like bradycardia is very important. So whenever patients come to us in the emergency, what we get is a good 12-lead electrocardiogram is must. Good transthoracic echocardiography to look for obvious thrombus is very important. So as far as ECG is concerned, you should always look for active ischemia. Whether patient has associated STEMI, non-STEMI, such patients can present with stroke because of LV thrombus. So we need to rule it out. And most importantly, when it comes to the neurology, we should rule out atrial fibrillation. So whenever patients come to us, if atrial fibrillation is evident on ECG, well and good. If it is not there, we should get 24 to 72 hours Holter monitoring. Our protocol is we get 72 hours Holter monitoring in all patients. So those patients who didn't show abnormalities or atrial fibrillation even on extended Holter, we have got ILR, that is implantable loop recorders. We can put it in the subcutaneous space, and that can record the events for 4 to 4.5 years. So rarely we do ILRs. So this is typical Holter report. So we should see what is the indication for Holter. So typically we do Holters for syncope and pre-syncope. So we should look for the patient-triggered events. So typically patients say, I have got anxiety, fainting, blurry vision, dizziness. There are different parameters. So what we should look, heart rate, minimum heart rate, maximum heart rate, and average heart rate. So only two things we should look in are pause and atrial fibrillation. When pause is more than 2.5 seconds, that is what we call significant pause. If patient gives history of syncope or pre-syncope and there are pauses, we should advise permanent pacemaker implantation because this is preventable cause of death. And we should look for atrial fibrillation. There is one terminology called as atrial fibrillation burden. So ideally, we should get 28 days monitoring for AF burden to calculate. And if patient has got more than 5.5 hours atrial fibrillation daily, then it is significant. But it is practically not possible. What we see on 72 hours Holter, we just calculate the average time the patient is in atrial fibrillation. So any atrial fibrillation more than 2%, we tend to consider anticoagulation in such patients. So this was patient basically came to me in OPD with the episode of atrial fibrillation. Heart rate was 190. This patient was referred to Apollo Casualty. By the time he went to the emergency department, it reverted to sinus rhythm. Patient was sent home with anticoagulation. Day 3, patient called up that I have got blackout. And this patient came to the casualty, ECG repeated, it was normal. Again, patient sent home, but with Holter, 72 hours. And this was the 72 hours Holter monitoring. It has showed long pause, almost 7.5 seconds pause. So this patient had tachybrady syndrome. So elderly patients, we tend to anticipate these episodes of blackouts or giddiness or pre-syncope to the antihypertensive medications, particularly beta blockers or aging or some sort of hypertension related to antihypertensive medications. So we have to be very, very careful interpreting such patients. Always get Holter. This is correct. So this patient had tachybrady syndrome, long pause, and episodes of atrial fibrillation. We had implanted double chamber pacemaker for this patient. There are multiple scoring systems already discussed. So CHADS to VAS score system. So I will just tell you how management changes. Suppose a patient is there with atrial fibrillation, known atrial fibrillation. There are 3 types of atrial fibrillation. One is paroxysmal, typically resolves within 7 days, particularly within 24 hours. Persistent stays for more than 7 days, and permanent is patient is in atrial fibrillation throughout life. So suppose you have seen patient at the age of 60 years, 60-year male, hypertensive. The CHADS score is 1. The patient does not need any medications or anticoagulation. Suppose that patient is following with you and he becomes 65 years age. So now the score becomes 2 because 65 to 74 years age has got 1 CHADS score. So the management changes. This patient is at moderate risk of stroke due to atrial fibrillation, and we should consider anticoagulation in this patient. The same patient is following with you for 10 years and he becomes 75 years. Then this patient is a high risk of stroke because of atrial fibrillation, and we should definitely start anticoagulation in this patient. So all of us are practicing for many years. So we should change the practice with time. We should evaluate these patients differently. Just don't continue all. The same thing happens with the female. Females are always all females have 1 CHADS score because female gender itself is a risk factor. So apart from atrial fibrillation, what are the other causes of embolism? Particularly those patients who have got acute myocardial infarction, left ventricular thrombus is very common. Those patients who have got rheumatic heart disease or any sort of valvular heart disease, they have got left atrial or left atrial appendage thrombus. We have got many patients on dialysis or aging population. They are particularly patients with neurological disorders. They are admitted for for few weeks, and we put central lines. We get thrombosis in and around central lines or hemodialysis catheters. We should be very careful. Those patients who have got cardiomyopathy, whether it is dilated cardiomyopathy or hypertrophic cardiomyopathy. Dilated cardiomyopathy patients, even these patients don't have LV thrombi. There is terminology called smoke or foggy appearance in the left ventricle. So we call it as spontaneous echocontrast. These patients are also at high risk of embolism. Particularly important in as far as neurology is concerned is PFO. So on echo we see renal wall motion abnormality, left ventricular ejection fraction, valvular diseases, structural abnormality like ASD and PFO. So this patient had acute myocardial infarction previous, means it was basically had infarct couple of weeks back, and this presented with stroke, and this was the left ventricular thrombus. So PFO evaluation is very important, particularly in younger patients, because the management changes. If patient has a ROPE score of 10, then these patients benefit with PFO closure. So basically there is difference between PFO and atrial septal defect. PFO is basically there is no defect. There is ostium primum and ostium secundum. These two comes together, and there is a tunnel-like passage in between the ostium primum and ostium secundum. This is normality. Almost 25% of the population has got PFO. So the most important difference between PFO and ASD, when we utter the word PFO, it is right to left shunt. When patient gets into valsalva maneuver, the shunt is from right to left, as compared to the atrial septal defect, where shunt is from left atrium to the right atrium. So PFO patients are more likely to get stroke due to paradoxical embolism as compared to atrial septal defect patients. This is very important. So there is one, these are some patients. So whenever we are suspecting paradoxical embolism, particularly in young patients, always get transesophageal echo, because this is very difficult to see on transthoracic echo. So we should get bubble contrast for these patients. So this is this is one patient. This is typical bubble contrast. We can see the whole right atrium, right ventricle is filled with the bubbles, but left atrium, left ventricle is absolutely free from the bubbles. There are no bubbles. So this patient didn't have PFO. This is normality. So why normally we don't get this bubbles in the left system? Because these bubbles are broken down by the pulmonary capillaries, and we didn't get any sort of bubbles in the left side. This is another patient. Here we can see the moment we inject, we can see the bubbles in the left ventricle also. This patient had PFO. So ideally, we should get bubbles within either 1 or 2 cardiac cycles. The moment we see the bubbles in the right atrium and right ventricle, we should see the bubbles in the left atrium and left ventricle. Then only we can label it as a PFO. There is third DD. If patient gets bubbles in the right atrium and right ventricle, and after some time we get bubbles in the left atrium and left ventricle. So what will be the diagnosis in such cases? Anyone from the audience? Because these bubbles are broken down by pulmonary vasculature. So there has to be some defect in the pulmonary vasculature. So those patients who have got pulmonary AV malformations can get bubbles after 3 to 6 cycles. So this is the this interpretation of bubble contrast is very important, and bubble contrast itself can induce stroke. If we don't change the agitated saline very properly, that can form air embolism and that can cause stroke, massive strokes. So this is very important thing. So we got a rope, that is risk of paradoxical embolism score. When score is 10, there is almost 90% probability that stroke is because of PFO. So they have considered some risk factors. So young patient with ischemic stroke without any risk factor. Suppose 25-year male without any reason. He is non-hypertensive, non-diabetic, doesn't smoke, no prior history of TI or stroke, and he had stroke on imaging. So we have to see, so if patient is around say 25 years, the score is 10, and very, very high possibility that this patient had stroke because of PFO. The same scenario, the patient without any risk factors, documented stroke at the age of 35, the score becomes 9. The same patient, again, at the age of 45 years, without any risk factors, but documented TIA, the score becomes 8. So the important thing here is, those patients who have got PFO after 60 years, they doesn't benefit with PFO closure. Younger the patient, more is the benefit by PFO closure. So while considering PFO closure, we have to be very careful. Unless there is documented source of paradoxical embolism and patient is not very young, don't advise or don't go for PFO closure. There are meta-analysis of almost 16, 17 trials. It's of no use. So another important thing for LV thrombi is left atrial appendage thrombi. This patient had this large thrombus in the left atrial appendage. So basically, while interpreting left atrial appendage thrombus, we have to be very careful. So I have got one patient. He was diagnosed as left atrial appendage. He had thrombus, and he was put on some anticoagulation. Even after 3 months, this TE was repeated, and the patient didn't get any resolution of thrombus. So basically, we have got one ridge. We call it as commodoin ridge. That patient had commodoin ridge. It was not thrombus. It was wrongly labeled as thrombus. So you have to be very careful while interpreting at the LA appendage thrombus. There are multiple anatomies for LA appendage. Most common is this like finger-like projection. We call it as Wentz-Oak, or there are other like chicken wing, cactus, and cauliflower. So before labeling as LA appendage thrombus, we have to be very, very careful. If you are in doubt, you can go for CT or cardiac MRI before labeling these patients have LA appendage thrombus. Those patients who have got persistent thrombus in spite of anticoagulation, we can have left atrial appendage closure, that is Watchman device. Or those patients who have got repeated episodes of recurrent stroke and they are not candidates for anticoagulation. Even in these patients, we can consider LA appendage device closure. So there is very limited role of biomarkers per se atrial fibrillation patients. Atrial fibrillation itself is an independent risk factor for diastolic heart failure patients. So all atrial fibrillation patients, we should get NT-proBNP done, and that is also for monitoring. Such patients need diuretics for treatment of diastolic heart failure. And baseline troponin, just to rule out acute coronary syndrome, is important. There is very limited role of cardiac CT or MRI in such patients. This patient, young patient, had some doubt on the TE, whether it is thrombus or this was some cactus-like deformity. So we have done the MRI. It shows this lay appendix clot nicely. So if you are in doubt, just get a cardiac CT or cardiac MRI, but radiologist should be equally competent before labeling it as thrombus. So basically, whenever you get a patient with ischemic stroke, get ECG done, start this patient on monitor, that is, you admit the patient in ICU, get good transthoracic echo. Generally, these patients, neurologists tend to thrombolize, or they just load it with dual antiplatelet therapy and give heparin or LMWH. So don't rush for transesophageal echo, because that can induce trauma and can cause complication. Once patient is settled, after 24 hours, we can plan transesophageal echo. If there is embolic pattern in young patients, consider assessment for PFO. Bubble contrast is very important thing. And treatment should be tailored as per the cardiac source. And if patient has got atrial fibrillation, thrombolus or LV thrombus, anticoagulation is must. PFO closure, you have to be very careful. And obviously, we have to manage hypertension, diabetes, and lipids as per guidelines. All patients with stroke should get intensive lipid lowering agents. That is rosuvastatin 40 milligram or atorvastatin 80 milligram with combination of ezetimibe. Nowadays, combination therapy is must. And target should be for coronary only. For primary prevention, it should be less than 100 LDL. And for secondary prevention, it will be below 50 milligram per deciliter of LDL. Or those patients who have got recurrent stroke, it should be below 30. So it is very important. So hope your next young ischemic stroke patient will have got 72 hours Holter monitoring get done, PFO assessment done, and good transesophageal echo done. Thank you.
I'm sure all of us agree, a very crisp presentation, and for physicians beyond the regular Holter and echo, the PFO concept and following it up. Dr. Mahesh Gogre, thank you so much. Any questions? Call it close.
So atrial tachycardia, see, whenever you utter the word atrial fibrillation, it is never atrial fibrillation. It is atrial fibrillation flutter spectrum. So even tachycardia has got multifocal atrial tachycardia, while Dr. Tiwari has pointed out that P wave abnormalities in lead V1, that was basically atrial thing. So all patients with supraventricular tachycardia should be considered as atrial fibrillation for all practical purposes, because it is not possible to monitor all these patients. Ideally, we should have 28 days monitoring, which is clinically not possible, practically not possible.
Doctor, 3 days monitoring will not be suffice? 3 days monitoring, because we see many patients with premature atrial beats, premature ventricular beats, so sometimes some other arrhythmia.
So, sir, those patients who have got premature atrial complexes, they don't fall into category, or they are not candidates for anticoagulation. So,
no, I want to know from you how we can early diagnose atrial fibrillations in so-called asymptomatic patients who show ECG abnormalities. 3 days observation is better, or as you said?
Yeah, see, longer is better, sir. Longer is better. 3 days, generally our protocol at Apollo is we advise 72 hours Holter. But ideally we should get 7 days Holter monitoring.
Okay.
So longer is better. The yield is more.
Because most of the patients are asymptomatic. Unless we suspect, then only we can pick up.
Yes. Sir, all patients with ischemic stroke, we have to get Holter monitoring. This is dictum.
That is
Just one additional point, Dr. Gogre, with your permission. See, cardiac evaluation in a patient of stroke is not just to know the cause of stroke. Here we are already almost suspecting, most of us, that it is a thrombotic stroke. But in a thrombotic stroke, why cardiac evaluation is needed is that all those who have cerebral atherosclerosis, which is cause for stroke, will also have coronary atherosclerosis without fail. Nobody ever dies of hemiplegia. All such hemiplegics will ultimately die of myocardial infarction. So that assessment and prevention of an infarct in all patients of stroke, that is important.
Thank you.
Thank you, Mahesh sir. To help us understand the different mechanism of a stroke, I would now like to invite Dr. Rama Patil, Madam. Dr. Rama Patil is a consultant neurologist practicing at RN Hospital, Sanpada, Navi, Mumbai.
जा रहा है हाँ नहीं ये नहीं है पेन ड्राइव लगा है ना पेन ड्राइव So, first of all, thank you, Dr. Vishal, sir, for suggesting me to talk today. Thank you, Apollo Hospitals, for creating such platform. So, my topic is mechanisms of stroke. So, where do we point this? It's towards screen, right? Okay. So stroke is a heterogeneous disorder with diverse pathogenic mechanisms. The mechanism, I think it's one of the most important questions that haunts every neurologist because it affects everything from clinical features to prognosis to outcome and most importantly to management. We had some of the excellent talks, where to use antiplatelets, where to use anticoagulation, where Vishal sir comes in picture and does miracles through neurointervention. All this, I think the first question that comes to his mind must be, what is mechanism of stroke? So, the system of categorization of subtypes of ischemic stroke, mainly based on mechanism, was first developed for trial of org in acute stroke treatment called TOAST trial. So this trial happened around 30 years ago, but it still holds the basis of how every neurologist thinks about the mechanism of stroke. So despite modern advances and many other modern classifications, this is still widely applicable classification. So as per TOAST, strokes are classified into 5 subtypes, that is strokes due to large artery atherosclerosis, strokes due to cardioembolism, strokes due to small vessel disease, strokes of other determined etiology, and strokes of undetermined etiology. Let's see one by one all of this. So when does a neurologist think that a stroke is in a particular patient is due to large artery atherosclerosis? So there are 4 things which we see in every patient. It's the risk factor profile, it's clinical features, the brain and MRI findings, MRI, MRA findings, and some other diagnostic evaluations. So when clinically, if a brain imaging finding is there of a significant, that is more than 50% stenosis or occlusion of a major brain artery or a branch cortical artery, presumably due to atherosclerosis, clinically patient is having features of cerebral cortical impairment like aphasia, neglect, restricted motor involvement, etc., or a brainstem or cerebellar dysfunction. And there is history of intermittent claudications, TIAs in the same vascular territory, a carotid bruit or diminished pulse. It all helps support the clinical diagnosis of large artery atherosclerosis. Generally, on CT or MRI of such patients, we get a lesion that is either cortical, cerebellar, brainstem, or subcortical, which is generally greater than 1.5 centimeters in diameter. So there has to be a supportive evidence by duplex imaging or arteriography of a stenosis of greater than 50% of an appropriate intracranial or extracranial artery. Diagnostic studies should exclude potential source of cardiogenic embolism, and this mechanism, we don't think of this when if the studies, arteriographic studies, are normal or show only minimal changes. So underlying this large artery atherosclerosis is basically the mechanism is in situ thrombosis. Thrombosis superimposed on atherosclerosis. So these are the areas where there's bifurcation. These are the areas where blood turbulence is expected to occur. It's a carotid bulb, siphon, proximal MCA, proximal PCA, mid-basilar, and the proximal vertebral arteries. So these are the areas where there is a high level of turbulence and where there is in situ, chances are more of atherosclerosis and in situ thrombus formation. The more common mechanism is artery-to-artery embolism. Because most of the times these atherosclerotic plaques, they have erosion, ulceration, intraplaque hemorrhage, which rupture and cause distal embolization. So there's a case of a stroke with a ICS stenosis and right MCA M2 occlusion. The third mechanism by which these major artery stenosis can lead to strokes is poor perfusion. This is most critical in border zones or watershed regions. So there are two types of watershed regions. There are cortical watershed regions and there are deeper internal border zone watershed regions. So cortical ones between ACA, MCA, MCA, PCA territories, and the internal ones are between the major ACA, MCA, PCA territories and the lenticulostriate arteries, recurrent artery of Hubner, and anterior choroidal arteries. So most of the times, it's the major stenosis. On the top of that, there may be a systemic hypoperfusion cause like cardiac arrhythmias, MI, volume loss, dehydration, or dysautonomia, which on the top of ICS stenosis can lead to watershed territory strokes. They are less common in the posterior circulation, more common in the anterior circulation. This is an example of a cortical watershed infarct in the ACA, MCA territory, in the MCA, PCA territory, in a patient with right ICS stenosis. You can see the stenosis here. And this is a typical deep white matter confluent ischemic changes, which give an appearance of string of pearls, again in a patient with a left ICA occlusion. Second common mechanism, most common mechanism, which we just got discussed with Dr. Mahesh Ghogre, sir, is cardioembolism. So when we think of this is when one of the cardiac source of embolism is identified, the clinical and brain imaging findings are more or less similar to large artery atherosclerosis. The infarcts are bigger, more than 1.5 centimeter generally. MR angio will be normal most of the times, and one of the features that supports this mechanism is having previous TIAs or strokes in more than one vascular territory. So this generally supports the clinical diagnosis of cardiogenic stroke. We definitely exclude a potential large artery atherosclerotic source of thrombosis or embolism before we think that this is particular mechanism in the stroke in the patient. So we already discussed this, that there are certain high-risk sources like mechanical prosthetic valves, mitral stenosis with atrial fibrillation, left atrial appendages with thrombi, and then there are certain medium-risk sources like mitral valve prolapse, mitral annular calcification, mitral stenosis without atrial fibrillation. These are not like clear-cut boundaries, and they definitely, the medium-risk sources can become high-risk sources in a particular scenario. So this is a case where we already discussed the TEE in depth, and this is showing myxoma leading to particular stroke in multiple territories. So these are posterior territory strokes plus anterior territory strokes, which support the clinical diagnosis of cardioembolic stroke. Another case of endocarditis with vegetations showing the embolic pattern of stroke. Posteriorly, this spontaneous stroke, and anteriorly, few emboli. The third mechanism is small artery occlusion. So the ischemic stroke which are caused by occlusion of perforating vessels. Here, clinically, patient generally presents. We think of this mechanism when a patient is having a traditional clinical lacunar syndrome. So a pure motor hemiparesis, pure sensory motor hemiparesis, ataxic hemiparesis, or dysarthria, clumsy hand syndrome, what we call. And they don't have any evidence of cerebral cortical dysfunction like aphasia or visual field defect or neglect, etc. And there is history of some risk factors like diabetes, hypertension. definitely we exclude any cardiac source of embolism, and the large extracranial arteries should not demonstrate any stenosis of greater than 50% in the ipsilateral artery if we say that this is the mechanism of stroke. And on imaging, we generally find the infarcts which are smaller, which are less than 1.5 centimeter. So they could be in brainstem, they could be in subcortical region, and this is an example of a lacunar, a small, very tiny dots in left thalamus, and this is again a small vessel disease, the leukoencephalopathy, which we call on flare. Underlying the small vessel disease, there are again two mechanisms. Either it's lipohyalinosis, which is a disorganized vessel wall, fibrinoid material deposition, and occasionally hemorrhagic extravasation at arterioles of around 40 to 400 micrometers in diameter. So generally, they frequently affect the lenticulostride branches of MCA, thalamoperforating arteries from PCA, and perforators of basilar artery. So this is just to show that with advances in the vascular imaging, we have been able to clearly understand mechanism of stroke in particular patients. So these are anterior circulation stroke of left corner areata, right corner areata, and with typically a very normal MCA. And you can see a very clear black lumen of vessel, which on the cross section with very high resolution MRI, we can understand that the perforators are not blocked by any atheromatous plaque. This is the posterior circulation pontine infarcts with a very clear basilar artery and clear lumen on the cross section. So the second, this is important because there is another way the small vessel strokes can happen, that is atherosclerosis of parent artery near the perforator origin. So as against the previous MRI, we can see that this capsular infarct with a normal MRA, so looking normal here, but on the high resolution pictures, we can see this grayish thing here. It's an atheromatous plaque. It's near the perforator origin. So ventrally, ventrosuperiorly, superiorly, these are the areas which is even enhancing on the contrast images. So this is particularly branch atheromatous disease, which is causing the strokes. So generally, these strokes are bigger as compared to those caused by lipohyalinosis. This is again the branch atheromatous disease of the basilar artery, the pontine strokes with normal basilar artery here looking normal basilar artery, but near perforator origin, we have this plaques, atheromatous plaques. Then the fourth type of mechanism is strokes of other determined etiology. So either there are non-inflammatory vasculopathies like dissection or moya, and inflammatory vasculopathies like primary CNS vasculitis, and the other hematological disorders like protein C deficiency, S deficiency, and many others. So when do we think of this as a mechanism? There is no particular clinical or imaging finding here. We may find in any territory, any location, any size infarcts, and the diagnostic test, the blood test or arteriography should reveal one of these unusual mechanisms. So there's a particular DSA, for example, it may suggest a particular moya pattern, and we definitely exclude the cardiac sources of embolism and large artery atherosclerosis before we conclude this as the mechanism of stroke. The fifth mechanism is stroke of undetermined etiology, that is cryptogenic strokes, where the cause or the mechanism could not be determined. So it includes three subcategories where multiple potential causes are identified. Like for a patient has both atrial fibrillation and ipsilateral 50% carotid stenosis, or a patient with traditional lacunar syndrome with ipsilateral 50% carotid stenosis. So there are multiple causes. Or there is incomplete evaluation, the patient did not complete evaluation, or the third thing is negative evaluation. Despite extensive evaluation, if you don't find any etiology, which is also called as ESIS, that is embolic stroke of unknown source, here again, the criteria are that the patient should have a non-lacunar stroke, and we should exclude any atherosclerotic mechanisms, we exclude any cardioembolic mechanisms, and no other specific causes identified like arteritis, dissection, vasospasm, or drug abuse. Then we label them as strokes due to ESIS. Then the potential sources, we nowadays know that more and more of ESIS is actually cardiogenic in origin. There may be covert paroxysmal AF, or there could be arteriogenic emboli or paroxysmal emboli and cancer-associated thrombi. So even at the end of this talk, even we remember these three words, it's enough, I think. So mechanism is either embolism. So embolism could be from heart, could be from artery, could be from paradoxical like PFO, then thrombosis. Either it is again due to atherosclerotic thrombosis or a hypercoagulation disorder, or maybe, vasculitis, and on the top we are having thrombosis. And the third thing is hypoperfusion. So hypoperfusion due to stenosis or systemic causes. Thank you.
I have a question for you, Dr. Rama. Nice talk. Only thing is regarding the clinical presentation of branch arthritis disease versus the lacunar infarcts. We know the clinical presentation is different, and the diagnostics in vascular imaging is making it very clear. But is there any therapeutic implication to that, and does it make a difference how we address these cases?
So management is more or less similar for both the, because both are thrombotic in origin. So the management wise it is still antiplatelets, and clinically more or less they are indistinguishable. Only thing, the size of infarct is generally larger for branch atheromatous disease related strokes than lipohyalinosis related strokes. Yeah, correct. Absolutely. Absolutely.
Yeah, you said some symptoms, bizarre symptoms of lacunar infarct. Can you just repeat?
So we generally get a pure motor hemiparesis. So generally we lack the cortical features like aphasia, neglect, and visual field.
So what are the features we look for?
So generally pure motor hemiparesis, only hemiparesis without any aphasia or neglect, etc. Or pure sensory motor hemiparesis or ataxia hemiparesis. So generally we get it in a pontine lacunar stroke. And then dysarthria clumsy hand syndrome is again one of the lacunar syndrome. Yeah.
So far as your etiology for the hypoperfusion causing a stroke, why it is limited to one particular artery and not in general? Because hypoperfusion per se is a physiological mechanism.
So generally systemic hypoperfusion causing stroke is very rare. It is generally territorial because it adds up to the, so whenever the area of stenosis, it is superimposed hypoperfusion that leads to strokes.
Yeah. Thank you.
Thanks, Rama ma'am. Thanks, Dr. Vaishali. Thanks, sir. Stroke remains one of the leading causes of long-term disability, while acute management aims to minimize brain damage and medical therapy focus on preventing recurrence. An equally critical component is reducing disability and restoring functional independence. Rehab plays a central role in giving patients a meaningful quality of life. We now move to our final session, Rehab and Post-Stroke Movement Disorder. I would like to invite our chairperson for the session, Dr. P.S. Shinde, sir. Dr. Ravindranath Sahi, sir. And Dr. Shyam Kamble, sir. Dr. P.S. Shinde, sir, is a consultant physician at Alibag. Dr. Ravindranath Sai is senior physician. And Dr. Shyam Kamble, sir, is a practicing physician at Gandhi Hospital, Panvel. However, before we proceed to rehab, we must address an important topic, cerebral venous thrombosis. CVT is an atypical cause of stroke with diverse and often misleading clinical presentation, making timely diagnosis essential. To take us through this significant topic, I invite Dr. Ram Bhagwan to deliver a talk on CVT and help us understand this great topic. Dr. Ram Bhagwan is a practicing neurologist at Vashi, and he is attached to NMMC Hospital, Vashi, and Kokilaben Hospital.
So thank you all for inviting me here. Thank you, Vishal sir, for this opportunity. I know we are in an afternoon session, so if you nod off, I will document it as a loss of consciousness and start a stroke protocol. So let's move on to from arteries to veins now. I'll be talking about the cerebral venous sinus thrombosis. This is the outline of my topic, but I'll mainly focus on the case and management and rush through other things of the CVT. So we had a 31-year-old female, past history of a LSCS in last 3 months back. There was no other comorbidities, presented with seizure, headache, aphasia, right-sided hemiparesis. You can look at the CT, you can identify there is a bleed and there is some hypodensity surrounding it. So the diagnosis is there is a cerebral patient underwent a MRI and the diagnosis of hemorrhagic infarct with a superior sagittal sinus and left transverse sinus sigmoid sinus thrombosis was made. So what are the standard question which should come to your mind while treating this patient? So what should be the acute treatment? Should we start the anticoagulation or wait considering the hemorrhage? If yes, what should be the choice of anticoagulation? What should be the duration of the anticoagulation? Is there a role of anti-seizure medication, intervention or neurosurgery? We'll try to shed some light on all the following topics. Okay. So what is CVT? CVT is a type of stroke caused by thrombosis of dural venous sinus and or the cortical or deep veins. So extracranial and auger thrombosis like retinal vein, jugular vein thrombosis without intracranial extension and spinal venous plexus thrombosis is not included in CVT. You can appreciate the MRI top image showing the major sinuses and the cortical and deep veins. So CVT represents almost 0.5 to 1% of all stroke. Some registry have reported up to 3%, and post-COVID we have seen increase in the surge of CVT patients also. So almost 10 to 20% of stroke in young adults are attributable to the CVT. One of the largest study on CVT was IS-CVT, which showed that 78% of the CVT patients were less than 50 years of age. It is more common in females, and it is attributable to the hormonal factors and the OC pills. And it has been shown that in female it presents earlier, around 33, 34 years of age, and in males it presents slightly elder, around 42, and in post-menopausal age group, there is no gender specificity, it is equal in both the genders. So what are the etiology and risk factor? It is important to classify the etiology of CVT into two types, the transient one and the long-standing and the permanent risk factor. What are the transient? Transient are the female and female-related factor like pregnancy, puerperium, OC pills, hormonal replacement therapy. HRT can be long-term factor also in a transgender, feminine person. Then infection like CNS infection, systemic infection, head injury, or we can do it iatrogenic like jugular vein occlusion, some dehydration, especially in childhood, it is one of the important cause, and it was vaccine associated was another important cause we have seen in a COVID patients. It was especially associated with adenovirus associated vaccine. The long-standing factor are the one most important are the prothrombotic risk like a hematological condition, protein C, protein S deficiency, antithrombin 3 deficiency, factor V Leiden, prothrombin gene mutation, Apla syndrome, hyperhomocysteemia are the most important one. Rest of the factors I have just mentioned for the completion. It is important to know that even if patient has some transient factor, but many patient will have a combination of the factor. So there will be a female who is taking OC pill. Additionally, she might be obese also, or some genetic factor might be contributing to the cause of the CVT. So you have to work up according to that. What is the etiology? So as discussed, the etiology is based on a Virchow's trial. There is either there will be stasis, vessel wall injury, or hypercoagulability. So the prothrombotic condition are the most important ones. how does the pathogenesis of CVT occurs? So first there is a formation of thrombus. There will be cortical or a superficial vein sinus will be occluded. It will lead to the back pressure. There will be increased venular capillary pressure, and so it will lead to the vasogenic edema. Eventually, because of this back pressure, there will be reduced cerebral perfusion, disruption of a blood-brain barrier, and which will lead to the venous infarction and a cytotoxic edema. So clinical feature will also be determined by this only. So this clinical feature fall into three categories. First are those due to raised ICP, then second are due to venous infarctions, and third are related to underlying disease like a CNS infection causing the CVT. The clinical feature are also determined by which sinus is involved. If patient has a cavernous sinus involvement, there will be associated second 2, 4, 6 involvement, cranial nerve involvement. So we will not go into deep of that. So most commonly CVT present as a subacute presentation. ISCVT showed that around 56% of the patient had a subacute presentation, and 48% had a 37% had a acute presentation, that is less than 48 hours. Headache was the most common symptom. It was often diffuse, slowly progressive over days to weeks. Minority of the patient had a thunderclap headache. So the presentation from ISCVT, we know that headache had 90%, seizures were present in almost 40% patient had a focal deficit, decreased level of consciousness. Some patient had only headache, around 50%, and vision loss was present in a 13% of the patient. So IIH-like presentation with headache and vision loss was seen in around 37 to 47% of the patient with CVT. So investigation of choice is MRI brain with MR venography. When it is not available, you can go for a CT brain with a CT venography. What do you look for in imaging? You look for a direct evidence of a thrombus. If you look for a thrombus, or you can look for a indirect evidence like a venous infarction is there or venous ischemia is there. So these are few of the images showing the direct thrombus. You can appreciate the non-contrast CT first, which is showing a dense clot sign. Then there is a dense transverse sinus can be appreciated on non-contrast CT. On a contrast CT, you will notice a empty delta sign, that is a filling defect will be seen, and surrounding area will have an enhancement. So cortical vein will appear as a dense cord on the thrombus in the cortical vein appear as a dense cord. It is called as a dense cord sign. On MRI, the patent cerebral vein usually demonstrate a low signal due to flow voids. So these flow voids are best seen on a T2 images, and absence of these flow voids are because of the presence of a thrombus. So if you see absence of a flow void, you can absence of a flow void you can see as a thrombus which is there. So thrombus is absence of normal flow voids. The management, the acute management was already discussed, like a ischemic stroke, you want to facilitate the venous return. So head positioning is important, avoid head rotation, avoid flexion of neck, there should be no collars, elastic mask band. If patient is ventilated, make sure to avoid high PEEP, avoid frequent suctioning, avoid the IJV catheter, especially on the site of the thrombus, and avoid the abdominal compression. So the most important management is oral anticoagulation. The objective of it is to prevent the thrombus growth, to facilitate the recanalization, and to prevent the recurrent events. So what was the evidence for that? So we use heparin for the acute anticoagulation. It has been, evidence is very strong, and the quality of evidence is moderate quality, and it is strongly recommended. Out of heparin, which heparin to use? The studies have studied for a LMWH and unfractionated heparin both. So there is a recommendation to use LMWH over unfractionated, but this has drawn specifically through some peripheral thrombotic studies like DVT and pulmonary embolism, where LMW is preferred. you still will use unfractionated heparin in a patient with a severe renal deficiency, or if there is you want to use it as a bolus, or if you are planning patients for a procedure. In that case, you can use a unfractionated heparin. So as discussed with our case, even in a presence of hemorrhage, anticoagulation is not a contraindication. You have to anticoagulate. Some up to 6.4% of a CVT can present with SH. Some patient can present even with a SDH due to rupture of the bridging veins from a back pressure. Both these patients, even with an intracranial hemorrhage, you have to anticoagulate. If it is very large, you can involve a neurosurgical intervention. So from the current evidence, what we know that you have to start a lead-in parenteral anticoagulation for 5 to 15 days. So they have not specified how much duration of heparin is required. They have said 5 to 15 days. Exactly why this strategy is used, it is not known. There is no comparative study to see if the longer duration helps or more. So after that, you can shift to the vitamin K antagonist or DOACs. So DOACs, what should be the duration for a preventive patients? So it was still it is debatable. There are 3 categories which are important. First is one with a transient risk factor. You go for a 3 to 6 months of anticoagulation. The patient with a recurrent CVT, you go for a lifelong, and the patient with a severe thrombophilia, you go for a lifelong anticoagulation. And in between patient, it is said that guideline says you can give from 3 to 12 months anywhere in between. They tried to study it through a XOVA trial, but they did not find any benefit of shorter duration or longer duration. One of the study, priority CVT, was done. They found that almost 70% of the patient get completely recanalized, 54% patient get completely recanalized by 3 months only. So, and even as early as 8 days, they found that 70% of the patient will either get completely or partially recanalized as early as 7 days also. So, and what is the evidence for DOACs in CVT? There were multiple studies. Before we used to use warfarin, but now there is evidence to support use of DOACs in CVT. The most important study was RESPECT CVT and ACTION CVT. Based on that, they studied dabigatran versus warfarin, and now it is in the guideline to use DOACs in CVT. The Einstein Junior was a study which was done in a pediatric population. They used a rivaroxaban in CVT, and it was also helpful. The recurrence rate was equal, and the bleeding risk was less. So there are still some situations where DOACs are not preferred, like a pregnant patient or a breastfeeding patient, where you will have to use LMWH, or in breastfeeding you can use a vitamin K antagonist. In APLA patients also, it has been seen with DOACs, there is a risk of recurrence is high, and in this patient you have to use warfarin. So back to the case, we started this patient on warfarin, LMWH, but in spite of that, the patient, say on second day, had a seizure, repeat CT was done, and there were an increase in the size of hemorrhagic infarct, and there was a new hemorrhage was seen. So what's next? So in spite of starting anticoagulation, so we have to move forward. So they studied similar cases. So they tried let's offer like a ischemic stroke. Some patients should be given a chance of a reperfusion also. So systemic thrombolysis was tried, but there was an issue of a major hemorrhages, even intrasymptomatic ICH, and the mortality was also high, and hence it was aborted. And the reason being for that, because the CVT, the thrombus load is high. So the symptomatic hemorrhages are more. So they thought to directly deliver that thrombolytic agent in the sinus, or you can do a mechanical manipulation of the thrombus. By that, the endovascular treatment options were given. So what are the options available? You can go for an intrasinus thrombolysis, or plus minus you can go for a mechanical clot retrieval, thrombectomy, aspiration catheter. In some cases, other technique of EVT can also be used. Which technique is better? As such, there is no current evidence to support a single technique which is superior. So, one study was done to act trial to see if EVT is useful in patients with CVT or anticoagulation. So they selected a cases of severe CVT, and it was a randomized control trial, but it failed to show any benefit of a EVT over a anticoagulation. So, but there was an issue with this trial. What was the issue? The sample size was very small. Only 67 patients were recruited. So it was an underpowered study. The EVT strategy was also heterogeneous. So, and some of the patient had a sinus rupture also. So what does current evidence say? Currently there is no fixed evidence to lack EVT as a standard of care for all patients. It needs a case-by-case evaluation by an intervention neuro team and an experienced neurointervention person. So consider, as of now, what are the indication? You can consider EVT in following cases. One with a symptomatic EVT, unresponsive to current medical management, like our patient, which worsened on a anticoagulation. If there is some contraindication to heparin, like recent surgery, some major bleeding diastasis, some in patients with vaccine-induced thrombosivity, or if there is a high risk of mortality. At presentation only, you know, patient has a coma, seizures, patient has a posterior cerebral involvement, or if there is a deep cerebral venous sinus thrombosis, or there is a progressive neurodeficit. In this patient, you should offer a EVT. But how long to wait before offering a EVT is still unknown. So in this case, Vishal sir was contacted, and this was there was a pre-procedure you can look at. Superior sagittal sinus was occluded, and post-procedure there was a nice flow in the superior sagittal sinus. So patient underwent mechanical thrombolysis and thrombectomy. Gradually patient recovered and was discharged after 5 days. Repeat CT after 2 weeks show resolution of a bleed very well. So, and in some patient you will need a decompressive surgery also. So decompressive surgery is beneficial in this patient. It was shown by a Decompress 2 trial, which showed that almost 77% of survivor achieved MRS score of less than 2 at the end of 1 year, which is pretty good. So who should be offered with a decompressive surgery? The patient with an acute severe CVT, parenchymal lesion with an impending herniation. It is very helpful to go for a decompressive surgery. So how do you determine which are the bad patients? So there is a CVT prognostic scale which is available. So what are the points in it? You give 3 points to coma, bilateral signs, generalized seizure, meningeal signs, bilateral lesion, and a hemorrhagic CSF. All are given 2 points each. And whatever, if the score is less than 3, it is considered that the chances of poor prognosis are less. Score of 3 or more than 3, the chances of poor prognosis are more. So this helps. Then what about the seizure management in CVT? Almost 34% of the patient with CVT will have a seizure within the few days of diagnosis, and majority of them will have within first 24 hours. What are the risk factors for seizure? Some patient with ICH, SAH, cortical vein or superior sagittal sinus thrombosis, patients with a cerebral edema, venous infarction will have a higher risk of seizure recurrence. Patients who have a focal neurodeficit at presentation, and female specific risk factor like pregnancy, puerperium we have discussed, those are associated with higher risk of seizure recurrence. So what does guidelines say? As such, they say that for a single seizure which is self-abortive, you need not give a anti-epileptic, but it should be available in a high risk cases. So as such, preventive prophylaxis is not recommended, but you can treat the patient ones who are having. Some of the special population, like we have discussed that pregnancy puerperium is one of the major risk factor. So you can counsel the patient that if you have a pregnancy puerperium associated CVT, it is not a contraindication for a further pregnancy. You can go ahead for a further pregnancy provided you start taking a prophylaxis with a LMWH during pregnancy, and 6 weeks postpartum is what is advisable. So another important is we have discussed almost 37% of the patient had a in ISCVT had a IIH-like presentation. So they have a visual changes and associated papilledema is present. So this can lead to a permanent and a severe visual loss if not detected early. The presentation is usually bilateral because it is because of the back pressure. So both it is bilateral. There will be presence of blurry vision, diplopia, photophobia, visual obscuration will be there. So what is the recommendation? You should examine every patient of CVT for papilledema. Ideally within first 24 to 48 hours if they have a signs of raised ICP, or within 7 days if the signs of raised ICP are not there. And how do you treat? You treat like a IIH. You give acetazolamide, and if patient is not improving, you can offer them a optic nerve fenestration or even a cerebral fluid diversion procedure, shunting procedure can be offered in these patients. What is the annual risk for the seizure recurrence of after CVT? For any type of thrombus, it is around 6.5%. For extra cranial venous thrombosis, 5%. For CVT itself, it is 2 to 7%. So, what to do after stopping the anticoagulation? As we have discussed, guidelines says 3 to 12 months of anticoagulation. So, as of now, there is no role of aspirin for a secondary prevention in a CVT. Once you stop anticoagulation, you have to leave it and wait for the recurrence. If a patient has a recurrent CVT, then you go ahead and give a lifelong anticoagulation. But some practices that some people start this patient on a preventive aspirin therapy, though it is not in guideline. So what is the long-term complication? So acute management is already, we have seen long-term this patient will have some cognitive and some psychiatric effect. You have to look at that also. Just because the imaging has improved, the recanalization has occurred, doesn't mean that patient will not have a chronic symptom. Many of these patients will have a chronic symptoms like headache, seizures, fatigue, and you need to manage that also. So this is the last slide, and this is the diagnostic algorithm which we have discussed. So if you are clinically suspecting CVT, go for a MRI brain plus MR venography. If available, not available, go for CT with CT venography. Confirm the diagnosis of CVT. Consider for a acute anticoagulation, LMWH or unfractionated heparin for 5 to 15 days, and then you stratify this patient into risk score of less than 3 or more than or equal to 3. If it is severe, you can give them an option of EVT or go for a decompressive craniotomy. And as a long-term prevention, you start this patient on an oral anticoagulation. We have already discussed some will require lifelong anticoagulation depending on the etiology. Some will require around 3 to 6 or 6 to 12 months of anticoagulation. So to summarize my topic, it is important to consider a diagnosis, especially in young female with a new or different headache, especially with a visual symptoms. The acute management typically involves anticoagulation with heparin, and DOACs are now considered a standard of care in this patient for a preventive therapy. Optimal duration of anticoagulation is still unknown. The role of EVT should be individualized. It should be offered on a case-to-case basis. There is a risk of vision loss in patients with CVT, so you have to make sure you examine them for papilledema, and you manage the long-term sequelae also. So what's next? All these questions are hopefully will be answered within few years. There are studies going on endovascular treatment also, and they are trying to, because we have just studied ki DOAC dena hai, but which DOAC to give. So they are trying to study and compare in between that also. So case was, thank Vishal sir had given that case of intervention. Thank you. Any questions? Repeat imaging as such, they did one study to see if there is a role of repeat imaging. So you can do a repeat imaging just for a prognostication, but it will not guide the anticoagulation. So if, because I said ki the priority CVT was done for that only, to see if there is a how is the recanalization? Because main goal in CVT treatment is you want to see the vessel opened. So they did a MRI, and at 8 days also they found that almost 8% patient had a complete recanalization, almost 60% patient had a partial recanalization. So, and by 3 months almost 60 to 70% had a complete recanalization. So, but they found that even if you leave that partially recanalized vessels, it doesn't matter. One of the lecture I was attending, they said one hospital practices like this, they give only that load in anticoagulation for 5 to 15 days. After that, they don't give also. For the prevention of recurrence, anticoagulation is also not given. So repeat role of neuroimaging is not there. It is not recommended. Yes. So that's what in this patient, the stent retrieval was the thrombus. They use a stent retrieval device. What they did, if there is a thrombus, you do a intrasinus thrombolysis and you try to remove that thrombus with the help of various devices. So stent placement is not there. Stent retriever was used and the thrombus was removed. Vishal sir can correct if anything else is there.
We take a big aspiration catheter and we connect to the pump. So we remove whatever possible we can.
So they retrieve a clot rather than a stent placement. So I think stent placement must have mistakenly put. Stent placement is not there.
The technique to remove, but as there is a high clot burden, so we generally prefer aspiration catheters.
But just outside this topic, are there any stents for regular venous thrombosis and all?
Stent retriever is device.
No, apart from this, like in case there are patients of extravenous vein thrombosis.
Aspiration is better.
Aspiration?
I will prefer aspiration because they are big, almost 7 to 8 mm caliber. So I will prefer thrombus because I have to do multiple thrombectomy with the stent retriever. Here I will take the aspiration catheter, I will connect to the pump and I can take it up and down.
Stent placement is not done.
Suppose it's a chronic case of
Chronic, no. Everything is an acute.
And with the facial condition, is there a way of...
No ma'am, we can't. Everything is an acute. Everything is an acute. Because what happens once the 24-48 hour passes, the clot becomes solid. You can't remove it.
Injection of this thrombolysis in the sinus.
Yes. RTPS same we use. Tenetable also we can use. Inside sinus. So we go inside and almost 20 to 30 milligram. We start injecting right from the superior sinus anteriorly. We go there, we inject, again remove catheter, inject, and sometimes we leave the catheter and 12 hours we can give thrombolysis slowly we remove the catheter. But there is risk of infection, we avoid that.
Good presentation, sir. I just have 2 questions. One is any role of anti-edema measures?
Yes, definitely. So the one which I had discussed, no, because it was already discussed in a ischemic stroke. So you can use mannitol, you can use 3% saline as an anti-edema measure. Because one of the pathophysiology is vasogenic edema is there. So you can use that. I have not covered that because I tried to give a point specific, but it is useful. Steroids are strictly no. Though even the vasogenic edema is there, you don't use steroids.
Anti-epileptic drug, we mentioned that no prophylactic role, but generally we see a lot of prescriptions. I want to ask, if no seizures, what should be the duration if given? And if patient present with seizure, is the duration differs from the normal seizure protocols?
No. As such, whatever we give for acute symptomatic, it is treated as acute symptomatic seizure. So they say, some guidelines say, for a prevention you don't give. Even for a self-abortive single seizure, you need not give a anti-epileptic. But how would you determine if it is a self-abortive or not? You go and load the patient. That happens.
Okay.
So
if we started we guess 2
1
episodes
month,
of seizures, 1 month of anti-seizure medication,
yes.
then you stop. Okay. Thank you, sir. Nice presentation.
Thank you so much.
Thank you, sir. Now we will move ahead with our next session. So the post-stroke care is no longer confined to the physiotherapy alone. So modern stroke management emphasizes multimodality rehabilitation, integrative physical therapy, occupational therapy, speech therapy, cognitive rehabilitation, and functional training to optimize recovery. To guide us through the principles of practical aspect of comprehensive rehabilitation, we have Dr. Nitin Menon sir, who will deliver a talk on a stroke rehabilitation.
So, meanwhile, Dr. Ram, that was very nice, because as usual, simple, therefore clear, perfectly delivered. Right? That's why I have hope in the youth. Very well done. While it is being fixed, in the last lecture we had, it is woman-centric mostly, women getting DVT. Any idea, being woman is the protection or risk factor for getting a thrombus?
Only thing is, it's not still.
So therefore, risk up to 50 it is a risk for this. Actually, being woman is protection against any thrombotic event, but those are all arterial thrombosis. You don't get an infarct. Menstruation is the best protection against getting an infarct. But venous, so it is a double-edged sword. Venous infarcts, women are more likely to get. That's why OCT pills are not much help. Otherwise, hormone replacement therapy had come initially, okay, so that you don't get a stroke. But then venous infarcts are more common.
Shall I begin? Yeah? Start? Okay. Thank you, Dr. Vishal. And we'll try to wind this up very quickly. Two more, so one presentation from me and one from Dr. Anil, and that's it. So stroke rehabilitation. So obviously all of us know that strokes are on the increase in our country, and strokes cause a lot of disability in patients, and it is one of the leading causes for disability affected life years lost. Economic burden of managing stroke and post-stroke sequelae are very large, and so all of us need to do something to keep this number and this figure down. As you can see, in India, we are just in Asia, we are outliers. Our stroke incidence is as much as Western Europe and the US. Like in developed countries, we don't have the systems to take care of these kind of patients. So we need to do something at source. We need to see that we do everything in our power to see that the disability percentage and the disability burden is as less as possible. With all of the treatments that we had discussed in the previous talks, a majority of these patients come beyond the window, and so rehabilitation remains the only option for addressing these problems. So if you look at what are the problems that a patient with stroke has, this is the list of all the problems. There are about 10 things. So you can have a patient in coma or in a vegetative state. You have cognitive problems, speech problems, language problems with swallowing, problems with bladder, problems with bowel, problems with sensory, the visual, mood and depression. So everything needs to be addressed for getting best and optimum outcomes of this patient. We will be talking a lot on the motor, and I will be just briefly touching on the rest of it, just to keep everything fast. So this is what naturally happens. So if patients come with a stroke and we address the issue, and then what do we see is that we see that the function dips and then it starts recovering after a period of time. It never gets back in most cases to morbid function. This we are talking about moderate to severe strokes. We are not talking about mild strokes which come with very little deficit. So if in rehabilitation we have something called as a stroke window. So this fMRI depicts that. So if you can see what happens is that immediately after the stroke, there is a window which opens up during which neuroplasticity is maximum. It is there in the initial few weeks to months, and after that, that window closes. Beyond 3 to 6 months, the window of neuroplasticity goes down. So if we want to do disability mitigation, so what I mean by disability mitigation is, if we want to minimize the disability to nothing or as less as possible, only 5%, 10% disability, this is the window in which we need to do everything possible to regain function. Beyond that, it becomes only disability management, because once the disability sets in, 6 months, 8 months go in, then you can reduce the disability, you can make the person live a better quality of life, you can reduce some, but the disability will not go away. So this window needs to be targeted very aggressively. Now, what happens to these patients with motor recovery? So there is a subset of patients. So the majority of the patients are in the middle zone where they improve functionally and then they taper. There are some patients who improve very drastically and they regain a lot of their function which they lose. And there are some patients who, whatever you do, they do not regain much of function at all. So it is imperative for us to the upper group is better. I mean, there even with very standard rehabilitation, you still get a lot of function back. It's the middle group that we need to target, because we can push them up and you can increase the level of their functioning. The lower group we can try, but most of them remain disabled to a large extent. And all rehabilitation depends on this concept. It is called neuroplasticity, which is a fancy word for learning. Basically, if you repeat it, if you do something which is relevant to you, you are engaged in it, you are spending a lot of time doing it, you are more likely to regain that skill, or you are more likely to gain that skill. So exactly the same principles work. There are about 10 principles of neuroplasticity. All of them we try to use this in our practice to try and get the best functional return. So some speakers earlier had discussed that there are some modifiable factors and non-modifiable factors. Obviously, there's some work going on in every this, but what rehabilitation attempts to do is actually influence this motor recovery to see that you get the optimum amount of return of function that can be regained in that person. So there are some strategies which are low-cost strategies. Most people use it, some to some extent, some not to some extent, and then there are some tech-enabled solutions as well. I will show you some of those. So I'll just go through each one of these and then we just enumerate what are this. So there are some drugs which we use sometimes in recovery. The evidence for drug is very moderate, and it is there only in conjunction with rehabilitation. If you are going to simply give the drug, it's highly unlikely that it's going to make much of a difference to the patient's final outcomes. But when added with other rehab measures, these drugs generally tend to have a little bit of a positive effect on motor recovery itself. With hemiplegia, we have one good thing, and that is that there is a sound side, which we don't have with people, say for example, who has a basilar stroke or somebody who has a brain injury. But so what studies say is that if you train the sound side, you can get improvements in the hemiparetic side as well. So which we try to use in our day-to-day practice as well, and there is good amount of evidence for that. So these are some of the exercises that we do with our patients on the sound side. This is not done on the hemiparetic side, it's done on the sound side. Then there is another strategy that we use, which is called as constraint therapy. So in simple terms, constraint therapy is what we do is we just block the use of the person of the sound side, and we force the person to use the paretic side. And there are studies which say that so in acute to subacute cases, this works very well. Sometimes even in chronic cases, this works because there is a lot of component of disuse, and once the person is forced to use that side, we start seeing return of function. This is a strategy which we use many times in upper limb training. So let's see if this video plays. So yeah, so if you can see, what we have done is that other side, the right side has been constrained, and this lady is being forced to use the left side to do tasks. You can see here. These are two very low-cost strategies. We don't use them in our therapy sections. We actually tell the patients to do this when they are in the patient room itself or when they are at home. So there are two tasks, two items which we give them. One is called as mental imagery and one is called as action observation therapy. So mental imagery. So if there is one task, say for example, I want to hold this bottle and drink water. We tell patients ki imagine with your paretic hand, you are breaking this task into some 4 or 5 different tasks. So the first task is to reach to the bottle. So imagine that your hand is going forward. You are reaching there. You have touched that. Then your finger is going around it. Then you have opened this with the other hand. Then you are taking it close to your mouth, and then you are drinking it, and then you keep. So this is a sequence of tasks. Our brain does it because this is something that we have learned and we have practiced and mastered over the years, but it's actually broken down into smaller tasks. And so we ask patients to imagine that they are doing this. And the more they imagine, the more the neural networks start firing. It's the same thing we show them in a video as well. So this is called as action observation therapy. So every small movement that we want them to, we show them videos and we tell them, you keep looking at this and imagine that you're doing it. It's very important that the person imagines. It's simply passively looking at a YouTube video is not really going to help. You have to sit there and imagine that you're doing it. That actually fires this. This has come from a very famous study on mirror neurons in primates, and we have found that like all primates, humans also tend to have mirror neurons, and they fire and they create these circuits in the brain. Yeah. Yes, sir. Yes, sir. So this is another low-cost strategy that we use. It's called mirror therapy. So what we do is we keep a mirror in front of I will show you on our patient how we did it. So we keep a mirror in front of the patient and we block the paretic side. And we tell the person to imagine that the non-paretic side is actually the paretic side and you're doing those movements. So the non-paretic side obviously works. This is the paretic side. The mirror is kept here. So the paretic side can't be seen by the patient. But the non-paretic side, that is the sound side, will look like the paretic side on the mirror. So we tell the person, imagine that your right side is moving. Again, based on the same mirror neuron, we sometimes use this for post-stroke pain, especially with CRPS, and this works really, really well with these kind of patients. So this is the technique that we picked up from there. We use this music therapy in movement disorders, but we also use them sometimes for coma stimulation and for training small hand movements. So we have a small keyboard, we bring it and we tell them to play sa re ga ma or some this, and the small fingers and these are very good methods to train the intrinsic hand functions. Arts therapy again. So this is done in a very specific way. Actually, what we do is we bring a piece of paper and we tell the patient to draw with both the hands or color with both the hands. Both hands have to be used. So this is a form of treating both hands. So again, you use both the sides. You find that the paretic side tends to follow or mirror the movements of the non-paretic side, and that is how you can get some amount of movements with these patients. So these are all very low cost, nothing very fancy. Dysphagia rehabilitation, I'll just cover later on some of this. This is called as effortful swallow. So actually what happens is when we swallow, it's a very reflex movement. As soon as the food goes into the posterior pharynx, it triggers a swallowing reflex and the person swallows. So here we don't tell them to do that. We actually tell them once the food reaches your posterior pharynx, use all your pharyngeal muscles voluntarily. These are all skeletal muscles. Use them and voluntarily swallow each. Of course, you can't do this for a whole meal. It will take a person 2-3 hours to finish one meal. But for this, you keep on doing it. Again, there are studies which show that if you do this more and more repeatedly, you will trigger all the motor pathways. So you can get good amount of recovery of motor. So this is, now we've come to some amount of aid of technology. So this is body weight supported training. So body weight supported training is basically this kind of a platform. I hope this video works. No. Okay. So just to tell you, so this is this kind of a platform that here we are not using it on a treadmill, but you can. So the platform actually has wheels, and the patient gets suspended from that. So now nobody needs to hold the trunk, and you can only train walking. So most of the times what happens when you do this at home is, because if you don't have recourse to this, the person, somebody has to hold both the sides of the trunk. When that is being done, you are not concentrating on the walking part itself. Here, what we do is we ask them, so this is done on overground, but actually we do it on the treadmill. So the treadmill runs at a speed and the person has to keep on using be at that speed. It's very good to train the lower limb because the lower limb has only one function, and that is to propel the body forward. In upper limb, this strategy is a little bit of an issue. So this is a body weight support system, sir. So what the problem with what we do, what the physios do, say for example, at home, somebody is getting rehabilitated at home, is that when you want to make the person walk, somebody has to hold the person from both sides or at least from one side. So that trunk is not held physiologically. That leg is constrained from both the sides. So this person can only walk a little bit. That amount of walking is not enough to regain walking. So what we do over here is we take this system and put it on top of a treadmill. That treadmill keeps constantly running at a speed. It's a very slow treadmill. It's not like the treadmills that you use for fitness. This is a very specialized treadmill. So it runs on that very slow speed. The paretic leg is forced to work along with the non-paretic leg. So here the paretic leg is following the non-paretic leg. The non-paretic leg keeps moving at that speed of the treadmill. So you're forcing the paretic leg here to move along with that. That trains the walking reflex much better than this kind. So that is why these kind of solutions tend to give better outcomes. I will show in the subsequent slides something else also that we do. Non-invasive brain stimulation is catching up. The evidence for this is again moderate and again in conjunction with other things. But RTMS, that is repetitive transcranial magnetic stimulation or direct current stimulation, there are two protocols that we use. One, we use it to suppress the sound side. So sometimes what happens is that the sound side of the brain is suppressing the paretic side of the brain. So there are suppression protocols that we use to suppress it, and then there are some stimulation protocols which we can use to stimulate the paretic side. So suppression protocols are generally used for aphasias or for people who have seizure disorders and people who have very dense hemiparesis, especially where the corticospinal tract, you can see in the MRIs that the corticospinal tract is involved. There the stimulation protocols tend to do better. Then electrical stimulation. So electrical stimulation is, in this case, it's done in a very specific manner. So what we do is we attach this kind of a stimulator and we train only that function. Most of the times, the people who have walking problems with stroke tend to have ankle dorsiflexor weakness. So the ankle dorsiflexor doesn't recover. So we just stimulate this ankle dorsiflexor. The ankle dorsiflexor has to work during the swing phase of the gait. So we put the person on, and only in the swing phase of the gait we stimulate that. So the ankle dorsiflexor keeps getting stimulated physiologically, and that is how you get the kind of response. The same thing we do with upper limb also, where the most problems are with wrist extensor and finger extensor. So only that movement where the wrist extensor and finger, that is the only thing we stimulate. Virtual reality devices are now coming. Children are playing games and things like that. You get virtual reality devices to train specific movements as well. This is not really a virtual reality device. This is a augmented reality device, but this is the principle on which it works. So if you can see this boy, we are training his balance. He's looking at the screen, and what he's supposed to do is he's supposed to maintain. So there is a circle on that screen, and he has to maintain his stability, base of stability on that circle. The moment he sways, it will go out of the circle. So we are very specifically training only his balance. Robotic rehabilitation, again, so the evidence for robotic rehabilitation, if you look at it, is not for chronic patients. So it is for acutes and subacutes only. So even only in those cases where you are rehabilitating acutes and subacute strokes will robotic rehabilitation add to your rehabilitation value. So this is for upper limb. So again, if you can see, it's very easy. There is a computer screen in front of and his task. So it's a task specific training in the sense that person has to use his arm in such a way to execute some task. So here he is collecting those points. He has to. So there are a number of games that you can get. Gamification is again big because it helps the person stay engaged. He has to focus on that task. He has to see that he completes. And every time you do it, you will get a score. Next time you have to try to better it. So then there is that added bonus of actually pushing yourself. So these are some of the things that you can use to, otherwise it becomes very repetitive and monotonous. कि एक block निकाला यहाँ पे रखा, block निकाला यहाँ पे रखा. Patients they disengage from this. This kind of therapy helps patients engage into it. Sorry? Yeah. So for gait training also same way. So this gentleman, as you can see, so this is a robotic gait trainer. So it is used to train gait. The advantage with using this over others is that this helps you gain a more physiological gait, because the robot has a trigger in it, and from 0%, that is your effort, if it is 0%, the robot will put 100% effort. To up to 50%, you can train it. Once the person starts on the screen, we can show the person how much your effort is going. So when we see that, okay, 1 week he's putting 90, next week he's putting 70, we know that this person's leg is now starting. So when he starts putting 50, we can see that the hip and the knee start moving. You can stop this robotic training and you can start conventional training, and you can get very, very good results. Generally 4 to 6 weeks of this kind of training is required for an MCA territory stroke with power of less than 1 or less than 1. Generally for power 2, 3 and more, we do not use this device. The evidence for this is not very robust. It's a little expensive to use it, so that is why we didn't use conventional methods to train. Brain-computer interface, you must have all heard of Elon Musk doing a whole lot of experiments in this. So brain-computer device is nothing that there is a device which you put on top of your head. You can have invasive electrodes, you can have EEG type of electrodes, and actually you use your EEG signals to control movement. So it's not actually used to control the entire hand. It is used to control specific movement. So if I'm not getting the wrist extensor, I just try to get that movement out of it, and then you can see so EEG is the brain control interface is a very good device to train specific neuroplasticity on a very massive scale. There is no commercial BCI device available right now in India. There are some devices which are available in US on research basis only. So just to go to the non-motor, so cognitive, again, we have computer aided, we have pen and paper. Pen and paper works very well. Computer aided is a little difficult. Patients find it difficult to understand and engage with it. Language therapy, of course, there's a whole lot of this on it. Visual fields, it's either blocking or prisms, those kind of substitution. There's dysphagia, we have neuromuscular stimulation. I'll just run through dysphagia also in the subsequent slide. And mood is generally pharmacotherapy or psychotherapy. Nutrition, somebody was saying about sarcopenia, so we are one of the big advocates for actually adding to correct nutritional deficiencies, because we find that patients become very tired and they don't engage in this unless their nutrition is taken care of. Pain management, again, up to 70% of stroke patients can get pain. It needs to be looked at. There are multiple causes of pain. Some are musculoskeletal and some are neuropathic, and many of them are combinations. So you need to evaluate what is the kind of pain that the patient has and treat exactly accordingly. There is a science to this. And so again, somebody was mentioning the outcome scale. So this is what the Barthel scale looks like. So Barthel scale is basically a functional scale. It looks at the entire functioning of the patient, and if we can track how much is the improvement. This is an objective way of tracking. मैं सिर्फ बोला कि patient improve हो गया, that doesn't mean. In my Barthel scale, if the patient is from 0 has gone to 50, I know that the patient has actually improved. I can point it out on that. Barthel scale is also used from our side for us to transition from IP based care to OP based care. So once the Barthel score hits anywhere above 35 to 50, we tell the patient that now you did not be in inpatient. You can go on OPD basis and complete your rehabilitation. That reduces the cost. You must have also seen in the previous slides about modified ranking scale. So that this is very stroke specific. This is also a similar scale that we use. It is called as the Scandinavian stroke scale. It is very similar to the modified ranking scale. This is how we look, and then we prognosticate. So you can prognosticate severe stroke, very severe stroke, moderate stroke, mild stroke. So for inpatient rehabilitation, we do not take mild stroke. So only on this modified, Scandinavian stroke scale, if this is in the moderate category, so 24 and below, only then we take them for inpatient rehabilitation. Otherwise, all of the rest can be done on outpatient basis. So this is dysphagia management. So tracheostomy, basically it is to do with the tracheostomy. All our patients, as you can see, these patients do a lot of rehabilitation even with tracheostomy. So the other thing about rehabilitation is that everything should happen together. There is no point in half people, somebody doing something else, somebody doing something else. The patient has to improve as a whole. So we have to try and see that we manage this tracheostomy while we are trying to manage motor deficits, bladder deficit, a lot of other things. So the few things that we do is for all chronic tracheostomies, we test whether the person we can do something called as cuff deflation. So the tracheostomy's cuff is always inflated. This is a small dye that we give. It's a colored thing, and then we check whether the dye is going into the trachea or the patient is able to swallow. If the patient is able to swallow, then generally that the person can handle some amount of salivary secretion. So then we start deflating the cuff, and we keep a speaking valve and give some vocal exercises to this patient. That helps laryngeal movements. And then once we see a good amount of engagement and the swallow recovering, we just get an instrumented swallow test done. So there are two instrumented swallow tests available. One is the modified barium test, and one is a functional endoscopic evaluation of swallow. Generally, we use FEES. Our ENT people do it for us. It is just to document or rule out silent aspirations, because about 20% of patients can aspirate even with all of this being normal. So the FEES or the MBS will pick it up. If there is significant silent aspiration, we just downsize the tracheostomy, but we don't remove it till we can prove that the silent aspiration has gone away. So these are all the things that we have done step by step. So you can see that this is our patient who's walking step by step, step by step, step by step. So we are getting the ankle, we are getting movements even in the distal. Now you can see both the knee and the hip have recovered, and patient is getting this is the electrical stimulation that I was talking about. He's learning how to redress. This is mirror therapy that I was talking about. His left hand is normal, right hand is paralyzed. He's imagining that the right hand is moving. Right? This is to get up from the bed. And this is how he was finally walking when he left. This patient came to us out of the window, so there was no thrombolysis possible. It was a basal ganglia stroke, and so with a complete dense hemiplegia, this patient came. At 4 weeks, he's going back home walking. So, yeah, if you know what you are doing, you can get this kind of result.
Thank you, sir.
So we have all this equipment here, Dr. Menon?
Yes. All this that I showed is all from Apollo, all from Navi.
Wonderful. See, management of hemiplegia is prevention. In between, which we talk most of, is non-productive. This is it. Ultimately, patients lands here and rehabilitation, and so you are taking advantage of what you know. Only 60% of the fibers cross over to the opposite side. 40% is still intact. You are using that. So that's wonderful.
Thank you.
And here, where is the role of Botox over here?
Very few people are left listening. So it always happens like that. The best part when it is nature puts its best part, everybody is asleep, you see. That's it. Yeah, next speaker.
Very well said, sir. Now we will go to our last session, the post-stroke spasticity. like it is a frequent challenge during the recovery, and many patients also develop post-stroke movement disorder. This condition can be a complex to recognize and even more difficult to manage in a real-world practice. To address this, to address this important issue, we are fortunate to have Dr. Anil Venkatachalam sir with us, who will provide us insight into the evaluation and management of spasticity and a post-stroke movement disorder. Dr. Anil Venkatachalam is a senior consultant, neurology in LTMMC Medical College, Mumbai, senior consultant in Apollo Hospital, Navi. आ रहा है क्या स्क्रीन पर आ रहा है किया है प्ले किया हुआ था वेलकम सर फॉर द टॉक PPT में ओके
So actually, so I'd like to thank all of you all for waiting it out. So I'd like two parts to this. The first part is movement disorders associated with stroke, and the second part is the role of botulinum toxin in stroke management. It's not moving. Not moving. Sorry for this, the technical issues. So stroke has traditionally been associated with weakness of one side of the body, but we know very well that stroke can also cause a variety of movement disorders. And these are mainly due to lesions that either arise in the cortex, the basal ganglia, the thalamus, the cerebellum, or the brainstem. So if you look at the major structures involved in stroke-related movement disorders, it's mainly the cortex and the connections around the basal ganglia complex which are responsible for the movement disorders. And again, you can get a wide variety of the movement disorders depending upon the structures involved, the nucleus involved, and also the pathways. So if you look at the, if you look at the network all the way from the cortex to the cerebellum, this regulates the movement. You can see that the major structures involved are the thalamus, the basal ganglia, as well as the cerebellum. And any lesion along this pathway can actually cause a movement disorder. So traditionally, when we classify movement disorders in stroke, they are subclassified into like two main types. Either a hypokinetic movement disorder, where the patient becomes very slow, or a hyperkinetic movement disorder, where the patient has got fast movements. So the subtypes of movement disorders which are associated with strokes, as I said, we have hyperkinetic movement disorders, which mainly includes chorea, dystonia, tremor, and like myoclonus. Then we have the hypokinetic movement disorders, which are very common. That is the vascular Parkinsonism, often under-recognized. We also have the post-stroke spasticity, and we have post-stroke ataxia. So when we first look at the hyperkinetic movement disorder, the most common one that we see is actually a chorea. It is often due to the lesions involving the basal ganglia. Then we have patients presenting with a dystonia. This is an abnormal posturing of the limb. It can be related to a lesion in the thalamus or the basal ganglia again. Then we have patients presenting with a tremor. So these are usually a rubral or a cerebellar tremor. And one of the features of this tremor is when you examine these patients would have a tremor at rest, tremor when they assume a posture, and tremor when they have action. So it's tremor in all the three positions, unlike what you see in Parkinson's disease or the hypokinetic movement disorders. And then a few of these patients can present with like myoclonus. So I don't know whether you would have seen, suddenly a patient would be walking, having a jerk, or they would be dropping things, dropping objects, they would be falling all of a sudden. These are like myoclonic jerks. So I'm not going to speak much on the theory regarding this. I'll only show you all videos, how to identify it and how to go about it, because we have actually a lot of stuff to cover in 15 minutes. So this is our first patient. So you can see this patient has got a hyperkinetic movement disorder, and it is more of a chorea and a hemibalismus which the patient is having. You can see this. It's actually a semi-purposive movement which the patient has. I'll again show it. So you can see that the patient is having this involuntary movement involving one side of the body, and it's continuous, it's present at all times, present both in the proximal plane and the distal plane. This is a patient presenting with, an ataxia. This is very disabling or like debilitating after a stroke. The patient leans onto one side, they cannot have a balance, they sway onto one side, often keep falling. Very difficult to rehabilitate these patients. And this is a patient presenting with spasticity and a dystonia. You can see the dystonia of the lower limb where there's a curling of the fingers. You can see the toe is going up, slight striatal toe. Again, there's a hand dystonia. And then the patient also has a spastic gait. You can see the circumduction of the gait when the patient is walking. See the spastic gait? Patient has got a circumduction of the gait. So these are the common movement disorders that you see whenever a patient presents with a stroke. The most common movement disorder that we see after a stroke is a hypokinetic movement disorder. This is also what we call as vascular Parkinsonism. This is mainly because of the subcortical white matter disease or the basal ganglia infarcts. These patients traditionally present with bradykinesia, rigidity and gait abnormalities. So this is also called as lower body Parkinsonism. So here you can see this patient presenting with a classical lower body Parkinsonism. There's not much of a tremor. You can see the hypomimic facies, and there's this gait initiation failure. They are shuffling, and then there's this gait ignition failure. They are struggling to walk. They often fall. They are frozen. This is also called as a magnetic gait, when you examine these patients. This is a consequence of stroke. Very commonly seen. So that's where I'm going to come to. So this is what we see on the MRI of these patients. These patients have white matter changes. They have small lacunar infarcts, also involving the basal ganglia region as well as the pontine region. You can see a lot of these patients presenting to us in our OPD with extensive white matter changes. Again, how do you differentiate them from the classical Parkinson's disease? So in Parkinson's disease, you would get the typical tremor, the rest tremor that is there. Again, asymmetry is very common in idiopathic Parkinson's disease, whereas in vascular Parkinson's, it's not asymmetric. It is more of a symmetric disease, more of like lower body involvement. Again, these patients have like postural instability, frequent falls. They have a very poor response to levodopa. Again, the clinical diagnosis is the key for these patients. And the supportive diagnosis is by their MRI or CT scan findings. Also important to rule out other mimics like normal pressure hydrocephalus, cervical myelopathy, drug-induced Parkinsonism. So we need to rule all that out. We need to do a strict vascular profile for these patients. Then often these patients are tried on like levodopa. Levodopa is not very effective, but you have to aggressively control the vascular risk factors. That is the BP, the sugars, the lipids. fall prevention, use of assistive devices, and home safety evaluation. Another problem that we often see is the post-stroke spasticity. This is because of the disruption of the corticospinal pathways. It leads to an exaggerated muscle tone, clonus, and reflexes. It's very common in the upper limb flexors and the lower limb extensors. This is basically because of the damage to the motor circuits, which includes the cortex, the basal ganglia, the thalamus, and the cerebellum. There is also an imbalance between the excitatory and the inhibitory pathways. And also the neuroplastic changes after a stroke also contribute to the movement abnormality. So how do you manage these patients with, who actually present with movement disorders? So most of the times we manage them with pharmacological therapy, that is with botulinum toxins, as well as the dopaminergic agents. Again, there's a huge role of like physical therapy and occupational therapy. In select patients, you can do DBS. So GPI, DBS may work in select patients. And spasticity management is the key because you have to do a lot of aggressive stretching, also medications and other injections to reduce the spasticity. Now this is the first part. We're still with the first part. What is the importance of like diagnosing movement disorders in patients with stroke? So this is very important because often they are misdiagnosed and they are mismanaged. And there's a lot of morbidity with these patients because, you start with a good rehabilitation. These patients may have a hemiplegia or a weakness, and then later on they end up having an associated problem like an ataxia, spasticity, or a movement disorder. And if you don't aggressively treat this, it leads to a lot of morbidity or plateauing of the physical therapy response. So it's very important to aggressively manage this. The second part of the talk is the role of botulinum toxin in spasticity. So we all know that spasticity is a velocity-dependent increase in the tonic stretch reflex with exaggerated tendon jerks. So it's actually a UMN syndrome. We also need to understand that spasticity is not bad. It's actually a protective thing. It helps you to stand, it helps you to maintain the motor tone, it helps with the mobility, etc. But because of increased spasticity, there are a lot of negative features which are there associated with it, mainly pain, slowness of movement, secondary stiffness, ulcers, and a reduced range of motion. So when we look at it, we have the various patterns of spasticity that we see in a patient who's got a stroke. In the upper limb, we can see that you could have flexion at the elbow, flexion at the wrist, flexion at the fingers. You can have, adduction at the shoulders again. You can have flexion of the fingers. You can have the thumb in hand phenomenon, which is there. You can have the curled finger or the curled fist phenomenon, which is there. Similarly, in the legs also, you have like the various patterns where you will have severe flexion at the hips, or you could have severe abduction, adduction problems. At the same time, there could be issues with the lower limb, like patients may have like severe spasticity of the toes. They may not be able to touch the toes to the ground. So it's important to identify the various patterns of spasticity. In general, if you want to examine these patients, I only tell three things. Observe from the proximal part of your body and then go like distally. So observe for the proximal aspect of your shoulders, then you go to the elbows, then you go to the wrist, and then go to the fingers. Same thing you do in your lower limbs. Observe for spasticity at the hips, spasticity around the knees, and then go lower down to the foot, the ankles, and the toes. So why do you get spasticity? We all know it's because of a disequilibrium between the excitatory and the inhibitory pathways. So basically you have the damage to the motor cortex, and also you have upregulation of the reticulospinal tract and the vestibulospinal tract, which leads to positive UMN signs, and it leads to a spasticity in these patients. So when we look at the role of spasticity and its impact on the functions, we can see that hypertonia emerges around from the first day to the 14th day, and then it reaches its peak by around the 3rd to the 6th week, and then by around the 3rd month you have the fixed deformity which sets in. So we have the first 3 months, as the previous speaker also was speaking about, this is the window where we have to intervene for these patients. Once you have a fixed deformity, you're just falling behind the curve. You may not be able to treat these patients appropriately. So there are lots of neurological disorders which are associated with spasticity, but the prominent among them is a stroke, and it leads to pain, limited mobility, and functional impairment. So if you look at the curve here, we can see that in a stroke, the initial aspect, you have the flaccidity of the limb, and then you have stage 2, then stage 3, where you have severe spasticity which sets in, and then you have stage 4, 5, 6, which only happen with rehabilitation and physiotherapy. So a lot of times our patients are actually stuck at stage 3, and it is at that point you need to intervene. If you don't intervene out there, you would not be able to proceed further. You would not be able to help in further sort of recovery of these patients. So when you have obvious stiffness and spasticity, it is at that point of time you need to intervene, and it's at that point of time, there's a role of like botulinum toxin, oral baclofen, etc., which help in the recovery of these patients. So what is the mechanism of botulinum toxin? It blocks the release of acetylcholine at the neuromuscular junction, reduces the muscle overactivity. Its effect begins around the 3rd to the 7th day, peaks around the 4th to the 6th week, and it lasts for around 3 months. So its indications are mainly for focal spasticity, post-stroke spasticity, cerebral palsy-related spasticity, traumatic brain injury and spinal cord injury, and also in multiple sclerosis. So the common muscle targets that we inject are the biceps, the brachialis, the brachioradialis, the pronator teres, the flexor carpi radialis, the wrist and finger flexors. And in the lower limb, we inject into the gastrocnemius, the soleus, the hamstrings, and the hip adductors. So we examine these patients, and then we use the anatomical landmarks to inject, So what we usually do is, examination is the key out here. We need to see what is the functionality of these patients. So one thing you need to realize is that if a patient is having severe pain, if a patient is having good, motor tone, patient is having a good muscle power, these patients are very good candidates for injection with botulinum toxin. For example, if a patient has a spastic hand but the power is very good, the chances that these patients would improve with botulinum toxin is very good. At the same time, if the patient is not having any good muscle power in the hand and patient is having severe spasticity, the chances that the patient would recover with botulinum toxin are not very good. Similarly, if the patient is having severe contracture in the upper limb or the lower limb, the chances that the patient would recover with botulinum toxin are not very good. So we need to realize this. So that's why you need to intervene early for these patients. We can either use the anatomical landmarks, EMG or ultrasound. Ultrasound is actually coming up in a big way. EMG can also be used. I prefer using EMG in my practice. Again, we see the muscle size, we see the severity of the spasticity, and then we inject these patients. And we usually avoid intravascular injection. It's an intramuscular injection into various sites. Various brands are available like Botox, Dysport, and Xeomin. Usually anywhere between 200 to 400 units of botulinum toxin are injected at a time for these patients into various muscles, and we repeat it every 3 months, or we see according to the response, and then we repeat these doses. Again, we need to realize that this is level A evidence according to the American Academy of Neurology. So it is approved by the American Academy of Neurology. There's strong evidence that it works. It helps in reducing the muscle tone, improves the gait pattern, improves the limb position, and optimal results are always there only when it is combined with rehab therapy. So I tell this to all my patients, if you're not going to do physiotherapy and rehab, then it's of no use to inject these patients with botulinum toxin. Again, we need to realize we've been speaking a lot about acute therapies like thrombectomies and thrombolysis, etc., which help in recovering the patient immediately from a stroke. But we need to realize one thing, and I actually tell this a lot to my patients, that if they have spent X amount, they need to be prepared to spend another X amount at home in order to help in the complete recovery of these patients. The second X is actually the important factor because that is where your speech, your swallowing, the spasticity, the physiotherapy, and overall the limb function, the morbidity improves. Under trained hands, the side effects are very less. You can have a little bit of local weakness, some injection site pain. Very rarely you may have a systemic spread which causes a dysphagia or breathing issues, especially if it's given for cervical dystonia around the neck, but not for like spasticity after a stroke. And we usually avoid it in patients who have NMJ disorders like myasthenia gravis. Again, there are not many contraindications except for a known hypersensitivity or pregnancy and breastfeeding or infection at the injection site. Otherwise, it's a very safe injection. If somebody asks me what are the contraindication or like what is the side effect, I say the only side effect is expense. That is the only known side effect if you look at it, and that's actually a significant part. We need to realize that it's pretty expensive, it's pretty costly, but it's a very valuable tool in the treatment of post-stroke spasticity. So it's an effective tool for post-stroke spasticity. It works best when it's used along with a multidisciplinary rehab. It's very safe when like dosed and administered properly. With this, I would like to thank you all for giving me an opportunity to speak. If there are any questions, I would be glad to answer. Yes, sir. So the earliest papers which came out advised giving, so I'm telling you both ways. So the earliest papers which came out advised giving injections after the first 4 to 6 weeks of the onset of the stroke. But now it needs to be based on how soon spasticity actually develops. It can be given as early as up to like 2 weeks after the onset of the symptoms. One of the clues is if the patient has significant pain, especially pain around the shoulder, pain around the pelvic region, pain around the ankles, that means spasticity is actually developing. That's one thing which is, the first sign that actually pain is an indication, yes. And if the patient has hemorrhage, intracerebral hemorrhage, the chances of spasticity are far greater than, a thrombotic stroke. The site of injection is intramuscular into various muscles depending upon the overactivity. In the muscle. Sir, in the belly of the muscle, proper belly. Yes. Yes, we do look for co-contraction in all spastics also.
So so usually when you look at these stroke patients, you can end up having co-contraction also. So the spasticity has to be separated from co-contraction. So I just asking, co-contraction.
So he was speaking about co-contraction of the muscles. Yeah. So there are two ways you can find out. Number one is there are these fixed patterns of weakness that you have, which you can easily identify on clinical examination of these patients. Obviously, if the patient is having co-contraction of certain muscles, like for example the quadriceps, etc., which are overactive, you would avoid those muscles, because if you inject into that, the patient would actually develop a sort of weakness of those muscles and sort of like you would underdose on the opposite side, especially in the hamstrings, because the patient would have something like a buckling and would fall down, or the patient would have like weakness of the lower limb. So I usually the way I go about it is I actually do a thorough examination, both on inspection and then on proper palpation. Then we look at the pattern, whether it is fitting into the pattern. Then you examine the patient when the patient is at rest, and you try to make the patient walk and see which is the active muscle when the patient is walking. And then afterwards you make a injection pattern and inject into these patients. Yeah. So, but these doses are pretty large, so and that's. So these are standardized fixed doses which are there in the literature. But the size of the patient would matter. For example, if the patient's body weight is under 50 or the patient is a child, then the dosing is far less. If the patient is slightly heavier or muscular, then the dosing is more. No, Dr. Menon also injects. This is one thing. One.
Once the 24 hours are over, then we come into the picture. We start in ICU itself. The person is started on mobilization. When the person reaches the high dependency unit, the mobilization is picked up. By the time the person reaches the wards, the person is in full mobility. So what happens is, like he was saying, there are certain conditions like hemorrhagic strokes. You generally tend to see spasticity very early. In thrombotic strokes, you generally see spasticity much later, and you treat only that spasticity which is stopping this person. So I'll give you an example. I have a person whose problem is that he cannot, his hand is like this. So he cannot reach out and grab an object. So I'm going to inject the biceps there, and so that the triceps will work. Now the triceps is working, but the spastic biceps is stopping him from reaching. So I'm just stopping that biceps from overactivity, and that's it. So it is used to drive a particular function in rehabilitation. It is not used for any other purpose. It is used sometimes for spastic pain, or it is sometimes used to get into an orthotic. So like he was showing, sometimes you can get patients who have a plantar flexed ankle, and that ankle does not fit into an ankle foot orthosis. So then you need to inject. No, sir. That is again, if you see early rehabilitation with us, lots of our patients don't have it. So it varies. So problem kya hai ki it depends on the perspective where you are seeing these stroke patients. We see stroke patients across a spectrum. So we see a lot of stroke patients without any of these. No, nothing. It has nothing to do with how it starts. The point is what we are trying to do is, so spasticity comes in when you have damage to the corticospinal tract in such a way that it's not that movement you're not getting. If you get that movement, that spasticity will not be there. So suppose by the time the patient is 4 weeks old and the patient is walking with hip, knee, ankle, everything recovered, that patient is not going to get spasticity. No, sir. Again, spasticity depends on what you are defining. So there is something called as positive this. So some of the spasticity actually helps the person stand and walk. What is being described is spasticity which is hampering progress. Only that spasticity needs to be treated.
So
many times,
spasticity is good.
So many times we see people on baclofen for no rhyme or reason. So it is not really necessary.
Exactly.
Thank you. Yes, you can sit here also, sir. We'll hand over. I request Shekhar sir to come on to hand over moment. Dr. Shinde sir. Hi, sir. Please come. It's one-to-one communication. Dr. Ram, please come. हो गया ना? एक ले लेते आखिरी लास्ट गार्ड स्टैंडिंग. Ashwin, please come. Dr. Ashwin. Good for you.